हेलो। अली। हेलो। चेक अली। 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 हेलो अली।
हेलो। 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 हाँ, आवाज आ रहा है सर। हेलो।
এখানে পোডিয়ামের ছেলেগুলোকে ডাক। ইয়েস ছেলেগুলোকে ডাক। हेलो अली।
हाँ, आवाज नहीं आ रहा मेरा?
नहीं, तेरा आवाज नहीं आ रहा।
एक मिनट। हेलो। हेलो। एक मिनट। हेलो। हाँ, आवाज आ रहा है सर?
एक सेकंड। नहीं नहीं, यहाँ से
हेलो अली।
জুমের আওয়াজটা দিয়েছো? বল।
हेलो।
हाँ।
हाँ, अब आ
हेलो।
रहा है आवाज?
हाँ। हेलो।
हेलो। हाँ। हाँ, क्लियर है मुझे।
क्लियर है। हेलो।
हाँ, क्लियर है। हाँ।
नहीं
हेलो।
नहीं, एकदम क्लियर है।
हल्का सा वाइब्रेशन है।
हल्का सा वाइब्रेशन है।
हेलो।
बात।
हेलो। हाँ।
हेलो।
हाँ, मैं अपने सिस्टम बंद कर दूँ। हेलो।
क्या?
हाँ, क्लियर है। एक मिनट रुकिए, मैं सिस्टम बंद कर दूँ।
ভলিউম দে, শুনতে পাচ্ছি না তোর কথা। क्या?
हाँ, हेलो।
हाँ बोल।
हाँ, मुझे क्लियर है आपकी आवाज।
एकदम क्लियर है।
हाँ, एकदम क्लियर है। 100%।
डन है।
ठीक।
ওইদিকে দিয়ে ব্যাগটা দিয়েছিলাম, ওই ওই সিটের মধ্যে আমাদের। জল নিয়ে না। তো ওটা ছিল। জানতে পারলাম যে মিল্টন সিনেমা দেখতে পারবে। তাই কি ভাই? কিন্তু আমি তো দেখি। अच्छा नहीं हाँ साला না, না, না। এমনি ওরা ধরছে ধরার পরে মাথা খারাপ হয়ে যায়।
Get optimized business class performance.
Every journey flows to a single
Hello, check. Hello, check. 1 2. Hello, check. 1 2. Hello, check. 1 2 3 4 5 6. Hello, check. Check. 1 2.
हेलो विश्वजीत। हेलो मेडिका। हेलो জুমটা দিয়ে রেখেছো তো? হুম। হ্যালো বিশ্বজিৎ। হুম, ঠিক আছে। হ্যালো। অডিও টেস্ট করে এটা তো। তোর এই, হ্যাঁ তোর, তোর এতে আছে তো, তোর মিনারভাতে আছে তো? ঠিক আছে। অডিও টেস্ট এখন শুরু হয়নি। ঠিক আছে।
Sujit. Hello. ঠিক আছে ঠিক আছে আচ্ছা একটু অ্যাম্বিয়েন্স বলে দিচ্ছি এবার দেখ ওই এবার দেখ
ঠিক আছে তো? ঠিক আছে, একটু ভিডিও ক্যামেরাটা দে। আচ্ছা, হুম, ঠিক আছে, 1 মিনিট দাঁড়া। ঠিক আছে, সার্ভার থেকে আছে, পুরো ফুল এইচডি পাওয়া যাচ্ছে। একবার দাঁড়া, স্ক্রিনে আমি দিয়ে দেখছি। হ্যাঁ গুরু, একবার দাও না দেখি। Zoom। হুম, ঠিক আছে, ঠিক আছে, চেঞ্জ কর। হুম,
গুড মর্নিং। আজকে স্যার 4টে আছে। অপরা থেকে ধরে পড়ে গেছে।
হ্যাঁ শুনতে পাচ্ছি। এটা ল্যাব 1 না ল্যাব 2 এটা? ল্যাব 2 তে দিলীপ স্যার কোনটাতে করবেন? আচ্ছা দেখে নিস। হ্যাঁ বল বল, বলে যা। ল্যাব 2 তে হ্যান্ড মাইক তো? বল। ঠিক আছে, ঠিক আছে। হুম, দে। আচ্ছা, আচ্ছা, হুম, এটা হেডসেট তো? হ্যালো, হ্যাঁ ঠিক আছে, হ্যাঁ ঠিক আছে, ঠিক আছে, ঠিক আছে, ঠিক আছে। বিশ্বজিৎ, বিশ্বজিৎ, পেছনে ব্যাকগ্রাউন্ডটা না ব্ল্যাক রাখবি, গ্রিন রাখিস না। ব্যাকগ্রাউন্ডে, হ্যাঁ বলছি পেছনে ব্যাকগ্রাউন্ডে কোনো কালার দিস না, হ্যাঁ পুরো আহ, আহ, না ওটা ব্ল্যাক না, ওটা গ্রিন আছে। আচ্ছা, ঠিক আছে, ঠিক আছে, আচ্ছা, হ্যাঁ বল। ল্যাব 1 তো? আচ্ছা, বল। ঠিক আছে, বল হ্যান্ড মাইকে বল। হুম, ঠিক আছে, ঠিক আছে, ঠিক আছে, আমি মিউট করছি, হ্যাঁ। Okay.
Namaste, namaskar, namaskara, swagatam, suswagatam, and a very warm welcome to all the dignitaries, to all the excellencies present here. We are about to start off with the second day of a day where is full of knowledge, a day where we have acquired so much of in-depth things that cannot be paralleled with any other thing. So let's start off with the second day of Eiicon 2023, and we have case presenters for CD competition. It's a continuation from yesterday. We move on to all the case presenters here. But before we ask them to present their case, I would have the honor and privilege of calling upon the following dignitaries in the chairperson panel. So may I request the presence of Dr. P.K. Deb, the presence of Dr. Dipankar Ghosh Dostidar, presence of Dr. Achut Sharkar, presence of Dr. Soumitra Kumar to please come up on stage. May I request the presence of Dr. Ajay Gautam, Dr. Alok Chaudhary, Dr. Jayanto Sharma, Dr. Spandan Bhaduri, Dr. Rabindranath Chakraborty to please be in the chairperson panel, and also to moderate this particular case presenter for CD competition. May I have the following dignitaries as moderators? May I have the presence of Dr. Udash Chandra Das, Dr. Biplab Paul, Dr. Moinaka Mukherjee, Dr. Malay Acharya, Dr. Arnab Datta, Dr. Amrita Paul, Dr. Radha Bhattacharya, Dr. Sandeep Kumar Gocha. So I will request the following excellencies and dignitaries to please take their seats so that we can start off with the CD presentation. CD competition rather. So before we start off, we do have all the case presenter present right in front of us, but I would request the excellencies to please guide them on what basis the ranking will be and what will be the total ranking. I will request Dr. P.K. Hajra sir to please join the panel as well. I will request the excellencies to please guide our case presenters among what will be the guidelines, what will be the grading, so they have a clear idea.
Okay. Yeah, morning. And this is second round of CD presentation. Yesterday we had one round, and there are certain marks we have given to them. And there are basically three categories: content, presentations, and final remarks of the judges. So we have 1, 2, 3, 4 judges, and 15 marks, 5 marks in each group. So we'll have one winner today, and yesterday we had only one winner. But out of these two, one person will get the prize, a ticket to TCT, San Francisco, USA 2023, to and fro journey. And whoever gets the highest mark will be chosen as the winner. So let's begin, and I'm sure with time, some more people will join. So our first presenter is Dr. Chandra Kumar Das.
Thank you so much, sir. We start off with the case presenters for CD competition when we have Dr. Chandra Kumar Das.
Good morning, respected panelists and judges and colleague. This is a case of Takayasu arteritis involving coronary artery. There's a 13-year boy diagnosed case of Takayasu arteritis for last 2 months on multiple antihypertensive, oral steroid and mycophenolate mofetil, presently developed exertional chest pain for last 1 month, which is increasing in intensity and duration. On evaluation, a CT peripheral angiography revealed mild diffuse renal artery disease, and CT coronary angiogram revealed coronary artery disease, single vessel disease, proximal LAD showing 80 to 90% tubular stenosis. His ESR and CRP were within normal limit. This is the actual peripheral the aortogram which you took, showing the normal this carotid and subclavian arteries. There's a right renal artery. There's 2 renal arteries in the right side. On the left side, renal artery is this mild diffuse disease in the both the renal arteries. This is the coronary arteries. This LAD is showing proximal around 80% stenosis with calcium. So we did the coronary angiogram, which was showing around 80-90% disease in the proximal left anterior descending artery. So we decided to take the patient as the patient was having ongoing chest, this exertional chest pain, as like unstable angioplasty symptoms. So we decided to take the patient for angioplasty to the left coronary artery. So we gradually dilated first with we did the IVAS with this patient, and I think it's not moving, but there is a critical stenosis of proximal LAD with level of 3.4 millimeter square. Then we took the patient for angioplasty. First, we dilated, gradually we dilated. We dilated for 12 balloon, followed by 2.5 12 balloon. Then we took Wolverine cutting balloon of 2.75. Then we check the result, and then we decided to take whether we'll go for the stent, but drug-eluting stent and drug-eluting balloon. When we decided to take a drug-eluting balloon, we dilated the artery with 3x15 magic touch drug-eluting balloon. So this was the result. So did the IVAS run again? So now the area was satisfactory of around 8.5 millimeter square. Even though the artery was around 3.5 millimeter in diameter, but as the area we achieved was satisfactory, so we decided to not to go with stent. If you go to our evidences of incidence of cardiovascular manifestation of Takayasu arteritis, you see that this coronary artery involvement is also there for up to 5 to 20% of the patient. Mostly the lesions are stenotic. And there is classification where there is involvement of coronary arteries. Type 1 is osteostenosis of the coronary artery. It's most common type. Type 2 is diffuse involvement of the coronary arteries or any focal segment of the artery, skip lesion. Type 3 is aneurysm of the coronary artery. So if you go to the treatment, there's an American cohort showing that if there is a surgery with bypass, then there is high incidence of restenosis up to 36%. And if you go with the stenting, with drug-eluting stent, there is more restenosis of around 78%. So with drug-eluting balloon, we don't have direct evidence of drug-eluting balloon in coronary arteries, but we have the evidence of drug-eluting balloon angioplasty in renal arteries, which are more muscular in comparison to coronary arteries, showing that the drug-eluting balloon angioplasty is safe and effective for renal artery stenosis due to Takayasu arteritis. Thank you.
Yes, good presentation, man. You did not mention about the composition of the stenosis. I mean, what did you see actually in the IVAS? I mean, what was the composition like, and what was your rationale for using the cutting balloon? It, did not open up with the usual balloon, or what was the actual composition?
After dilating, we didn't IVAS, but after actually,
I think we saw a bit of calcium also.
Yes, sir. There was calcium in the first IVAS run, sir. There is calcium, but mainly, sir, fibrous.
So have you read up the literature with IVAS studies in coronary involvement in Takayasu? I mean, what are the usual lesions and how often they are calcific?
So mostly they are fibrous, but exactly the calcification is noted, sir. It's frequently observed, but the more often it is fibrous peritonitis.
What is your plan in case of restenosis?
Sir, if there is restenosis, then we can go again with ballooning, because even ballooning is better than stenting. You can go for repeated ballooning because it's 13 years boy only. There is high chance of again restenosis, but you can go again with ballooning. And I think the dilating balloon, as the renal arteries is showing good result, I think it will be better in comparison to only simple ballooning or rather than putting a stent.
All the literature about Takayasu arteries and ballooning is on the peripheral lesions. There is not much literature is on the
Yes, sir.
coronary.
Yes, I didn't get.
And this is a proximal LED lesion.
Yes, sir.
So do you think you have taken a big risk in not putting in a stent, just doing a drug balloon?
Yes,
Because there is no study in Takayasu which is recommending drug balloon in a proximal LED lesion only. All the drug balloon are there for the renal and peripheral, that I admit. But this is a proximal LED lesion, young boy. So do you think the stent would have been a better option?
Sir, as the chances of restenosis with stent is more, suppose for the next after 6 months or 1 year, the patient comes with chest pain, and if we have at least another chance of ballooning, but if we put stent inside the stent, that's another problem again. So I think it will be better if we give as BMU we do in the mitral valve. I think that chance
only this is a proximal LED lesion. That is why I'm just asking you this.
Yes, sir. Yes.
Okay.
Connect.
Thank you.
Thank you, sir.
We'll move on to the next speaker, and I will request Dr. Emma Rath to please come forward for the CD presentation.
A very good morning to all the seniors and the judges and my colleagues. Today, I'll be presenting a case which I did recently 2 days back, that is SVG intervention. Saphenous vein grafts are coronary bypass conduits and limited by longitudinal attrition. They begin to degenerate soon after they are exposed to systemic pressures. Failure rates are 50% at 10 years and 30% in the first month. The graft failure occurs due to 3 important things, that is early postoperative thrombosis within 1 month, and then it continues to have smooth muscle accumulation and then causes neointimal hyperplasia, and then the regular atherosclerosis sets in. So this is a natural history of any SVG graft. That is initial one year, it is always early remodeling and it causes a neointimal hyperplasia type of a lesion, and then it goes on to the severe lesions and lead to the total occlusion of the grafts. So my patient was a 70 years old male with post-CABG status 15 years back, is a diabetic, hypertensive and a smoker. He presented with history of effort angina 3 months back to me. And as we practice, we don't try to intervene in the first part. So I saw the ECG, it was an infralateral ischemic changes, and echo showed the regional wall motion. So I asked him to get a CT coronary angiography. So what it showed was native vessel was diseased, LAD with patent lima was there to D1, and LMCA was normal. There was 100% occlusion of LCX with patent SVG and OM1 graft. Native 100% occlusion of RCA and occlusion of SVG PDA graft. So this was something which I did after doing an angio. So there was nothing in the LCX, and this was LAD. It has a native disease which can be addressed later, but then the D1 had the severe disease and with the graft patent, and this was the RCA. And when I did the graft angiography, it's a here. Patent graft for SVG to OM1, very good quality. And then the Lima was patent, which was given to D1. And then what about the SVG to PDA? This was the picture I got. So as per the protocol, the other two grafts are there, protected left main. What to do next? A redo CABG with 70 years would cause a higher mortality risk. So I opted. So this was the graft I saw. I initially there's a hospital in which there is nothing equipped there. So I referred him to the surgeon. I told them, go ahead with the redo because it's risky here. So they opted for a PCI. So what I did was, this was a picture in different views. I thought if I could do something. So initially I engaged the SVG graft with the JR, then tried with the intermediate wire, which hardly went until the mid of the artery with a lot of difficulty. But then I didn't advance because as it is a old graft, it might perforate and things like that. So I didn't have an extension catheter. I used a 1.5 Teramo balloon as a guide support, as a support to the wire. So this was the balloon I used and advanced it further. So and inflated with the same balloon until the maximum stenosis there, and then went on with an escalation. Why did I use the second balloon? Was around 2 into 10, which I inflated around 13 in the initial inflations. So this was the picture I got something after the inflation. So as I didn't want to take much of thing because I didn't have a distal protection device nor a backup of the surgeon there available, I went for direct stenting there. So I took in anticipating that it might not go. So I took a smaller stent initially. So it was around 21, 2.5. I inflated at around 13 to 14 atmospheric pressure. Then I checked with repeated Nicoran flushes and to prevent the slow flow and this was the first stent inflation. When I saw the anastomosis was fine, then I proceeded with the further next stent in which I took as 42.75 I took this time, and then again I inflated it around 13 atmospheric pressure. So this was the result I got, but I missed the proximal part because anticipating for the negotiating the stent, the first stent was small, so I had to use the third stent, which was a small 16 into 3 and inflated 14 atmospheric pressure. With a continuous Nicoran infusion and GP2B, I could get the result something like this for the graft, which was protected with the in which the LM was protected, and then he was stable hemodynamically throughout the procedure. And as there is there was no imaging which I could get to show the exact character of the lesions there. So as per the treatment protocol, again, if there is an SVG lesions, they are candidates for CABG for all reasons, and then we have to classify them whether he needs additional revascularization. That is, if the Lima is damaged, then he goes for the redo CABG. If it is patent, then you think for an SVG lesion or a native angioplasty. So the native angioplasty, if there is a complete damage of the saphenous venous grafts, And if the native arteries are there and if the minimal damage of the minimal atherosclerotic lesions are the friable lesions of the SVG, then we go for SVG PCI, which is recommended by the as a guidelines. And these are some of the distal protection device we have to use if at all we get a proper way to do for the SVG graft. That is what we have worked is a filter wire and a spider FX. And in conclusion, I would like to say SVG intervention constitutes 6% of the total PCI. Reduce CABG has higher mortality rates and outcome compared to SVG and native PCIs. It should be accompanied with distal protection device and imaging modalities. Letting the failing SVG go is the dictum, and recanalizing the corresponding native coronary arteries with DES may be the preferred strategy for complex SVG lesions if technically feasible. Thank you very much.
Yeah, thank you, Hema, for a nice case. You think you are distinctly lucky to get away without a distal protection device?
I think I was lucky, sir. Actually, I don't know the lesion.
The state of the graft.
The state of the graft, I thought it would not open, or I might end up perforating the graft, or there would be a fresh on-table MI or something like that. I was anticipating many things, but then somehow without, just with the medicines of like Nicoran and nitrocontin, I just infused for every shot. And then I gave him a GP2B infusion, and that probably...
We didn't see the CT images of the native RCA. Did you ever think of opening up the native?
Native RCA was 100%.
Yeah, but the distal part was visible through bridging collaterals, I think.
It was bridging, and it was...
So did you ever think of trying?
I don't think so. The RCA was feasible to do a native coronary angioplasty.
Okay.
Hema?
Yes,
Okay.
what is the ejection fraction before there is 40%? So
Yeah,
after
it
the
was-
operation, how much ejection fraction increase or how much?
It was done 3 days back, sir. I should follow it up. The case was done just 3 days back. So I'll follow it up with the patient in the next visit, because restenosis and the rates are quite high with the SVG grafts.
Case very nicely done, and I think you are extremely lucky that there was no slow flow or which is very common because this is a type C type of lesion. And distal protection device is not a must, and you have nicely demonstrated that even without using it, the nice results can be achieved. But one thing I would comment that you are operating on the totally occluded right coronary artery. I think temporary pacemaker backup should have been used.
Yes, I should have used that as a backup. Probably I didn't notice.
Anyway,
Thank you. Thank you very much.
Thank you so much, ma'am. We can have open sessions. If anyone is interested to cross question or have a discussion on it, we can go forward with every case with our open session. So now we move on with the next case presenter, and I would request Dr. Rituparna Borua to please come forward for the case presentation of the next topic. And we are having the CD competition as of now.
First of all, thank you, judges and the organizing committee, giving me this privilege to speak regarding my case. So this is because of the paucity of the time, I prepared this slide at the last moment. So the case was, it was a 58 years old male, and he was diabetic for last 20 years on insulin and all other oral anti-diabetic drugs. This patient presented to me with severe raised claudications along with a non-critical, non-healing ulcer in the left great toe. And This patient is very thin built, and initially we thought about doing the procedure, but first I thought that we should first get a roadmap about this disease. And we did a CT angio initially, and it's showing diffuse BTK diseases, both the vessels, both the bilaterally involves, and both the anterior tibial, posterior tibial, and the peroneals are involved in these cases. And then we opted for below the knee interventions with long balloons, and there was a lot of calcification, like tram track calcification in the fluoroscopy. So initially I thought about to take a ultrasound guided puncture antegrade so that we get a long the catheter length, so it will be easier to get into all my balloon and stuff distally. But then I thought that because we don't have that ultrasound at that particular moment, so we use a crossover seat, that is the 7 French bulking seats, and we access through the right femoral artery and crossover. So this is the left leg angiography, and there is a diffuse disease. And I took a long cine and involvement of the both all these anterior tibial, posterior tibial, and the peroneal arteries diffusely involved. And I used this PTCA wire 0.014 inch, and then trying to dilate all the vessels. First, we tried the anterior tibial. I took a long armada balloon, that is 120 millimeter. That is was also, this is only that long balloon I saw in myself, and try to dilate the vessels one by one, starting from the anterior tibial, posterior tibial, and the peroneal. And in some point of time, it was very difficult to negotiate the long balloon. In that particular situation, I use a coronary balloon, NC balloon, and then short balloons, and try to negotiate, particularly the posterior tibial artery, because there is an acute band. And then we dilate it with very high pressure, 20-24 atmospheric pressure, so that to find out a pathway there, so that we can place my long balloon deep into the vessels. So you can see that wire, and this is a long balloon that was used, 120 millimeter armada, that is compatible with 0.014 PTCA wire. And finally, we achieved some good results with not exactly TIMI3 flow, but at least TIMI2 plus flow. And this is, and I find very difficulties to negotiate the balloon in the, particularly at the level of the ankle, because there is like tram track calcifications. And then in that particular situation, we use small balloon, coronary balloons, dilated, and they fractured the calcium, and then it was easier for us to negotiate the longer balloon. That is the ankle joint. This part particularly, it is very difficult to pass that long balloon. So we dilate it with a coronary balloon, 3 millimeter NC balloon. And finally, this was the last angiogram of the right leg, showing a good result, significantly better than the that was shown in the first image. So the diabetic patient, this incidences of peripheral arterial disease is significantly high to the tune of almost 50 to 60%, particularly those patients have a long-standing diabetes. And this patient, diffuse disease, calcified lesions, and it's very difficult to negotiate with longer balloon. And so short balloons, inflations using the coronary arteries, fracture the calcium, and then using the long balloon, helpful, particularly that was shown in my case. And also important is that this is a critical limb ischemia, and also patient having a non-healing ulcer for almost like 3 to 6 months. And there are a lot of dressings, and even this also the opinion of the plastic surgeon taken, but it was not healing. So it is a recent case. So we are going to follow up this case regarding the healing of the ulcer. And if the ulcer heals, that is the greatest satisfaction we'll find at the end of my case. Thank you so much for the attention.
This is a diabetic patient. It's not Barger. Barger
It's
is
not Barger. It's not.
okay. And very nice presentation and very well done, because you have saved the leg from amputation. Only I would ask you, what are the long-term results in this patient, and what medications would you recommend to this patient?
So invariably, there is almost 70 to 80% chance that the patient will come back with restenosis. So in that case, we'll definitely go for the balloon angioplasty of the BTK vessels. And here the main indication was to heal the ulcer. So and in improving the outflow and then healing the ulcer. That was and my medications in that particular case was he was on DAPT. We have given silostazole, and these are the medicine. And we are very aggressive on reducing the LDL cholesterols and controlling the sugar and all other risk factors he was having at the right moment. So we're trying to reduce the LDL.
Did you consider rivaroxaban?
Yes, in this patient, we have given rivaroxaban 2.5 mg twice daily dose, along with
Triple antiplatelet?
Dual
You said
antiplatelets.
DAPT and silostazole.
Silostazole was given, sir.
So 3 aspirin,
Yeah.
clopidogrel, silostazole,
Yes, also.
and rivaroxaban.
Yes,
Don't you think the
rivaroxaban was
risk
given
would be
in
too high?
peripheral arterial disease, 2.5 twice.
Rivaroxaban I appreciate, but what about the antiplatelet choice?
So my opinion is that because there is a diffuse disease involving both the legs, and this is a comparatively younger patient, only 58 years old, and the risk of bleeding is very low. It is, and we thought that we will continue the silostazole along with the DAPT for 3 months. Then we'll reduce and stop the silostazole, continue with DAPT and rivaroxaban.
Did you consider using drug-eluting balloons?
Yes, it could be maybe a good case for drug-eluting balloon, but at that time we don't have that balloon.
Full of pentoxifylline in this case.
Pentoxifylline, yes, it has the but the study is not showing there is improvement on pentoxifylline.
Thank you.
Thank you, sir.
Thank you so much. Now may I request the presence of Dr. Arohi Jain on stage for the next presentation. So we will require a few moments of time as we will be just shifting the technical laptop. So we require some time for the setup.
Good morning, respected teachers and dignitaries. I am Dr. Arohi Jain, second year cardiology trainee from RN Tagore. I am going to present my case on left main bifurcation lesion. So my patient was open pearl, 57-year-old male. from Agartala, who was a hypertensive diabetic with a history of tobacco chewing. Was admitted with the chief complaints of angina on exertion for 6 months. He had good LV systolic function on echocardiography. This was the ECG. As you can see here, there is T inversions in 1 and AVL and a typical Wellen sign present in V1, V2, and V3, which signifies a proximal LAD lesion. So he was posted for angiography. So, I'm sorry. Is it not playing? It's not playing. It's not playing. Just give me a sec.
You put the folder and show just the video.
Yes, sir.
No need to show the slide.
What a folder. Oh, it is playing now. So this was the coronary angiogram of the patient. As you can see here, when we engage the left, there is a distal left main critical stenosis with ostial LAD and LCX lesion of almost 90%. And so it was a critical distal left main bifurcation stenosis with a DBD. And this RCA was, there were minor plaques present. So we decided not to do anything for the RCA. We did a Medina classification, which was a 111, and hence we proceeded for dedicated left main bifurcation stenting. So we used, first we did the wiring of LCX, and then run through intermediate, and used a Shan blue for LAD. Then we did pre-dilatation of the LCX using a 3.15 millimeter NC balloon, and the same balloon was used for left main and for the LAD. I don't know why it is. So after pre-dilatation, the patient suddenly became hypertensive. There was a slow flow in the LAD, and then hence we decided to first send the LAD into LMCA as a bailout procedure. So this is how we did the left main to LAD stenting through a 4 millimeter and 4 into 48 millimeter of a stent. So this was the final result. Then we removed the LCX wire and did a pot by using 5 into 8 millimeter of balloon, and then rewired the LCX. So then left main to LAD stent struts were opened through a balloon. This was around 3 millimeter of 3 millimeter into 12, and this was the final result. And then the stent was taken. So and stent was applied deployed in the LCX ostium, and this was the final result. We also did a pot after this. So this was during post dilation. We opposed 2 balloons together and did a kissing balloon inflation. So this was T and protrusion technique, which we actually did as a bailout. We tried to do a pre-procedure IVUS, but the stent was so tight that the catheter could not go through the lesion. So hence we did the post-procedure IVUS run, and this was the diameters. Post LMCA, we found it was around 14.46. Then post LCX, it was 8.46 millimeter square, and post LAD, which was, so we know the stent was properly opposed and well expanded. So there was no edge dissection seen. So post-operatively, patient was stable. We tapered the vasopressors, and he was discharged in a few days. So in summary, I would say distal left main bifurcation, DK crush is the ideal choice and should always be preferred. But we should also keep in mind of bailout techniques when in need. We should always follow it up with imaging for good results to see if the stent opposition and expansion is adequate. Thank you.
So you had to put a stent from the left main to the LED but that was a bailout thing. So what was your primary strategy to begin with?
We wanted to do a decay crush.
So it was a decay crush. It was a
Yes.
Medina 3111 and it was a decay crush to begin with. Okay. And you did not do the IVUS. Another point is the IVUS before the
Pre-procedure,
pre-procedure.
the catheter we could not pass the catheter through the left main. That is why we couldn't get the image.
Right. Right.
Arohi, I missed the first slide. How old was your patient?
So 57-year-olds.
57. And what was the clinical presentation?
So chest pain on exertion for 6 months.
So, I mean, did you put this to the heart team before taking this up?
Yes, sir. We consulted the CTVS professionals and the patient did not want a CABG.
But you did not have a heart team approach. I mean, discussing, because as you said, I mean, doing a 111 LM bifurcation, and you were sure that IVUS won't cross, or maybe you won't be able to cross it with IVUS. So, I mean, judging the extent of the plaque in the left main and other things were difficult, no? Without a pre-procedural IVUS. So that is the whole point. I mean, did you explain the risk of the syntax?
The syntax was more than 22, around 36.
Okay.
Can I ask a question, please?
Yes, please.
I'm Professor Mustafa Jamal. A nice question, and but already there a lot of questions you have answered. Number one, syntax score already you have answered. My question is: have you changed the wire, and why the blood pressure has fallen? And can you understand? And you have changed the strategy, and you have I don't know, you have changed the wire. Understand? First you use Sion blue, and another one is intermediate wire.
So in the LCX, we put the intermediate wire and in shine blue in the LED. And sir, actually, there was, when we were doing pre-dilation, there was a LED dissection. So hence, we had to do because we wanted to do the procedure fast. So, and save the patient, we did the left main LED first and didn't think about the side branch.
But you told that before your primary strategy was decay crash, and then you have changed the.
So because
strategy.
the
You were
patient,
lucky that the angle was very good.
blood pressure time.
Oh, good. The pressure angle, the LED and the L6 angle, and port actually is very difficult because the port in the left main is very difficult to get the small size balloon everywhere. I know, that especially for 4x6 or like this, or so. We could not sometimes do the port, but port is mandatory in this scenario.
Yes.
So, but ultimately your result is good. But you should
As we did the left main stenting, left main to LED stenting, the patient relatively stabilized. So hence we continued the procedure for the LCX, or else we would have
yeah.
abandoned.
This is actually you told bailout, but you can take the primary strategy also like this, because you have very little armaments in your hand. Already you have no IVAS, everything. Thank you.
Dr. Jain, I have one more question. The first angio we saw, could you consider, instead of a decay crush, could you consider a provisional stenting, bifurcation stenting, so that you leave out the left, you leave out the LCX to begin with, and do a stenting of the LMCA to LED. If you could show the first angio picture, could that be done? Because here the LCX, the ostial LCX is, although it's an LCX, of course, and it's a big, do you think this could be a consideration? Because all the newer trials are saying that that instead of an upfront two stent strategy, single stent strategy could be done. So what is your views on that?
I think actually this two stent should be the best choice in this scenario, because already
My
LCX.
question is, why is so? Why would you? So it is true. Stent strategies.
For that, we need to do a pre-procedure IVUS to see what is the plaque burden, what is the length of segment of the circumflex involved, and how long is the disease and how severe is the disease. I think I'm very right. I would have done a provisional stenting with this approach because angiographically, the length of lesion looks to be less than 8 millimeter. If you do, I will definitely do it on IVUS and see if what is the significant, what is the plaque burden, everything, and then I can assess. I think still, I think a provisional strategy would have been a good, but for that we need to do an IVUS first to assess.
And always judge after wiring of the two LED and L6, then you can judge adequately with everything, disparity of the diameter and the LCX and LED angle, everything. And three angle is very important. One is LED to LCX, another is a let main to LED, another is a let main to LCX. Everything you should calculate every angle. And your end result is very good. And even when you KBI, kissing bell inflation, there should be simultaneous, but you're not simultaneous. One is first, then again another LED was little delay. So it is dangerous because this may cause the disparity of the stent size and shape also. So this is important. It should be simultaneous. The both hands should be, suppose 4, 6, 8, and at a simultaneous, just like a museum, actually, at a time. Thank you.
I think a pre-procedure IVUS should have been done.
Yes, sir.
If you're not able to pass, you should have pre-dilated with a bigger balloon and then would have tried to pass. I don't see much calcium. I think IVUS could have been.
So actually during predilation only I told
Yeah,
you the LED.
because it gives a lot of information
Yes.
about the angle, circumference angle, what are the size of the stent, how much length of the quad balloon required, and whether the probability of losing a side bunch is not. We have number of criteria in the IVUS in the pre-procedure which could have been utilized. Which have been done.
Thank you, sir.
Thank you. Thank you so much. Now we move forward with the last case presenter for the CD competition. And for this, may I request the presence of Dr. Anubrata Shane to please come up on stage and present his case. So this will be the last case presentation over here, and then we will be gradually moving on to the sessions that we have followed by live sessions. So there is so very much to explore today. So we are here, few sessions will be here, few session will be in the Victoria Hall. So it will be a combination and mixture of both. So now, Dr. Anubrata Shane.
Good morning to my teachers, my seniors and colleague. Myself, Dr. Anubrata Shane, a resident of Arctics, presenting a case of IVL in left main coronary artery disease. So my patient, a 64-year male chain smoker, presented with worsening exertional angina of class 3, despite maximally tolerated anti-anginal therapy. He was a known case of COPD, hypertensive but non-diabetic. The echo revealed there was generalized wall hypokinesia with ejection fraction of 50% with good RV functions. His hemoglobin was 15.9 with a creat of 1.32. We did the angio and it revealed left main triple vessel disease. There was tubular left main disease with calcification and also disease in the LCX as well as diffuse disease in RCA. So this gave us the first option of CABG and we promptly did look for a Lima. But when we took shoot, it revealed there was stenosis in the subclavian as well as the Lima was diseased. And more so, the bilateral renal artery were stenosed and the peripheral arteries were also diseased. So we have only left with the options of PCI, as he was a CABG turn down. So before starting, we had these queries in our mind, whether which vessel to do first, whether it is RCA or left main LED and LCX, what to do about the calcific left main, what are our choices of plaque modification, whether it is ROTA or IVL, and in intravascular imaging, which we would prefer, IVUS or OCT. And as we were doing unprotected left main, if need of mechanical circulatory support, which will be our choice, IABP, ECMO or Impella. So
we went with RCA first, as we wanted to establish the flow in the right system to support the left system and beginning of the intervention in the unprotected left main. The RCA was also a very much diseased, calcific, and it was tortuous. We required meticulous pre-dilation, bed preparation with sequential non-compliant balloon dilatation, and we also needed catheter extension of guidezilla, as it was a tortuous artery and as well as calcific. So first we went with two drug-eluting stents of 2.75 into 24 and 3 into 32 in the mid and prox RCA. For stent deployment and stent delivery, we also required guidezilla. And after stenting, we found out that there is a residual disease distal to the mid RCA stent, which was confirmed by IVUS, and it showed up fibrocalcific plaque. So we had to go for another stent distal to that of 2.75 with 18, and this was the final result of RCA, and which is confirmed by IVUS also, which shows a roundish RCA result with in both the diameters more than 3 luminal stent area. Then we proceeded for LAD, and we did a pre-procedural IVUS and OCT run, which revealed severe medial calcification. There was also some luminal calcification, and the arc was more than 270, which we can very well appreciate from the IVUS. And apart from that, in the middle one, there was a calcific nodule, which we can appreciate both from the IVUS as well as OCT. So here in a left main calcification, a large lumen with so much medial calcification, we choose IVL as the procedure because we had the rotor bars of 1.5, 1.75, which won't even touch the calcium. So we pre-dilated LAD to LMC with non-compliant balloon. Then we did IVL to left main and also LAD. And as there was occlusion for 10 seconds for 8 cycles, patient had episodic bradycardia as well as hypertension. And post IVL, we did a OCT run, which clearly showed cracks in the calcium, which can be appreciated here. This was one of the cracks here. Here also we can appreciate that, and this one in the nodule. But along with that, we have a problem as well. There was a aortosteal dissection here. Here there was a aortosteal dissection. And you can see this is the nodule, and there is a clear crack in the nodule. Then we post-dilated it, modified it with another NC balloon, and this was the final result. And we deployed a 3.5 38 stent and post-dilated it, and this was the final OCT result with good left main area of 10.6, sorry, and good minimal stent area. And the OCT clearly shows good apposition and stent expansion. So coming back to our questions, which one we address first? As I have mentioned, we addressed RCA first because we want to stabilize the patient, provide good hemodynamic support so that we can intervene the left main. And as I also said that we preferred IVL, and this algorithm also shows that we filled up the criteria for both for IVUS and OCT, that there was a more than 270 degree arc of calcium, a length of more than 5 millimeter. Here it was 12, and there was a definite calcium nodule visible. And this was also summarized here only, and we have filled all these 3 criteria. And is there any experience on that? There is a small study with 16 patients of left main calcium where they took IVL and they gained good luminal area in 100% of cases. And the outcome was good. And as far as the IVAS and OCT concerned, IVAS is always preferred in the left main because of the more lumen. OCT has a less depth perception. And also there was a ostium disease in the left main. For OCT, we need to disengage the catheter and also make sure that there is a good dye flush, which is difficult. For that, IVAS is always preferred. But as there was a calcium dominant, and we need to see the thickness of calcium, and also after IVL, we need to see whether there are cracks or not. OCT was also needed. We had the luxury of having IVAS in our lab, so we did both. And we had IBP ready in the lab with established line. Thankfully, we didn't require that. So this is what I need to say. There are multiple vascular territories, and it was involvement and surgical turndown case. We tried to achieve a complete revascularization. Meticulous planning and use of intravascular imaging was key to our success. The lumen is wider, difficult to rotablate, so it was an ideal case for IVL. And in order to maintain hemodynamics, we have taken breaks between giving the IVL burst, and we kept IBP ready in hand. Thank you.
Very challenging case, Ranobrata.
Thank you, sir.
But I'm equally worried about his other vascular territories. So how many months now into the follow-up? When have you done this?
1 month ago, sir.
1 month. So far, so good. What has happened to the kidney function?
Kidney function remains stable. It was initially 1.32. The kidney function is around about there only.
So IVAS OCT, you have yourself raised the question and answered it.
Yes, sir.
But you had the luxury of using both.
Yes, sir.
So you think you not using OCT would have given you an inferior result, or how has it helped you in the final?
Possibly not, but we wanted to see the calcium, the thickness, and the result of IVL we want to sure. And we were expecting this to be academic case only. As we had the option of having both, we go for it to document it.
What happened to your osteal dissection?
Sir, we have stented it. We have overhang. Yes, sir.
The last frame was showing the dissection.
You tell us about the left main stent you have used. What is its size?
Yes,
how
sir.
much it is protruding into the aorta?
Sir, here. We have overhang 3 to 4 studs outside.
Can you still see the dissection?
Yes, sir. Here. And also here. There is the dissection.
How did you decide the size of the IVL balloon?
Yes, we went for 1:1.
What was the size of the left?
3.5.
Left. What was the size of the left main? It
Pre.
used to be 4.5.
Yes.
You took a 3.5 for left main.
Yes, we went for 3.5.
This is not 1:1.
Yeah, the pre-run showed it was around about 4 in the left main. This is post, sir, and we inflated it to 4.
It appears to be more than 4. Still,
No, sir.
3.5 is not. It's not 1:1.
So this is the thing. There we can see this was the close to the left main. It was on horizontal. It was looks like 3, and in vertical it is 3.5. Yes, sir. So lower one is LED and upper one is left main, sir.
See the proximal LED. It's almost 4. 1, 2, 3, 4.
Yes, sir.
Proximal LED.
Yes,
Left
sir.
main must be more than 4.5.
But due to presence of calcium, we
Vessel. We are
Yeah.
discussing about the vessel size.
Yeah, yeah.
It's more than 4.5 approximately. And we are using a 3.5 balloon. So this is not 1:1.
Yes, sir. Agreed. Yes, I agree, sir. And in IVL balloon, I have the options of 2.5 to 4.
It's a long legend. It's a distal. We usually measure the based on the distal diameter, the balloon. But if there's calcium in the proximal segment also, then sometimes we use a 2 balloon, one matching the distal size and one matching the proximal center.
Sir, we only looked for having IVL in the left main mainly with some LED ostium. We didn't go into the left LED too much. We had the option of 2.5 to 4. We take 3.5. We inflated it into 4, gave the shock waves, then inflated to 6, so that after giving shock, we can produce the cracks.
What was the cause of dissection? IVL or?
IVL, sir, post IVL. Yes, sir. Thank you, sir.
Thank you so much. And I will thank the elite moderators and chairperson for moderating the CD competition. Thank you so much. Now we move on to the first session of the second day of Eiicon 2023. And for the first session, we have is pressing issues. For this particular session, may I request the presence of the following excellencies on stage. May I request the presence of Dr. P. Shahu to please come up and join on stage. May I request the presence of Dr. Pankaj Manuria to please come up on stage. May I request the presence of Dr. B.P. Pandey, sir, to please come up on stage. And I will extend my thankfulness to the elite dignitaries. Thank you so much. Thank you so much. And now we start off with the first session, pressing issues. I have just announced the chairperson name for this particular session. I will take the privilege of announcing it again. Dr. P. Shahu, Dr. Pankaj Manuria, and Dr. B.B. Pandey. So we will have them on stage right now. And to moderate this particular session, we will be having the presence of Dr. Kaushik Bandopadhyay, Dr. Shubhashish Chakraborty, and Dr. Arnup Banerjee. The first topic of this particular session will be by Dr. Shomo Patra, and his topic will be chip algorithm. So after the picture perfect frame of the day, we move forward with the first session of the day. So I will request all the dignitaries to please take your seats, and I will request Dr. Shomo Patra to please come up for the first topic of the day, that is the chip algorithm.
On speakers after this.
Shomo Patra, I cannot see.
Shomo Patra. Okay, so we move forward with the next topic. We will be having the presence of Dr. Sandeep Bansal to please come up on stage, and the topic he will be covering is viability algorithm. So the first topic of this particular session, pressing issues, covered by Dr. Sandeep Bansal, viability algorithm.
Dr. Pradeep Bhaumik is not. Pure viability. So the first speaker is Dr. Sandeep Bansal. This is a very pressing issue actually. Once we detect a 3-vessel disease, whether we'll do a PCI or we'll do a CABG, whether we'll do viability assessment, ischemia assessment or not, no better person than Sandeep to discuss this issue. And then we'll have a comparative session by another learned speaker, Dr. Soumitra Kumar. Sandeep, floor is yours.
Thank you, sir. This is a rather longish topic, so please allow me if I overshoot a little on time. We have ample time.
You have a luxury of extended time because
so much.
2 speakers are not there.
Yes. So the first important thing to understand in this particular area is the difference between a stunned myocardium and a hibernating myocardium. So this cartoon shows that whenever there is a decreased perfusion in a particular area, there is also a reduction in function, the top of it. But when the ischemia is relieved and the perfusion is restored, the function of the myocardium continues to be low, despite the perfusion having been restored. And this entity, when you have a restored perfusion, but you continue to have a myocardial dysfunction, this is known as myocardial stunning. On the other hand, if you have a reduced perfusion and you continue to have reduced perfusion, the, the function of the ventricle continues to be hypofunctional. And this, myocardial dysfunction, or you can say the hypocontractility of myocardium, in the presence of a continued hypoperfusion, is called as hibernation, and that is going to be the major topic of discussion in my talk. So what is a viable myocardium? A viable myocardium is generally referred to as an alive myocardium, independent of its contractile status. So it is alive, although it is hypofunctional. This term is actually derived from hibernation, as we all know, is derived from amphibians. Whenever the winters come, the amphibians go deep into the water and they reduce their functioning to the extent that they are alive, but they are not moving around. It is also important to remember that all ischemic hearts, whenever we do any reversibility testing, we do a treadmill, we do a dobutamine stress echo, or we do a stress thallium test or a stress MPI test, we are actually detecting ischemia. So it is important to remember that all ischemic hearts are viable, but the contrary is not true. All viable segments are not ischemic. They may not show ischemia. It is also important to remember that in order to judge whether the myocardium is alive or not, it has to have some degree of preservation of wall thickness. It has to have a contractile reserve, as we understand, to have cellular membrane integrity, and an active metabolism. The substrate changes, but the metabolism has to continue. And this metabolism needs that there is some amount of, perfusion by the blood. It can be an antegrade blood flow, and many a times we find that there is 100% block, but the artery is getting perfused through ipsilateral or contralateral collaterals. So the existence of blood flow is also very important. Now, all this is theoretical. The main thing is, the main importance of viability is whether the functioning of heart is going to improve once the flow is normalized or not, once the flow is normalized. So as I said, the tests for viability take into account all these features that are highlighted in this particular slide. That is, there has to be some minimum amount of wall thickness of the myocardium. The myocardium, when stimulated, should be able to contract more than it is doing at the baseline, or what we call as contractile reserve. It has to have cellular integrity. You cannot have destroyed cell wall or the integrity of the cell destroyed and have a viable myocardium. And it has to continue to have metabolism. The substrate, however, changes. We need to understand that the normal substrate for a normal heart is free fatty acids. And when there is a continued hypoperfusion or low flow to the area, the substrate changes to glucose, because this is a more energy efficient pathway in those given scenarios. And so the metabolism has to change from free fatty acids to glucose. And as I said, the perfusion is a must. It is not that you can have no perfusion at all and have a viable myocardium. So based on that, this also shows the 4 major ways in which myocardial viability is detected. It can be detected. There are some non-invasive and other markers also. But by and large, we either use echocardiography, we use positron emission tomography, or the PET studies, as we call them. We also have thallium studies and technetium-based, perfusion studies. And in the center, as you see, is the CMR, or the cardiac magnetic resonance imaging. This is in the center because currently it is believed that the best resolution up to the tune of about 1 to 2 millimeter is actually given by magnetic resonance imaging. So this is also believed to be one important method of diagnosing a viable myocardium. The concept of viable myocardium is not very new. It is about 20 to 20 years old approximately. And this is one of the seminal editorials by a person who did a lot of work in this, Shahabuddin Rahimtullah. He actually showed in one patient who had an LAD disease and the ventricle that was dilated, which is shown on the left of the screen. After the CABG was done, there was a great improvement in the ejection fraction from 37% to 76%. And this was largely contributed to by a reduction in the left ventricular end systolic volume. So if somebody asks me what is the single most parameter that changes, it is actually the left ventricular systolic parameters. Now, this is based on the fact that he also observed that if you have a normal heart and you develop occlusion, in the acute stage itself, when you revascularize, the functioning normalizes. If the blockage continues over a period of time, you have remodeling. And if you revascularize the heart early in the remodeling, it normalizes. If you revascularize at a relatively late time, there is a reversal of this remodeling, but it is to a lesser extent. And if you have it in an absolutely dilated ventricle, and I'll come to this concept later again, there is the benefit is actually questionable. So when do you use viability testing? Not in very young patients, not in people who have angina, not in people who have a normal left ventricular function, and not in people who have ischemia on, the routine testing like treadmill or dobutamine stress echo. But it is more useful in people with left ventricular dysfunction, in the people who are relatively older, who don't have any angina that is present, and on their angiography, you find a chronic total occlusion. And the purposes of the viability imaging are basically to plan the revascularization strategy, to risk stratify the patients, because those who don't have a viable area, they fare much worse. Their prognosis is much worse as compared to those in whom there are viable areas. And also to plan the revascularization strategies, as Dr. Pandey just alluded to. And there are some situations like a low flow state with aortic stenosis, for example. So these are the situations in which viability imaging is used. Now, the indicators of viability, well, if a person has angina, you really don't have to do, it should be a true angina. There, that is the strongest marker of the fact that even if the ventricle is dilated, even if the ejection fraction is low, and there is hypoperfusion, if the patient is having angina, that is the strongest predictor of the fact that the myocardium is viable. There are other markers, easier markers, such as lack of Q waves in the ECG. Many a times we get a patient who has a proximal LAD disease, but there are no Q waves on the ECG. Likewise, there are studies to show that persistent T inversion after a myocardial infarction is another marker of viability. Further, if many a times when we send our patients for a MPI scan, the nuclear cardiologist sends the patient back saying that though there is hypoperfusion, because there is a preserved wall thickening, the ventricle is very much viable. From our knowledge of echocardiography, we know that a myocardial infarction on echo or a scar is defined as, number one, failure to thicken or systolic thinning or failure to thicken by more than 10%. Also important is the presence of a contractile reserve. Many a times we find left ventricular angiography is seldom done these days, but in the good old times, when I did my DM, left ventricular angiography was a part and parcel of doing the cardiac catheterization, even if it was coronary angiography. So one noted that if a hypocontractile area increased in contraction after production of an extrasystole, the post-extrasystolic accentuation was enough to tell you that this patient has a contractile reserve. Although now in the modern times, we have more modern methods. So on the thallium scans, if we have radionuclide uptake, which increases by more than 50%, if we have seen any nuclear scan on the right side of it, there is a bar chart which shows areas which are absolutely dark to those which are bright orange. So that is the sliding scale on which the perfusion changes. And if there is a greater than 50% increase in the radionuclide uptake, that again is a marker of viability. Likewise, as we shall see, if there is a mismatch of perfusion and glucose uptake on PET scan, that is again a very strong marker of viability. And if you have on dobutamine stress echo, particularly, if you have a new inducible increase in the contraction, that is again a predictor of myocardial viability, because it tells you that this patient has contractile reserve. And if there is no or minimal late gadolinium enhancement on the cardiac magnetic resonance imaging, then again it is an indicator of viability. So this slide actually shows that what is the sensitivity, specificity, a positive predictive value of all the non-invasive tests of viability. And as we find, if you consider both sensitivity, specificity, positive predictive and negative predictive value, the gold standard is at the present time is FDG PET, although a tough competition is being given by the cardiac magnetic resonance imaging. So these are the various modalities on the left side. So you have nuclear imaging studies which actually use perfusion, cell membrane integrity, and presence of intact mitochondria on to judge whether the area is viable or not. And the PET scans actually use the change in metabolism as the indicator of viability. Echocardiography and dobutamine MRI, they use contractile reserve, and the plain MRI uses the presence of scar tissue as a predictor for viability. Now, as far as echocardiography is concerned, as I said, we have known that if the ventricular wall is excessively thinned out, the presence of a ventricular wall thickness of less than 6 millimeter is actually a very clear indicator that this is likely to be non-viable myocardium. And when we do dobutamine stress echo, these are the various types of responses that we can have. And so what we find is that if a patient has a biphasic response, which means that when you start the patient on low dose dobutamine stress echocardiography, the contractility improves, and later on at high dose or peak of the dobutamine stress echo, if the contraction decreases again, this is the strongest predictor of viability. And of course, you have different types of responses on dobutamine stress echo. Now, as far as the nuclear scintigraphy is concerned, as I said, the radionucleases, they need to get into the cell. And for that, you need the integrity of the cell wall. As far as the nuclear scans are concerned, most people do not use thallium scan any longer. The good old thallium used to behave as potassium. And we know that potassium is an intracellular ion. And so thallium would go into the cell, and that it can do only well when the cellular integrity is preserved and there is some degree of metabolism occurring. So based on the thallium scans, we could predict more reliably whether there is myocardial viability or not. And I said, if there is a 50% increase in the tracer activity or more than 50%, then this is the most important criteria to be used in SPECT imaging. So on the top are the agents which are used for SPECT imaging, which is mainly thallium or sestamine. And for PET scan, we have perfusion imaging, for which people use ammonia or rubidium. And we have the metabolic imaging, for which we use fluorinated deoxyglucose. Now, the thallium scans divide the segments of the myocardium in pretty much the same way as we do on echocardiography. And two types of things are important. What is the defect severity? As I said, it should be a more than 50% change. And what is the defect size? Because those two factors determine whether the function is going to improve or not. So this is a typical nuclear scan picture that we see. The first one is normal, which is showing orange color in the entire thickness of the myocardium, both at stress and at rest. Sometimes such defects may be present both at rest and at stress. And these are large areas, non-specified vascular territory. These are basically attenuation artifacts. The attenuation artifacts are more importantly present in the diaphragmatic surface and the inferior wall of the myocardium. If the defect is fixed, that means at stress also there is no perfusion, and at rest also there is no reperfusion in that area. This is suggestive of a scar. And the most important for us is on the extreme right. If we see towards the apex, there is a blue area on stress, which fills up with the orange perfusion at rest. And this shows that there is ischemia, and this is going to be a viable myocardium. As far as the PET scans are concerned, as I said, this consists of two imagings. One is the perfusion, which means the blood is going there or not. And the other is metabolism imaging. And as I said, in cases of chronic hypernation, the substrate changes from free fatty acid to glucose. And so this is a typical PET scan at the bottom. And it has been seen that almost 1 in 4 segments, which are actually classified as non-viable on a stress thallium scan or a stress MPI scan, are actually determined to be viable on a PET scan. This is a slide which I've taken from one of my presentations for the CSI. I was asked to show a case where nuclear imaging had been done. And this was a 45 years old male who had an anterior wall MI. And this guy drove his car for 13 hours from the border of Chhattisgarh to all the way to Vijayawada in Andhra Pradesh. And his angiography was done. The angiographer found that LAD was 100% blocked. And however, he was one of those kind ones. He did not blindly go ahead and open it up at that time. He said that you should come later when we will do some tests. The patient landed up in Delhi. He was related to one of my colleagues. And so when he came to us, I got a FDG PET scan done. And as you see in the first picture on the left-hand side of the screen, there is a large blue area, which is the perfusion scan. So that is the technetium perfusion scan. The large blue area suggests that there is no or very little blood going in that area. And the middle one is the FDG or the perfusion scan, which shows that there is a good amount of uptake of glucose by the same blue area, which is showing on the perfusion scan, which means that the substrate of this particular area has changed from free fatty acid to glucose. And that is why this area is viable. And when you subtract the two images, on the extreme right, you see an orange area, which is the area of viability. And so I went ahead, I did the coronary angioplasty of this patient. And after 4 to 5 months, his ejection fraction had improved from 30% to 47%. And his left ventricular remodeling also occurred. There was almost a 5 millimeters decrease in the left ventricular systolic diameter. So if we try to know the pros and cons of all these tests, they are highlighted here. The SPECT is supposed to be more sensitive than dobutamine stress echo. We are all aware of limitations of dobutamine stress echo. You may have window problem and you may have a host of other problems. However, it is a all or none phenomenon. It doesn't have a great grading between the different types of viabilities. Dobutamine stress echo can use both the thickness, because we do a resting echo. So it can use both the predictors of thickness as well as contractile reserve. Cardiac magnetic resonance imaging uses the wall thickness as the most important criteria. And the PET scan, as I said, uses the viability. As far as the magnetic resonance imaging is concerned, again, the cutoff here, because it is a more sensitive parameter, is not 6 millimeters, it is 5.5 millimeters. And again, this is being used in many areas, as we see here. So you can have scar present in typically in 1 to 25% of the cases. On the second part of the cartoon, it can be 25 to 50%, or it can be more than 50 to 75%, or more than 75%. So if it is more than 75%, the scarred area, then it is clearly sure that this is going to be a non-viable area. If it is less than 50%, we are pretty much sure that this is going to be viable. And if it is between 50 to 75%, we do contractile reserve testing, and then we are able to predict the viability. Now, the most often discussed trial for kicking viability, I would say, is the STITCH trial. Now, in the STITCH trial also, in the STITCH trial, what they had done is taken patients with left ventricular dysfunction, subjected them to medical therapy or coronary artery bypass grafting. In a percentage of people, about 40% of them, they actually did viability studies. And what they found was that whether you had a viable myocardium or not, there was no great difference in the results of doing CABG versus giving medical therapy. However, if you considered the viable segments and non-viable segments, there is a increase in the ejection fraction in those patients who have viable areas. However, again, as I said, the main point in the STITCH trial was that whether you did viability testing or not, this results of the CABG were not going to determine the ultimate outcome. However, there were many criticisms of this because the STITCH trial did not use MRI or PET. They used, SPECT or dobutamine stress imaging, which we all know are not the gold standards. Almost 40% of these patients were asymptomatic. The patients were never assessed for presence of ischemia, so it is quite possible that many patients had ischemia, and the LV volumes were not reported. However, this study did show, as I said, that if you have a viable area, your ejection fraction improves over a period of time. And there are subsequent studies which have shown that if you have a contractile reserve present, then that predicts the viability even better. This is a slightly older paper of 3,100 patients, which clearly showed that revascularizing, if we look on the top graph, if you revascularized the viable areas, then there was almost 80% decrease in the death rates. And it did not matter. It was statistically insignificant if you had medical treatment in these patients, which is given at the bottom. Now, further, it has been seen that if you consider viable segments, then the predicted death rates actually improve a lot. And on the right side are given the scatter bars, which shows that between the different modalities, what is the scatter, what are the 95% confidence intervals. So what we find is that for thallium and TSC, there is a very wide scatter. We can see the vertical bars are very big. But for FDG, the vertical bar is very small, which means that the results are more consistent and more accurate. So that continues to be the method of choice. There is also another paper which has looked whether the area of hibernating myocardium is important or not. And there was a PAR 2 trial of which this sub-analysis has been published. It has been seen that, if the viable area is more than 7%, then the primary outcome, which is a composite of cardiovascular death, MI, or heart failure, is less, and the number of patients surviving is also more. But there are 0 deaths in this. So I'll just be a very few minutes. So the 2021 AHA-ACC guidelines for coronary artery revascularization states it remains unclear whether viability studies should be used to inform clinical practice. And if they are used, it remains unclear which should be used. There is a paper published in Journal of Thoracic and Cardiovascular Surgery, which tells you that it is not just the amount of dysfunctional but viable myocardium, but also the left ventricular volume, which is important. So I've tried to draw this in this chart. The first one shows a normal sized heart. The heart then dilates and we have a mild to moderately dilated heart. Here, the viability is important. But if you have an extremely dilated heart, as it is given in the bottom, then the neurohumeral systems have already overtaken the benefit of viability. Whether you revascularize them or you don't revascularize them, you're not going to get benefit. So volume is also very important. Now, the topic was actually the algorithms. So this is the most simple algorithm. If you have coronary artery disease and the patient has angina, he doesn't fall into this viability testing. If he has dominantly dyspnea, you check for left ventricular function. If the left ventricular function is normal, even this person does not need any viability testing. If it is low ejection fraction, then you do the viability testing by using myocardial perfusion scans or PET or dobutamine stress echo or MRI. And at the bottom, it is given clearly that if your patient has hibernating myocardium or ischemic myocardium, that is the patient who's likely to benefit from revascularization. This is a more simplified, but in terms of acute MI, if you have a negative ischemia test, suppose you have not been able to revascularize the patient in the 36 or 48 hours window, which is a class 2A recommendation of the ESC, then you do that, and the ischemia test is negative, go ahead and do the tests of viability. And if the myocardium is viable, then you consider revascularization, as I showed you in my case. So these are the last two slides. So the algorithm, which is given by the AHA scientific statement in 2020 on the imaging for myocardial viability. If your patient is suitable for revascularization, he goes to the second step. Then you assess whether there is presence of ischemia or not. If there is no ischemia, look at the extent of scar. If the scar is more than 50%, but less than 75%, you look at the contractile reserve. If the contractile reserve is present, then you revascularize the patient. If the contractile reserve is not present, then you leave the patient alone. And this is in subacute left ventricular dysfunction. If the patient is not suitable for revascularization, anyway, he's out. If he is suitable for revascularization, does he have any regional dysfunction? If he has regional dysfunction, test for ischemia. And if that is not present, test for metabolism or contractile reserve. And these are the patients who will benefit from revascularization. I thank you for your kind attention. A rather long talk, but I thought there was no other way to get about it.
So thank you, Sandeep. I think we'll take the questions after the presentation of Dr. Soumitra Kumar. So please be seated here. So our next presentation is by Dr. Soumitra Kumar. He'll tell us about the perspective with respect to the Revive BCS trial and Stitch trial, which Sandeep has already touched.
Good morning, everybody. Thank you, chairpersons. Much of my job has been done by Professor Sandeep Bansal already. So I'll try and give you some crisp take-home message as how to go about, because most of the introductions about viability and the associated trials have been spoken about by Dr. Bansal. So in the field of chronic coronary syndrome, these are some of the landmark trials that have happened in the new millennium. So in the first half, we had Courage, Bari, 2D, Stitch. That is the subject of one of the subject of my talk. Then to follow it up, we had more defining trials like ischemia, FAME2, Orbita, and then we had various follow-up studies of Stitch, the long-term follow-ups, the Stitch viability studies, and so on, which were published later. And very recently, in 2022, we have had the revived BCI S2 trial and the FAME2 trial. And based on this, we have had some of the guidelines, the ESC, ESCTS guidelines on myocardial revascularization, ESC guidelines on chronic coronary syndrome, and ACC/AHA SKY guidelines, again on myocardial revascularization. So why are we talking about addressing this kind of contentious issue like viable myocardium and subjecting the patient to PCI? This is because of the tremendous advancement in the field of PCI that has taken place, starting from the study of coronary physiology, the FFR and its various other recent advancements, the IFR and so on. Then non-invasive imaging of the coronary arteries, Then, of course, the intravascular imaging, IVUS, OCT, and so on. So all these have contributed to tremendous improvement in PCI outcomes. So we have become more adventurous and now thinking of addressing very ischemic LV dysfunction. So this is the study that I'm going to present in little bit details and then talk about its perspective in view of the other trials, the REVIVE trial, presented in the last ESC 2022. What was the background? Whether revascularization by PCI can improve event-free survival and left ventricular function in patients with severe ischemic left ventricular systolic dysfunction as compared with optimal medical therapy, that is individually adjusted pharmacologic and device therapy for heart failure alone is unknown. So this was the design. LVF was less than 35%. Viability was studied by all the modalities that Dr. Bansal has mentioned on CMR, DSE, SPECT, or PET. So it was a very state-of-the-art assessment of the viable myocardium. PCI feasible to lesions subtending more than equal to 4 dysfunctional but viable segments was carried out, and then the patients were randomized either to the state-of-the-art PCI or to optimal medical therapy. Optimal medical therapy was also state-of-the-art, as I'm going to show you. Echocardiography at 6 months and 12 months, and the clinical biochemical follow-ups were done at 6 months, 12 months, and 24 months. So it was not a very long follow-up. It was mostly 2 years or about so. But then there was no difference. We had 129 events in the PCI group, 37% of patients, and OMT 134 events, 38% of patients. So there was absolutely no difference in outcomes in the two arms, PCI versus OMT. And if you consider the subgroups, there are some interesting trends, but none were very definitive. You see younger patients tended to fare better with PCI. The BCI jeopardy score, the more the score, the results were somewhat better with PCI. The worse the EF, again, little better with PCI, but not significant. Diabetes did not matter. Functional class, we did not have too many patients in NYHA 3-4, which was a fact, but then there was no difference. AF did not matter. Left main, very importantly, if you had left main, then doing PCI in such patients did have a poor result. So that is a point to be noted. And again, NT-proBNP values did not matter. So overall conclusion, among patients with severe ischemic LV systolic dysfunction who received OMT revascularization by PCI did not result in a lower incidence of death from any cause or hospitalization for heart failure. So these are some of these trials have been mentioned by Dr. Bansal already, the HEART Part 2 and STITCH, and then the latest REVIVE BCI S2. So, I mean, the primary outcomes were variable. So STITCH, REVIVED, and HEART considered all-cause mortality, the hardest of endpoints. Part 2 had more of a composite outcome of CV death, MI, hospital admission due to cardiac cause. But REVIVE also considered hospitalization for heart failure because these patients had severe LV systolic dysfunction. There were several secondary outcomes, more so in the recent REVIVE change in NT-proBNP and unplanned revascularization were some of them. So, and then the quality of life scores, very important. That was also considered in REVIVE BCIS2. Inclusion criteria, all trials included very dysfunctional patients, LVEF in all were less than 35%. Heart insisted on more than equal to 5 viable segments. Then part 2 had more a varied kind of inclusion criteria. STITCH did not depend on viability at all. So, I mean, whenever the coronary anatomy was suitable for revascularization, it was done. And REVIVE BCIS2, I mean, had a more stringent criteria, as I mentioned, that they needed to have 4 dysfunctional myocardial segments amenable to revascularization with PCI. And then people with acute coronary syndromes and other diseases needing surgery like aortic disease, cardiogenic shock, blah, 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 were excluded. I'm not going into that. So LVEF on an average was less than 30%. So very sick patients. As I said, of all these studies, the revived BCIS2 had all the modalities that were studied. So it was a comprehensive viability study technique that was taken up in revived BCIS2. So all these studies were more or less 5 years, but except revived BCIS2, where it was even less than 2 years, you can see 41 months was the mean follow-up. So very short-term follow-up, and that is one of the drawbacks or limitations of the revived BCIS trial. Now, when it comes to outcome, one thing is common: no significant benefit of revascularization of our OMT in the short-term period of 5 years. So STITCH only showed benefit when the 10-year follow-up results were considered. It showed a lower all-cause mortality than OMT. Revived BCIS2, again, overall same conclusions. But you see, as I'm going to show, somewhat better quality of life that is to be considered. But then whatever was there, quality of life improvement, tended to disappear beyond 24 months of follow-up. So these are the trials side by side. And this again beautifully shows the impact of impact of viability guided management on all cause and cardiac mortality in RCTs of patients with ischemic cardiomyopathy. You see more or less neutral. It does not provide any benefit except for a subgroup of part 2, which showed that study of viability does matter. But part 2 overall was a very small trial. You can have a look at the number of patients that were included in this subgroup, very small subgroup. So this is a kind of a master slide. You see we have 3 variables: viability, prognosis, and functional recovery, that is improvement in LV function. So you see the dotted lines means conflicting data. The solid lines means well supported, and the red solid line means RCT demonstrates no association. So overall STITCH viability showed somewhat improvement in prognosis, but whenever revascularization was done, it was very, very doubtful. But overall, in the 10-year period, when CABG did show a reduction in all-cause mortality. And then overall viability and functional recovery, no. It does not. So functional recovery does not occur, but patients somehow at the end of 10 years with CABG in STITCH trial live longer. Christmas trial, but was a medical therapy trial with carvedilol. It did show that if there was viable segment, if you treat patients with carvedilol, patients can have an improvement in ejection fraction. In fact, beta blockers were the first group of drugs which showed an improvement in ejection fraction. And then functional improvement, better the ejection fraction, the better the prognosis, is something that we all know. And then coming to the STITCH viability sub-study 10-year outcome data. So it mostly banked on SPECT. And you see medical therapy alone and medical therapy plus CABG. When these groups are concerned, overall, in terms of demonstration of viability, no significant difference in the hazard ratio, but with viable myocardium, you can see that patients tended to do better with medical therapy plus CABG compared to medical therapy alone. So if you do revascularization with viable myocardium at the end of 10 years, you do benefit from CABG. So that was the outcome of the subgroup study, that is STITCH viability sub-study. So a side-by-side comments, you see patients with STITCH were treated at the state-of-the-art OMT at that point of time. So ACE inhibitors, beta blockers, and digitalis. Now, in revived BCIs, patients were treated with ARNI. You see 29%, almost 30% receives ARNI. MRAs, which were not used in STITCH, were used, and beta blockers were, of course, used along with ACE inhibitors. So patients in revived received better treatment. Of course, SGLT2 were not used still in revived trial. Now, another drawback of revived when compared to stitch, I mean limitation, is that less symptomatic patients were included in revived, and whereas in stitch trial, almost 43% of patients in stitch had CCS class 2 angina. Such patients were not included in PCI BCS2. So this is the point to be noted. So unless you include patients with symptoms, how can you look for benefit? So that is one of the drawbacks of revived BCIS2. On the other hand, revived included older patients with a mean age of 70 and 69 years in PCI and OMT groups, whereas in stitch, there were younger patients, less than 60 years. So these are the points to be noted when we say that CABG is better and PCI is not. So although overall results lead to a conclusion of no added value of PCI over OMT in patients with coronary artery disease and reduced LVEF, there are at least 3 issues that may be taken into account when interpreting the revived trial. First of all, well, we have only studied till 41 months. So we really do not know what is going to happen at 5 years and 10 years. But already we know there were lesser incidents of VTVF terminated by ICD in the patients who had ICD. So of course we can, hope that these patients should tend to live longer with PCI when done properly. Then mirroring what we could see in the ischemia and FAME2 trial, the rate of spontaneous MI seems to be decreasing over time in patients who underwent PCI as opposed to OMT alone. So in addition, as expected, the rate of unplanned revascularization was reduced in the PCI arm. And third, as pointed out in an article in NEGM, a degree of selection bias could not be entirely ruled out, as some patients potentially profiting from revascularization may have been diverted towards surgery before being considered for trial enrollment. So these were another drawback. So in addition, 2/3 of patients had no angina on baseline, and the decision to revascularize was preconceived by the existence of myocardial viability, which in the stitch trial did not have an impact on the effect of surgical revascularization and mortality. So these are the modalities, the types of kind of ischemic LV that we know. So stunning, early hibernation, advanced hibernation, and infarction. And you know how it matters in terms of contractile reserve, glucose metabolism, extracellular volume, and so on. And these are the various methods again highlighted by Dr. Bansal. So SPECT targeting membrane integrity, CMR extracellular volume, DAC on contractile reserve, and PET on glucose metabolism. So the conclusion, which also Dr. Bansal has highlighted, viable myocardium should not be considered as a single entity, but as a spectrum, including jeopardized, stunned, early hibernation, and advanced hibernation, the revascularization of which may yield different pathophysiological benefits. For patients with ischemic LV dysfunction, the question is not whether they have viable myocardium, but how much they have of each type, where it is, whether it is likely to recover, and how long this may take. So these are the crucial questions to be asked. So this is a master algorithm that I would like to present to the audience. So managing patients with ischemic cardiomyopathy, anginal patients, if no, look for significant myocardial hibernating myocardium, at least more than 7% studied by PET or CMR. If yes, go straight for CABG on top of OMT to improve prognosis. If not, go for a heart team evaluation, consider CABG. If low surgical risk, Euroscore 2 less than 4%. Consider PCI in selected cases according to syntax score. If anginal symptoms are there and there is significant inducible ischemia more than 15% of the LV, yes, again straight away go for CABG on top of OMT. If no, again heart team evaluation, CABG for low surgical risk, Euroscore 2 less than 4%, PCI in case of refractory symptoms if CABG is not indicated or refused. So the concluding remarks, until newer and more relevant evidence emerges, surgical revascularization, when technically feasible, after carefully weighing of the perioperative risk, would appear to be the best option for selected patients with ischemic cardiomyopathy. Such an approach also has been reported to be cost-effective over OMT. Viability or ischemia testing appears not to be mandatory based on current evidence. Documentation of viability today possible at its best with CMRI or PET would, please note, would still appear, however, a logical step, no matter if not based on strict evidence, but with the aim of tilting the balance in favor of surgery in cases where perioperative risk makes decision particularly difficult. And then conversely, the practical impact of ischemia testing on clinical decision-making, particularly in the absence of ischemic symptoms, would appear less robust, although in recent retrospective evidence in patients not selected for LV ejection fraction suggests a possible benefit of ischemia-guided revascularization in the presence of a very severe ischemic burden, that is more than 15% of LV myocardial, as I showed, based on SPECT. Such data, of course, need further confirmation in dedicated RCTs. So considering the recent results of revived BCIS2 trial, indications to PCI in patients with ischemic cardiomyopathy would remain limited to patients in whom ischemia-related symptoms such as angina are refractory to AMT and predominant over heart failure-related symptoms. Thank you very much for your patient hearing.
Yeah, thank you, Dr. Habaj. Sandeep, just I wanted to know what is the difference between viability and ischemia? How do you interpret the report?
So ischemia typically means that we all know of ischemic cascade. The ischemic cascade starts from a problem in the perfusion. Then there is a problem in the diastolic function of the heart. Then there is a problem in systolic function in the form of regional wall motion abnormalities. And then there is ECG changes. So we can detect the ischemia at any stage. We can detect it with, as I said, with SPECT or with dobutamine stress echo or with treadmill testing. There will now, what is the difference between viable? Viable basically means that if you do a treadmill test in these patients, this may still be negative because these patients may not show any ischemia. On the other hand, they will show, this particular thing actually arises only in a chronic hibernating myocardium. You may not have ischemia, but there will be a lot of patients who may still have a living myocardium, which will improve with revascularization. Ischemia essentially means that there is a difference between stress and rest. That's it. Whereas viability means that there may be no improvement on stress, but the heart may still have area which, if reperfused, will improve in function.
And second question, Dr. Kumar, we see a lot of LV dysfunction. So do you suggest all patients of LV dysfunction should undergo angiogram? Because then only this question will, because if you see the revive, it looks to me it's a heart failure trial, almost semi-symptomatic, asymptomatic EF28. How it was planned to do angiogram and find out he had a 2 vessel?
Yeah, it is something that we do like in motor neuron disease to exclude the spinal compression. Okay. So, knowing the etiopathogenesis of LV dysfunction is almost mandatory. For that, angiogram is definitely required. Now, next issue comes whether we are going to do something based on the angiogram report, whether it can improve the LV function. So therein comes the question of viability and ischemia. But then, as you said, in younger patients with not so dilated LV, subjecting them to CABG, unless there are other comorbidities, may still ill benefit. But in older patients, where you are not sure, demonstration of viability, I still think holds good. If patients have anginal symptoms, decision-making becomes much easier. But for asymptomatic patients, decision-making is more difficult. So,
yeah, Dr. Sahu. Yeah. It's on. Yeah.
Question of viability we ask ourselves, or we ask when the patient presents with a severe LV dysfunction, presents with a heart failure, and there is no history of angina. It may be comorbid diabetes or other comorbidity. Patient has no angina, we go for a angiography in those cases. So with heart failure, when there is no symptom of ischemia, or can it go for a reversible ischemia test like suggested either TMT or reversible myocardium echo or myocardial perfusion imaging? Then we go for a viability study. So my question is when patient with the ischemic cardiomyopathy presents and we should go for angiography whether we can improve the patient the either dilated or ischemic cardiomyopathy. We go for an angiography and found there is a block, but unless the myocardium is viable, he won't get benefit. So we test for viability. So which viability study, if all of the viability models are available, which test will do? Because in street trial, as you were mentioning, they had did not have the SPECT or bed study, other things they did not do viability study in all cases. So which viability study will suggest in this case?
See, as I said, the gold standard still continues to be an FDG PET, fluorinated deoxyglucose PET, because the change in metabolism of a hibernating myocardium is a very important feature. Actually, this is a gray area. As I showed I tried to show that it is not just viability that matters. What also matters is what is your ventricular size. If the heart is ballooned out, it is. I was talking to Professor Bax, Jeroen Bax, in one of the meetings in Bombay, and they said that if the left ventricle is dilated beyond 7 centimeters, if my patient's LVID-D is more than 7 centimeters, or if my patient's LVID-S is more than 5.8 centimeters, 58 millimeters, then there is not going to be any benefit of any intervention, because by this time the neurohumeral activation has become so strong that even if you revascularize, there is not going to be much benefit. So it is not just viability, it is the degree of dilatation, it is the duration. Dr. Soumitra repeatedly highlighted that, and I also tried to do that in my first few slides. If my patient's index event has happened a couple of months ago, 3 months or 4 months or 6 months ago, then the remodeling has not taken to an extent that revascularization will not benefit these people. When you're not able to make out, you look at patient's contractile reserve. If the patient, because that is also one of the methods to judge the viability. So viability it's got different arms, and one has to take a collective judgment based on the volume, based on the presence of contractile reserve, based on the FDG PET, and even CMR. Yes, because if it is not showing increase in contractile reserve, as I said, one of the problems with the nuclear scans is that they are continuous. They are on a sliding scale. They do say, if that is why they say if it is a more than 50% uptake improvement, that is important. But generally, you will find in routine viability testing, they will just say that this is a viable area. And then we have also, he also stressed on that, and we have all learned in 1993, when I was actually preparing for my DM, the American College of Cardiology statement used to say that if the ejection fraction is less than 40% and you have more than 20% viable area, then CABG helps. It helps in improvement of mortality. But slowly and steadily, as angioplasty has overtaken, the percentage of viable myocardium has been decreasing. From 20, it came to 15, which Soumitra also said is very large area, and it is considered now. It used to be 20%. So you are becoming more and more non-selective. You keep on decreasing. This is what happened in ischemia trial. They started with a 15% cutoff, then they came to 10, and then they came to 7. So we are like wanting more and more. If you follow stricter criteria, you will show improvement. But it is because we are making our criteria less and less. That is why the statistically significant improvement is less. And the most important underlying fact is what Dr. Soumitra also showed in one of his last slides. We must realize that medical therapy has improved tremendously. When the previous trials were done, there were no drugs to treat. Now you have ARNI, you have the 4 pillars of heart failure therapy. They are beneficial across the board, whether it is ischemic or non-ischemic.
When multiple
Live case actually at 11:20. So
Can I ask one question?
yeah, last 1 minute. Yeah,
Okay.
we have to go live.
What do you do in your clinical practice?
For viability? Yes.
Yeah, related to viability, acute and in chronic situations.
So in your institution, what is available? So most of the time it is, if you have oncology, you have a PET inside your hospital, you get a PET scan done. And if you are not, then next is MRI. So nowadays, hardly we are doing a technetium or thallium scanning. Either FDG scan, which has a lot of ifs and buts of carbohydrate, of so many drugs. MRI problem is interpretation problem. So people are still learning on MRI. So you make a use of probably both. I'll use PET first because we'll assess other etiology, infiltrative, sarcoid, myocarditis, other things you can rule out and then do a selective MR.
If a patient has obstructed LAD, MI 3 days duration, what do you do?
That's different. If it's a flowing artery, probably I'll go and fix it. If it is occluded, just put him on medical management and assess viability. Okay, so we close the session and thank both the speakers and my co-chair.
Thank you so much. So this is the conclusion of this first session of pressing issues. I will request to connect us with Medica. We will be having the online case site. So I will request to please get connected us to Medica. So we are already here. And for this, I will request the following elite personalities and excellences to please be on stage. Dr. S.S. Chatterjee, Dr. Shubhanan Ray, Dr. Saroj Mondal, Dr. Anil Mishra, Dr. Jayanto Shah to please be on the chairperson panel. Requesting the panelist, Dr. Shobhik Kanjilal, Dr. Gourango Sharkar, Dr. Moinat Mukherjee to please be in the panel. Along with that, we will be having the 2 live cases back to back from Medica itself. First live case site, Medica. The speaker will be Dr. Rabindranath Chakraborty along with Dr. Shomo Patro, Trans Lumina Rota. And for the second live session, the speaker will be Dr. Arindam Pandey along with Dr. Sanjeev Mukherjee from Translumina. So we start off with the live session. We are already connected. So over to the panelist.
Hi, Dr. Robin, can you hear us? Hello.
Hello, Medica Hospital.
Yeah, can you hear us? Yeah, this is Dr. Anil Mishra. Can you hear us? Hello. Dr. Robin, we can hear you, Dr. Robin. Can you hear us? Oh, we can't see the faces. We are only seeing your hands. Sound is not so clear. Can we technicians take up this, make the sound a little better? Meanwhile, I have Dr. Pandey with me and Dr. Jayanto Saha with me on the panel.
So we already functioned with the Kuda function as the dot and Kuda as the access to the 716 and then we took the 3.5 new capital and already we have engaged our software over microcapital the rota we stick to we are preparing for the rota code. Please go the individual before. Please play. We can see this man is having very severely calcified LED vision optimal with LED junction. However, 99% sensitive to the system and there are also is on the RT, the Harting approach was taken and let's send you some views. Play the views. You can see here very tiny of the LED. I had a difficulty to cross with the microcapital, but somehow I was able to cross it and now I am taking the to crack this vision. And we have a plan, if we crack this vision, we will do our work, our plan of management is to do our work. And
You project the main screen now. Project the current fluoro image. We are not seeing the screen. Right. Now we can see.
Yeah. So I am taking the so I am taking the rota 1.5 rota bar.
Do you do simply straightforward or you do use Dynaglide to move it forward?
Yes, the Dynaglide already is started.
Why did you choose ROTA? Why not orbital atherectomy or IVL or something else?
So I think I'll say rota in this case.
What speed are you going to use?
No, that's not right. No, it's not going. It's not going.
Is it Rota Link or Rota Pro Shomo?
Okay. We'll start. Yeah, it is Rota Pro.
Okay.
We'll start.
Where would you want to keep the distal end of the wire?
Let's move this over. Ongoing. Not there.
No, my question, where do you want to keep the distal end of the wire?
Pressure, you can show the pressure from there. We'll go ahead.
What's the RPM you use?
Can you drop in the pressure? So far,
So Somo, you are using a high speed rota or a medium? What is the speed?
what's that?
What is the speed? 150, 160, how much?
130, 130 and
Okay.
130 RPM. Okay. You can increase little bit.
Why are you using relatively low speed?
No, I am going to gradually actually. The very time you can see this is so far not cracked. No problem. I think I cracked a little bit, that jump and there is drop of power 5,000 RPM. So we'll do one more run.
Yeah, probably you want to do a couple of more runs.
Should I do one more run?
I think so.
Okay, I will. Roughly 10,000. Will come back.
Looks good now. You polished it well. Is there some further obstruction beyond that? The mid segment? Is there some further obstruction just beyond the tip of the?
So you have a plan to use after rota?
Yes, yes. I planning to do it. I think now. Oops. I think we have crossed and this region also.
Yeah.
Now we'll put the wire. We'll make the railway call.
Yeah.
Good. But this is.
Yes.
Good. Yeah. Microphone.
Around 12.
Holding the wire. Okay, wire is 5. So we extend this rotor wire with our wire. And then we'll do the Eiicon and then we'll decide further. Another important thing is this is a very complex case of with rotor, maybe IDL and it's a very tight classified research. So here proof to take can be understanded or as an rather than giving the speaker. Is there any comment from our panelists?
Was he preloaded earlier with the DAPT or?
Giving the whole of candle, followed by we are giving the infusion of candle, our gallery is just longer, is longer, you can tell us what is the dose, is how much we have given. Only, na? So I am inserting our microcatheter to extend the wall for wire. So you can see this microcatheter now gone very smoothly. Previously, I had a difficulty to cross it, so I removed this rotor wire. We take now our wall wire.
Is it your usual practice or you pass your wire just by the side of the rota wire?
That can be done. But as we has a length of 300 centimeters, so it's better to have a. We do not have any problems for microcatheter in the wire, so I will remove it. Because it's a new one. I think
First.
you must get, So, this microcatheter, which I don't take it, it has came out, so I did not take payload even inside the catheter to keep it up. How will it take what how will it take hot? How will it happen, how it's looking, then we will take I was ready. Are you ready? Now you can see there is cracking of the calcium or some calcium, I think we need to give some Nicola and we will give some Nicola. It can happen. I have experience with organization and those that did not do this proof, but in my both the cases after doing the run, there was then I give this small molecule and this molecule. Give me Nicola and before giving the I was to have exact group versus the diameter behavior, then we decide for the
You want to wire the diagonal as well now? You want to wire diagonal as well?
It's a large branch. And this will need further pre-dilatation, I suppose, the mid segment at least.
Yeah, it was Eiicon before. So, small molecule like Nicotinamide and injection BTM giving intracoronary. So now we will do the Eiicon imaging. So do the Eiicon imaging to our.
So Shomo, this patient is on Cangrelor and aspirin. What else?
Aspirin and Cangrelor.
No P2Y12. No ticagrelor, no prasugrel.
After that, there will be one ticagrelor and then we.
Yeah, you can give it before because you can give it before.
We'll do
Now, since this is a planned case, why would you want to use Cangrelor and not just preload with ticagrelor or something?
सुनील आइगस के बाद हम लोग स्विच कर लेंगे बात करते
Show me my question meanwhile, since this is a show me.
Class needed. Class. Now better. Is the better side is can we go here? Okay, the better side is about 2.75 I think.
Yes, it's at 2.75. Yeah.
2.75.
Easy. Shomo, you show us the IVS. After that, we'll switch to Dr. Arvind Pandey's lab and we'll come back to you.
Increase the count. No. Not really coming. Pull back. Manual pull back.
Yeah, it's a seen well.
There is, you can see, there is lot calcium and there is fat on the calcium or in the calcium level. You can hear you can see.
Yeah, calcium mark is more than 180.
Here, where it is, I think is the calcium. Mean for the story. There is difference. And here also is there just now, there is greatest of the calcium. Roga, I think, yeah, this much of actually luminal good or not gauge with your orbital aperture. That is for sure.
Yeah.
The gauge is better with Roga and orbital aperture will be user friendly. But nowadays, with the Roga flow, I think both are the same. Using the Roga flow and the orbital, both the hands we can use. So I will look at it.
So your plan is to do further plug modification? So what I do, keep recording it. We'll come back from Dr. Arindam's lab. Okay, switch over to Arindam. Arindam, you are live. Yeah, Arindam, tell us about your case.
So very welcome from medical practitioner. This is our new cat app. Azurian 1820, we actually opened just 1 month back. And we have a case, I think Dr. Sanjay Mukherjee will be giving us about the case. He's a 79-year-old gentleman. Dr. Mukherjee.
Can't hear you.
Chairperson and friends. So this is a 79-year-old gentleman. Again, we are dealing with calcium. So it's an LED which is going at the last meeting. We have done few things prior. We have already started the case. So again, he has got a very tortuous LED austere, followed by that a long segment tubular calcified division.
We are not able to see the original angio.
So, yeah, is it visible now?
Yeah, we can see.
The division and Horizon has come fresh with the Japanese technique to show a contact calcium that will show. Show the next. So this is the lesion. We can see the option of the area involved and each area is involved. We can clearly see the very significant amount of calcification. In fact, the patient was initially taken from CTNU outside and they refused to do CTNU because of very high calcium load.
Okay.
And at this point, we took in, there are some important clinical history regarding information. The 29-year-old gentleman, chronic atrial fibrillation, chronic coronary syndrome, CCS class 3, and at this point, he is having a CTEC score of 19 for a cardiac disease, LAD, proximal, and osteal stenosis, very significant calcification. I plan to check for Eiicon guided management of calcium, followed by angioplasty. Now the issue is why it is a 7-French jail because it was short length and osteum of the LAD was involved. And 7-French jail we could wear it very easily, no problem at all. The problem started after that because we take Eiicon catheter, but Eiicon catheter because the new of Eiicon catheter is not going this way. So we actually could just cross the osteum of the LAD up to that much, but it was I will show the guidance whatever you gather. But catheter, video catheter is not being negotiated with the vessel. Is the Eiicon visible?
Yes, on the side, you can make that, yeah, now you can see the big screen, right?
So now we started because this kind of patient will perform very significant calcification and we thought we need to do iron vessel and some calcium management tool as well. So we did that the compliant balloon. Now we are with the 2.5 we are with the not compliant balloon. I have a plan to do Eiicon now. Let's see the Eiicon goes or not. Okay, come to the initial one.
So this IVUS which we are seeing is dilatation? Right. Okay.
Okay, go at 22. So the 2.5 non-compliant application balloon, we are directing at 22 down days. Okay, and do another, go, 22 again. 22, okay, it's not opening nicely anyway, come down. Let me take the IVUS catheter and see whether it goes or not.
Is it because of angulation or is it because of calcium? What do you think?
I will try to show that the IVUS catheter. Patient is also having a history of chronic atrial fibrillation, so there can be some discussion regarding the antiplatelet and anticoagulant strategy of the patient. You are having a full dose. I stopped having a 2 days before hospitalization. I have given aspirin and topical loading, and after that procedure, I'm planning to go with a triple anticoagulant therapy, aspirin, topical, and either dabigatran because you are comfortable with dabigatran. I'm planning to continue that for another 2 weeks, followed by stopping the aspirin and continuing with the dabigatran and topical.
So he's on clopidogrel only today or for quite some time? So you don't intend to use Cangrelor? Arindam, you don't want to use Cangrelor, high-tech procedure. Clopidogrel will take several hours to act.
Okay, now we are live the IVUS, so we could do that. Fortunately, we could cross the IVUS to the mid-LED. You can see the event right now, live IVUS is going on.
Make the IVS onto the full screen.
Please take the IVUS on the full screen.
Right.
This is the healthy section. You can see very good result. I think it's at least 3.25 result. Now the block is starting. We can see the calcification. Oh my goodness. Almost
Yes.
But very, very significant calcification. Here is 270 calcification, almost like an active ring. That was the reason our New York IVUS catheter was not getting negotiated. This was the HD IVUS.
Yeah, it's almost 360.
You're almost 360 or in the proximal part, yeah.
I can see with the AC balloon, some that was made in proximal calcification.
Yeah.
And now I'm showing towards the ostium. This is the ostium. This is also significant. Very significant. No doubt about that. Any opinion from house about using the ideal catheter and so opinion not opinion how what calcium we are supposed to take in this data.
I'll go for root ablation because the length, in fact, whole LED proximal mid, you will not be able to cover with one IL.
The second option is this 120 impulse one, if you have one.
120.
Because that may give you the full length coverage.
Not yet. In future, we have. One problem with using ROTA in this case, the ostium of the element is involved. There is a good amount of angulation. And as the angulation, as we all know, if we use ROTA, there are possibility of some complication because there might be wear, bias, and all. So, ROTA is a good option, but I don't have like already stated the 2.5 millimeter non-compliant balloons. I think we are going with the ideal. So, very significant using the classification. We will try to use our counters very uniquely so that we can finish it by 2.
So, Arindam, whatever you record it, we come back to, in short while, we switch it back to the Soumya Patri's lab. Switch to lab. Yeah, yeah.
I have a distal cross distal calcium, what I was getting during the rota. So there must be a calcium nodules there, especially calcium nodules. So I am doing IVL on the distal calcium.
What is the size of the IVL you have chosen?
Yes, so I am taking 1:1 with the IVL of 3 with the IVL I have taken.
Can we see any indentations when you inflate the balloon?
Yes, we are going in the 4 millimeter, 4 atmosphere bar, nicely. Now we are getting the power pulse.
Very small indent.
Look at the ECG.
Yeah.
Sometimes during this ideal inflation, there is arrhythmia, sometimes it could happen. But it usually is benign and after depression and all, it will come back here. Okay. So I will go there. Go here, please. Go here.
So how you are going to ration your IVL?
Since there is a lot of calcium actually in the IVL, maybe due to other things, maybe due to this, you can see there is still oil in the very main portion of this IVL emitter. So you can see as an expensive calcium, so we need some sort of modification.
I also see some air bubble in the distal balloon. Yeah, so you want to get rid of that because it may cause burst.
Yes.
You lose the other 70 impulses.
Yes. Okay. We'll come here. We'll come back. Here you do. Still you can see there is a lot of calcium. Even the fluoroscopy is going.
So one very valid question Dr. Pandey has just put in, how are you going to ration your impulses? How do you decide that?
I actually, you can see in the monitor, there is calcium and we move our remitters between the calcified area, the fluoroscopically divided.
The distal part which is not expanding is away from the emitters. There is visible calcium on fluoroscopy as well. We can see that area. Would you want to center your balloon on the densely calcified area? Yeah, just get the emitters over there directly and see what best you can get.
The optimal calcified area, optimal means the way of getting the calcium with our rota, but the distal one is causing a problem. Arrhythmia. There is arrhythmia. I have to be ready. Now please. Now fine. Now the arrhythmia. Now let's go here. I have done almost. So last few pulses over this calcified area.
Sure, proximally you're not going to get stuck. Proximally also there is significant calcium. Oh, there's a lot of indentation. This deserves some more shock waves.
Ready, come stay with the patient. Now. One more idea, maybe on the phone taking idea, but we don't have. Now the rhythm is again.
So that is one of the problems. When you have long lesions, The
Yes.
ideal IVL has limitation of only 80 impulses where you would want more. So thank God they are coming up with 120 with the same cost.
Still there is, I will, go ahead, go ahead. This is the area.
Yeah, just inflate and see whether you want to deliver anything there at all or save it for the distillation. Well, this also warrants some. The mid, I mean, from, yeah, what we see, the middle is still indented.
I already expected that there would only Honda or Eiicon is not going to get full benefit. So I decided to go for this year that.
As well, I think personally, some of us feel Rota could have been a decent choice as well.
What?
Upsizing of Rota.
Everybody, I think all of you agree that we need is only one calcium molecule.
Yeah,
will not be helpful.
I think this is expanded. You don't need to deliver anything there, possibly.
Qualified student. So I don't know whether it will go more than or.
Look where it doesn't expand well, deliver the rest there.
No, this is also, okay.
I think approximately it's stuck.
On this step over here. Okay, fine. We'll remove that there. We'll it will see later. No, I don't think possible. There is a lot of greediness, I can tell you.
It's quite expected though.
15 pulse, if we would have to
See.
cross the 10, they will decide whether post-staging IVL is done or not.
One of the problems is sometimes with this dense calcification everywhere, there are some calcium spicules, and while you are removing the balloon, they burst into your balloon. So, so while removing the balloon, one should be cautious that it's fully deflated, because we have had this experience that in normal angioplasty balloon, as soon as it's deflated, you start pulling it out. And I've seen twice that you're after 20-30 impulses, your balloon is gone because you have pulled it out too quickly.
We have only 50% left. So I'm giving small molecule, then look at the angiogram. If you tell, then I can take the stent in. You want to give us more or not? You want to okay then? So who will pay for that? So, for okay, we need another wire. Oh, this is fine, or this is fine, all is open. There is calcium nodule, we have to.
Looks decent, I think, it's ready for stenting.
So, okay. Let's go to take care, so we will take the same here.
Yeah. Question from the audience, what about the LED ostium?
Yeah.
No, we never delivered any impulses to LED ostium. So,
Yeah, Indrani, keep on. Come to the microphone.
There in the LED ostium, no, would you not like to address that? The calcium is there, right there on the LED ostium, just see there.
Actually, we'll do I1, okay, no issue. We'll take the same, or we want to do I1 once again. We'll take the same there. There is plot at the distal LNCA, but you know every plot could not be treated, so I don't think you will see that plot even. So I will do the LNC staging, then we'll do the I1. If anything, then we can think of that. Yeah, what about the opinion of panel? We'll take the same.
Well, yes, I suppose after keeping a wire in diagonal, it's a last diagonal.
Yeah.
I mean, I know it takes a little extra effort, but some safety always in doing some extra things.
Yeah, but you were the diagonal and I find a good residual after diagonal. Probably you need another NC balloon work just being the diagonal. Yeah. Just you plan to put a 3.5 stand?
We'll take these steps only.
Okay.
Then we will just put that with the 3 OPL we have.
Yeah, one thing good about IVL is even if you deploy the stent, you can still go with another IVL and deliver shock through the stent and still have expansion. So that scope is there. It's a very forgiving thing. And having used all the three modalities, ROTA for many years, orbital recently, and IVL for some time now, we find this IVL to be very safe. There's very little learning curve in it and least complications.
Yeah, can we switch to the other lab? We want to see.
So I put the diagonal over. I think you want to be happy right now.
Makes us feel comfortable, of course.
Yeah, it is going forward. So without wasting time, take the step.
Yeah.
What is the
We are switching to our lab. We'll come back to you. Yeah.
Can we switch to the other lab, please?
Live.
Thank you very much. So, fortunately, we crossed the IVL, and IVL balloon, it was a 3 minutes IVL balloon. We have started already delivering the shock from the mid portion of the LED to the top tunnel. We have given 50 pulses altogether. We are left with 30 more. So I'll now make it 6. So I'll now go to the ostium of the LED. Okay, please.
After this, can we see the previous runs to see how well the balloon expands after IVL?
So I should can someone show the how we delivered the pulses, how the balloon opened up, and by that time I will take the IVERS. Should they take IVERS or take a Okay, we'll take IVERS. Opinion on the house. I thought I will be leaving a packet balloon at this point. Anyway, we are taking the IVERS to see how much calcification tracking was done with the ideal balloon. We are still left with 20 pulses.
Can we see next images?
Show the ideal calibration.
This one.
Next, please.
Looks good.
We are quite satisfied the way ideas will opened up during delivery of the houses. We are very confident that our job has been done nicely. So let us see the drivers. That will further boost our confidence. The drivers is going easily now. Go to Kevin, please.
Can we put the IVAS images on main screen, please?
Hello. Thank you. Go again. So across the region, that we do the align drivers. Put the items on the main screen, please. This is the heavy segment, almost motor 3 millimeter, 3.25 to 3.5 millimeter vessel here. And we have started to pull back. This region from where the mission and calcification started, you can see the tracks very clearly. There are reverberation. At this point, probably, this is definitely cut. The calcium is cut again. So this is calcification. At 11 o'clock, as well as at 6 o'clock, 5 o'clock, there are clear cuts. We can see there are reverberation effect, which also suggests that calcium has been taken care of. But I don't think I think we need more movement gain.
Yeah.
Cutting balloon at this point, opening of the house.
Yeah, you need most likely cutting room there.
So there is which cutting balloon we go ahead.
So you have a Wolverine on the shelf?
Yeah, we have.
Yeah.
So start what size is the panel suggest?
Yeah, take 3.
The balloon was 3, no?
Can go ahead of 18. So fine. I was done with the left main, I think. Yeah.
Those 2 cuts leave 180-degree arc on either side. Would that be sufficient to expand it?
I'll see. Otherwise, we have 20 more passes left in the ideal balloon. Let me see how my this balloon opens up. That will give me more confidence. Okay. Stop the area.
Right, yeah, 2 grade, 3 is man. Expand करेगा, needs to have a little more tracks here and there. Floor crack होने से होगा.
What time? 3.25. So we are taking a 3.25 millimeter here.
Okay.
So what pressure the panel suggests to go up to? It will
Go to at least 12.
If you're taking 3.25, I will first try 6 to 8 first and then see.
Any other suggestion? Because I have seen operator who are going with even high pressure up to 18, it is not recommended.
I think you have already pulverized the calcium because there is an advantage of getting OCT. You'll get more information what the IVL has done than what the IVOS is showing. Yes.
I mean, there's no study to show that basically. There's a theoretical possibility, but I don't think from polymer it won't be released so fast.
Most of the time, either you need a drug-eluting balloon.
You see, no, thing is, polymer is a soft thing and the shock waves will affect the hard things.
10, 12. I think it is open to very nice.
Yes, see in some other orthogonal view.
Yeah, I see that. Because this area was not that much of calculation and put it and see in other orthogonal view. Let me put it up. Go. Go slowly up to 6. 8, 10, 12. Slowly another view. Orthogonal view. Other order you can go to the other level. 12, with a 3.25, I will taking a screen. I can see very nicely, very nicely. No
Yeah. It's open well.
Good, please. Yeah. The calcium good also showing good lumen gain. Go there. Go 6, 8, 8, 10, 12. Is it opening? I think reasonably open. Very good.
Looks all right. I mean, the distal part where there was almost 360 degree, that's where it seemed to open well.
Go ahead. Seven, 8, 9, 10, 11, 12. This area. Okay, it's not open.
Proximal.
16, 18. Okay, down. It's open. Okay.
Yeah, it's better. We'd like to see IVUS run again now.
Yeah, I'll do that. Let me do a little more. Okay, go. 8, 10, 12, 14, 16, 18. Okay, this also open. This was some indentation in the middle. Okay, now I went up to 18 here. Middle portion showing some indentation. Then go again here, go 6, 8, 8, 12, 14, 16, 18. Okay, come. Go to yellow quadrant, please.
How is the blood pressure, Arindam?
Blood pressure is very good because 110/60 from the very beginning, like that only. Yes. Go ahead, go. No,
This section. Huh?
Next. I think we have done a good job with the building as well. The patient is holding.
Yeah.
Normal. Items are normal.
You obviously dissected.
Yeah, we have created a good dissection as well, which is helping in our process of putting a stent and doing post dilatation, I hope. So at this point, everybody present to do a liquid diversion or take the stent later.
Right, we'll come back to, let's see the finishing shot from other lab. Yeah. Switch to the other lab. Yeah, show us what you have done so far.
And definitely the calcified research, but with this calcium plus modification is called sorry. So I do first we do see we take the balloon I will take out the balloon.
So what was the distal stent size?
Was 24, I think, and the proximal stage was 3.5 into 24, I guess, the ultimate PC, and we can show the bone changing here, where to the warehouse, and I where is the diamond, the panel, to put here, there. You can see this is there, little bit different, but I cross with into the diagonal, and then I took the value of 3.5 again for the pot. You can see here I am doing the pot. Okay, I am doing another balloon dimension. Show me the both fluid. Very good. Okay. I think it's little bit. Okay. Go. Yeah. But yeah. Okay. So I did the pot. So now I will show you, and then you decide whether to take OPS or whether to take 3 or 3.5 millimeter balloon to finish my case. I already done. So you can see and you decide. Hey, what is the
What is the ACT you are maintaining?
Last time it is 266, and then we did 25. No, 266. Then 266. So give me please report on small molecule, then we'll take the plot. Yeah, report details. So just bring report details. So then you tell me what to do, whether to give OPA, make OPA direction, or to just INC value. So we are just 5 to 10 minutes more. Finish my case. Nowadays, what is nowadays, we see lot of young generation patients also having so much calcium. Even when I started about 7 years back, I found some patients with a lot of. You can see this is done nicely. Your diagram is also showing.
Show us some other view. There is a lot of glare actually here.
Yes. So, I'm really glad to try to class after giving the roller.
No, just collimate the little bit collimation. Put the filter on the upper quadrant. Yeah. Yeah.
Yeah, that's better.
Oh, very good result. So just before the septal, probably you need to work slightly more, otherwise it looks very decent. Yeah. I think you need some make adjustment. I will leave it to you.
Yeah. Maybe just before the septal, you need one more dilatation, post dilatation. But again, even otherwise, it's a good result. And IVL shown has done the job it's supposed to do.
Yeah, you solving IVs, just look at the same. Look at the NSA and decide. Okay. Yeah. Yeah, you look at the NSA. And you have a very good result. We want to thank you and we see the result is. Thank you very much for the nice demonstration of the IVL calcified lesion.
Yeah.
So switch to Arindam Pandya's level. Let's see the final result, what he has done. Yeah, Arindam, we are with you. Yeah, we are seeing. Yeah.
You can see. It has made very nice. Even in this area where there was 50 degree calculation, there was very clear cut parts. can see here.
At this point, yeah, there is at 11 o'clock and 5 o'clock.
Yes, but this is here in silent line.
But the limit gain is not that much.
This is that, but the cut is very good and we got a very good distinction as well.
Yeah.
So what I'm planning to take the stand at this point.
Can we see the one last angle you did in criminal group? Leave it on the main screen, please.
I mean, the rest of the vessel looks fairly reasonable, but the distal part still has a lot of
Yeah,
with only
yeah,
two splits.
At one point, just after the septal. Yeah. Yeah, but there's a lot of jump, some modification. Yeah.
He'll be just missing the ostia, looks like.
Yeah, he'll pull it back.
So osteum is covered.
No, I think it's all right, actually.
Just about okay, looks like.
Yeah, in this view, yes. Just take one more view. Yeah.
But why is it looking a little eccentric?
Yeah, because of angulation.
But the die wind is
नहीं वो angulation ऐसा ना तो जैसे लग रहा है दो separate origin है.
I think it's covered.
Yeah.
You can still pull it around 1 meter. So
It's a lot of sinogram, so a lot of contrast in the sinus.
yeah.
We have a fair amount of dissection around.
Yeah.
Very short but actually disengage is catheter. We will sign up now. So that fine. Okay. Yes. So digital angiography looks good. I think I'm.
Yeah, proximal is also good. You are.
It's okay.
Yeah.
7, 8, 9. What is now? 9.
So in the yeah.
I think reasonable opening.
Yeah, in the only proximal 10 millimeter, you probably need to work.
Okay. Come down.
I would imagine the proximal half.
Yeah. Up to that bend.
I think the proximal half of the stent needs a little more post dilatation. Rest all looks fairly good. And most of the job is done. I think we may have to switch to the other lab to see the final result. No, they're done. Good.
So this is the part of give me a 3.75 non-compliant please. Let me see, I want to reply our opinion.
Just a small announcement. All the delegates will get their lunch coupon once you enter the lunch arena. So nothing to worry. Okay, we are switching to lab one for a final shoot. We have still 5 minutes. We'll come back to you. Okay. Yes, Shomu.
There is no other regulatory calculus. So it will be the OPM balloon I have to the utilization the three OPM balloon.
At what ATM?
What ATM? 30?
24.
24.
The distal age of the stem is not, there are a lot of ways, so everything was going about 5.6 at that point, and the other one is more than less than. Or more than 7, what is the everything about?
MS in the proximal LED was how much? Oh, okay.
Proximal was good actually, but the distal was problematic. Okay, then let us talk. Lots of candidates. That kind of days with rota, their ideal, they okay, there is nothing in our hand.
Acceptable for stent area and stent expansion, 90%.
How, if everything is more than 7, then it is acceptable.
Yes.
If the everything is more than 5 or acceptable. Okay. One, then on the column view. Already directed with the people, I will writing or I am getting and I will compare. This is directed down.
Let's see.
Will do our final thought and give
Let's
the
see.
people an out. Come to spider. As I didn't give was more than 36 for 40 days or so, the wire is this to otherwise the wire will come back sometimes to the higher pressure. This is fine. Give me for a detail and our final thought to 5 minutes more. So I finish my case. I hope everything is fine.
The minimal acceptable MLAs are different for Europeans and Asians because the Korean studies show a little lesser.
Yes, yes. Asians will be there. So and Canadian also, we have done what was possible to show the case challenging with the use of Canadian. This is right. We'll go the way. Career there is, okay, what can we do? Okay, fine. So, take on. So all this, I think.
The other view as well. This looks good.
Yeah. What is this? Very good. In fact, distal left main now looks narrowed.
Yeah. Actually, the distal left main looks a little narrower now that we have opened the LED well. But again, that's acceptable. Okay, 20-30%. So what?
Yeah, you have a very good result.
What you are saying, the last part. Our one secure concept is okay, I go the stage where I go the result. I think we should be able to accept this.
Absolutely. Yes, Soumya, thank you very much. You demonstrated very nicely use of 3 modalities to how to deal with calcium in one case. So very interesting, good results.
Actually, it was a difficult and I thought I need for the more difficult one.
Yeah. Thank you very much. We'll switch back to the other lab to see the final shots.
Just switch to the other lab for the final shoot. Yeah.
Thank you, Steve. Thank you, all.
So, Arindam, yeah, we have got 2 more minutes to go.
Yeah. So we have already functionality. I think I'm going to cover the options. Okay. Ready? Good.
Yeah, go ahead, Arindam.
So So this is the proximal part. We have already post dilated with the 2.75 client Apollo AC balloon. Go up to 28. Fine. Thank you very much. Now, we are planning to do the distal portion with 3.5 balloons, 3.5 non-compliant balloon. Take me down, get one quarter in it. Your quarter will be taken.
2 minutes. We have only 2 minutes to go. So
Right now, what is ready?
Yeah, but the LED ostium, which was the tightest, is from the good result. Yeah, only the ostium we have to take care.
Picture looks good. So we take a 3.5 balloon.
why is it looking hazy around
Yeah,
the
there is some haze.
septal area?
Some haze. Look at the ACT. So Arindam will be offline, so continue and we'll listen from you in the evening. So thank you very much for the good demonstration of the ideal and calcified lesion. So we close the session along with my co-chair, and the next session will be announced by the hour. Yeah.
Thank you so very much to all the elite dignitaries present here. And we close the live case site. Yes, we will have a picture perfect moment. It was a very tough case, as already sir has stated it. So conclusion of a live case, 2 live cases. We have so many more live cases to be witnessed today here. But as of now, we move on to the next session, which will be potpourri. And for this particular session, may I request the presence of Dr. Anjan Shiotia and Dr. Mrilinendu Das to please come up on stage as the chairperson panel. May I request Dr. Dipendu Khandra and Dr. Shubhashish Roy Chaudhuri to moderate this particular session. May I have the following dignitaries on stage, please? And we start off with the first speaker of this particular session, potpourri. The first speaker, the topic is SVG PCI by none other than Dr. Munna Das. So we will have the speaker here on stage, but before that, I will request all the chairperson and the moderator to please be on stage so that we can start off. I will take the privilege of calling upon the names again. In the chairperson panel, we will be having Dr. Anjan Shiotia and Dr. Mrilinendu Das. In the moderator panel, we will be having Dr. Dipendu Khandra and Dr. Shubhashish Roy Chaudhuri. So requesting, so we start off, as many are present, we start off with the first session of potpourri, the topic being SVG PCI by Dr. Munna Das. And to all the delegates, dignitaries, yes, definitely. And to all the dignitaries, officials, excellencies, please do not bother about the lunch coupons. You will be provided with the lunch coupons when you enter the lunch arena. So we will be providing with the lunch arena, lunch coupon at the lunch arena. We also will be having Dr. P.K. Hajar sir joining in the chairperson panel. So we start off with the first topic of potpourri.
So it is my proud privilege to Das. He worked in our department of cardiology for a long time. After that, he is dynamic cardiology at the hospital. Okay. Please request to present the subject for the graft intervention.
Thank you, sir. Thank you, sir, for your kind deliberation, and good afternoon, this August audience. We are here to discuss something about saphenous vein graft interventions. As we all know that the saphenous vein graft interventions are not uncommon in the entire career of a practicing interventional cardiologist. We do encounter saphenous vein graft failures, and saphenous vein grafts, as compared to the native coronaries, have some unique features. They have high failure rates to the tune of 3 to 12% occluding before hospital discharge post CABG, and 8 to 25%, that means 1/4, do fail at 1 year, and only 50%, half of them remain patent after a decade. So around 13% of patients who undergo CABG will require some form of repeat revascularization within the next 10 years. Another 18 to 20% of all PCIs that we perform in patients with previous CABG, and 6% of all PCIs are performed on the grafts. So the burden is quite substantial. And the natural history regarding the venous grafts are basically a substantial fraction of these venous grafts do degenerate in the lifetime of the patient, with degeneration starting within the first year itself, and then progresses at 5 to 10 years, around 50% will get occluded. Now, very early failure, that is within less 1 month, is mainly due to a technical failure or thrombosis, most commonly at the anastomotic site. And early post-CABG venous graft occlusion, that we define as within 12 to 18 months, is actually characterized by a marked intimal hyperplasia. And this intimal hyperplasia occurs due to the hemodynamic stress of arterial pressure being transmitted to the graft itself. And that causes platelet aggregation, growth factors, cytokine release, imbibes smooth muscle cells within the intima that undergo phenotypic change into fibroblasts, proliferate extracellular matrix, form new intima, new vessels arise, neovascularization, rupture occurs, plaque rupture with occlusion is the ultimate fate. And that usually occurs beyond 1 year. And this is the graphic representation of how the vascular disease progresses in the grafts. Now, this graft atherosclerosis, it progresses actually at a faster pace compared with the native coronaries. And this is obviously a more concentric and diffuse phenomenon rather than a focal pattern we observe in your normal coronaries in certain cases. And the cap itself is very less prominent or even absent. Therefore, they are very much prone to rupture and cause occlusion of the grafts. Now, regarding venous graft interventions, the Achilles heel is basically the nature of the atheromatous plaque deposition within the veins, which are very friable and without a thin fibrous cap. That actually poses a high risk of distal embolization. There is a risk of vasospasm too, and no reflow, with attendant periprocedural MI and a long-term mortality in such patients. Now, certain factors we can predict regarding the 30-day MACE events following graft interventions. They are actually the venous graft degeneration and the plaque volume that we are dealing with, in particular the lesion length. Long SVG lesions are actually detrimental. Chronic renal insufficiency as a baseline factor is obviously an important cause for MACE events across the spectrum of interventions, and a high periprocedural biomarker rise in terms of CKMB 5 times or more predicts mortality. Now, native vessel percutaneous intervention should be our main motto in such situations where we find graft failure, if at all feasible. The anatomy is amenable. So, in only exception is in acute occlusions, where venous graft PCI initially can be done as a bailout procedure, and if the native vessel PCI is not feasible at that moment, and that can be staged later. Otherwise, native vessel PCI should take precedence. A reduced CABG is preferred in situations where you get multiple venous grafts that have failed together, and you have no patent graft to LAD. Obviously, you need a limit to LAD. If that has not been done previously, and LAD is diseased, obviously the patient gets a chance of a reduced CABG, and diffusely diseased venous grafts and low EF patients. And these are all features that we get in patients who have long-standing venous graft degeneration. Now, the flow chart regarding how to manage venous graft failure is first to qualify whether this patient is a candidate for redo CABG. If yes, and there is a need for additional revascularization like Lima to LAD that is feasible, obviously consider a redo CABG. If no, the patient is not a candidate for redo CABG for comorbidities based on Euroscore and other factors, then obviously native vessel PCI takes precedence, and whether the lesion is complex or not. If not, obviously native vessel PCI. If it is complex, then you have to judge whether your venous graft PCI is more complex or less complex. So if it is still complex and you're able to treat native lesion, then also you treat native lesion. If no option, then venous graft PCI, and you can stage your native vessel PCI in the second setting. Now, regarding guide catheter selections for venous graft cannulations, obviously there is a choice among the physicians, and depending on the anatomy, whether it is a right-sided graft or a left-sided graft, and whether it has an anterior takeoff or not. Your choices include multipurpose, Judkins right for the right-sided grafts, Amplas left, right bypass, and obviously for the more anterior takeoff, you have the AL and supporting catheters, maybe Judkins right, multipurpose or hockey stick. And similarly for the left also, Judkins right, hockey stick, and the others as mentioned. Now, the general considerations in venous graft PCI are that, as we just mentioned, always preference to native coronaries should be given if feasible. And if venous graft PCI is being done, to avoid balloon pre-dilatation. That means we always try to go for a direct stenting of such lesions to avoid no reflow phenomenon. And these embolic protection devices, although they are not in use appreciably, around US data shows only 1/4 of such patients get embolic protection device, but it should be used, and guidelines also endorse it as a class 2A indication wherever it is technically feasible and cost is not prohibitive. And microvascular vasodilators, particularly through your microcatheters or infusion catheters or export catheters, should be liberally used, preferably even before your stenting. And post-dilatation should be avoided. And if at all post-dilatation is needed, it should not be, balloon should not be oversized. It should be 1:1. And you have to perform a slow and prolonged stent and balloon inflation at nominal pressures, not above that. And you accept a slightly undersized stent, but a longer stent length to reduce plaque extrusion through the stent struts. And consider thrombectomy in lesions with a heavy thrombus burden. Keep the activated clotting time on the higher side, that means 300 above. And the dual antiplatelet therapy beyond your procedure should be based on the DAPT score, obviously, but you try to obviously treat this patient as a high ischemic risk patient and try to prolong the DAPT beyond 2 years if feasible. And these are all the filtered devices and the occlusion devices that we use to prevent the no reflow in form of the proximal occlusion, the proxys, the guard wire, the distal balloon occlusion, and we have the filters, the filter wire, spider, and the interceptor by different companies with all their specifications mentioned. Now, the role of embolic protection devices are obviously this in such subsets with a class 2A indication, and where the embolic protection is not available, there you can actually mimic a distal occlusion device by placing a balloon distally, inflate it, do your procedure, and then aspirate the entire stagnant blood column, provided you get the appreciable ischemia time lower. And this is direct stenting of the osteoproximal venous graft stenosis. As you can see, the stented portion is undersized, underdilated, but still acceptable. And this is a focal lesion of the venous graft, which was actually stented without an embolic protection device. The lesion length predicts the risk of atheroemboli and no reflow. And this case, luckily, got away without an embolic protection device. Now, if no reflow occurs with or without embolic protection device, obviously, if it is with embolic protection device, you have to close the embolic protection device carefully. And prior to that, you need to aspirate at least 20 ml of blood twice before pulling out the embolic protection device. And if you have not used, then intracoronary microvascular vasodilators like verapamil, adenosine, nitroprusside, or nicardipine that you use normally in the native coronary interventions, they need to be used liberally in such patients. And if there is a heavy thrombus and you need to debulk the thrombus, then mechanical thrombectomy with a large sized catheter like an angiojet or a CAT RX catheter, or aspiration thrombectomy through our usual Pronto export, or even guideline or guidezilla can be done. Laser atherectomy can be done. And there is no role of giving a GP2B3A in venous graft interventions. On the contrary, you can use bailout intragraft fibrinolytics such as TNK-TPA, tenecteplase. Stent choice. Now, obviously, we are left with the drug-eluting stents, but contrary to our conception, here drug-eluting and bare metal stents, they have trials have shown conflicting results, and both are equally effective and safe in venous graft interventions. And choice would be based on the lesion type, the diameter, and the long-term DAPT tolerance and adherence to medications. Now, a 1 or 2 line regarding the venous graft aneurysm. Venous graft aneurysms are also not that uncommon, and they can present as symptomatic in the form of either a rupture or a compression-related event, or fistulization, or they can be silent, detected by your CT coronary angiography or a direct angiogram. And then if this patient has a complication, obviously surgery takes precedence in form of ligation or resection. And if this patient also has a viable ischemic territory, then a redo CABG combines this emergency procedure. And if this patient has graft patency well restored, only the aneurysm is the issue, then they can be observed if it is less than 4 centimeters and patient is a high surgical risk. But if more than 4 centimeters and patient is not a high surgical risk, then you can go for a covered stent to treat the venous graft aneurysm. Now, take-home message is like CABG is being increasingly performed using total arterial revascularization or as a hybrid procedure of stenting the non-LED vis-a-vis minimal access Lima to LED grafts and the minimum need for venous grafts in the present era. Still, we encounter venous graft disease, and it might require PCI with its unique challenges. The current favored strategy is obviously PCI of the native coronaries, especially in long degenerated venous graft disease, as outcomes have been favorable for native vessel PCI. PCI is preferred over repeat CABG for early recurrent symptoms after CABG in patent Lima graft and amenable anatomy patients. So redo CABG is always a more risky procedure if your Lima graft is patent. And balloon predilatation is not recommended. Distal protection should be considered the standard of care in such patients. Intragraft vasodilators to be used liberally. To avoid post-dilatation, consider thrombectomy in patients with heavy thrombus burden and keep the ACT on the higher side, more than 300, and a prolonged DAPT more than 2 years if feasible. Thank you.
Thank you, Dr. Manandas, for excellent presentation. So you have to believe that is the native, taking care of the native coronary, which is more important than the venous graft treatment. So if it is the native coronary is available, is always better than the venous graft treatment. Any question from the floor?
That I just, yeah.
One size. If we have to imaging, we are in a better position to select a size. We may not post that unnecessary.
No, only issue is like imaging. IVUS has not had that much trial-based evidence, data-wise evidence. But they are small compared to the native vessels. Obviously, if IVUS is on board, it's very useful. True.
Prevent perforation.
True.
And to prevent unnecessary post-dilatation.
True.
Very good.
Yeah. Next thing, if the venous graft is total occluded, what is the result and how much role of intervention in this venous graft in the CTO?
No, if venous graft is occluded, then obviously we go by the flow chart that we just mentioned. Is that if native vessel PCI is feasible and this patient has a patent Lima to LED graft, then obviously we will go ahead with a native vessel PCI. The only condition in which such adventurous attempts of venous graft occlusion intervention can be done if this patient is unstable and native vessel PCI is technically challenging and will take time. So you can bail out this patient by opening up your venous graft and allow some time for a staged native vessel PCI at a later day.
Okay. Yes, that's good.
Perforation occurs since there's no pericardium.
Yeah.
So it's very
So it
difficult
is
to aspirate. How do
absolutely.
you manage such cases if there's perforation occurs during a venous intervention?
No,
So
if
to aspirate because there's no pericardium, the
No,
connection will be
actually-
just behind the left atrium.
yeah.
So it's very
So
difficult.
if these patients had prior CABG, so and there is a lot of adhesion, obviously the hematoma can be contained at times, but if it is a free hemorrhage within the pericardium, then obviously the same principle of native coronary perforation of inflating your balloon there and causing and draining your pericardium through your pericardiocentesis and auto transfusion should take precedence.
You have to try for that first a balloon tamponade. So balloon inflation proximate to the perforation, at least 15 minutes, even more, that is very, very successful, more than 90% of cases. Of course, if there is not control, definitely you take in the cover stent some extent. And if the cover stent, that the chance of restenosis is very high. That is the problem of the management of, because subvenous venous graft intervention really is separate animal. So many things is problem may arise. Okay, thank you, Dr.
There will be more chance of bleeding outside the pericardium, isn't it?
Yeah.
Yeah. So that, how do you tackle that?
No, that is obviously through the lumen itself by balloon tamponading and as just mentioned, and putting a covered stent because and absolutely. Then you have to obviously call for surgical help too.
At present, the availability, the phenomenon, of course, if you thrombus, restoration is very good. Otherwise, organic thrombus, it will not be successful at all. Okay, thank you, Munna.
Thank you so much, Dr. Munna, for your contribution to Eiicon 2023. Now we move on to the next topic of the same session, the next topic being ISR, and the speaker will be Dr. Prithviraj Bhattacharya. So we request sir to please take over the stage as of now, covering the topic ISR, the session being potpourri.
Thank you, respected chairpersons, my dear colleagues. So instant restenosis, if we look at the study from US, we can see that it happens by 10% of total PCI in the last 8 years of US study. And from Europe, from France study, we have seen that the ISR PCI approximately 7% of total PCI numbers in Europe. And this still remains the preferred modality of treatment, and definitely the outcome of ISR PCI in terms of target lesion revascularization is worse than non-ISR PCIs. Coming to the angiographic classification of ISR, you can basically classify into two types. One is focal and another is diffuse. Type 1 covers the focal types of restenosis, whereas type 2, 3, and 4 covers the diffuse type of restenosis, and diffuse restenosis usually results in more target lesion revascularization either by PCI or CABG. And current classification of ISR, the etiological classification covers the mechanical issues, the underexpansion and stent fracture, biologic issues like instant hyperplasia, neoatherosclerosis without calcification, and neoatherosclerosis with calcification, mixed pattern, chronic total occlusion, and more than two layers of stent involvement. And according to the classification, the treatment options may differ. From human autopsy studies of drug-eluting stents, it has been found that two factors are very important in multivariate analysis. That is the number of stents. The number of stents is used, total length of the stented segment, and the minimum interstat distance, the maximal interstat distance. These are the two factors which can predict the rate of restenosis in future. Other factors also include the medial injury by stent struts, the number of inflammatory cells around the stent struts, and lipid core penetration by stent struts. So after the development of DES, we thought that we have tackled restenosis, but we are already 2 steps back, because with DES implantation, the neoatherosclerosis has been found to be earlier and more severe compared to BMS. Whereas in BMS, the neoatherosclerosis is usually absent before 2 years and almost very low before 4 years. And in case of sirolimus eluting stent, new atherosclerosis is found at as early as 9 months. Another important factor in late-stage stenosis is strain strut fracture. It is important to identify when we treat such lesions. Coming to the image or imaging, OCT is very helpful, not only to diagnose the pattern of stenosis, but also the optimization of ISR PCI. We can see the homogeneous bright uniform layer, which corresponds to neointimal hyperplasia. When there is a heterogeneous composition with instant necrotic core, it actually predicts to new atherosclerosis, and stent under expansion can be clearly identified by OCT. Looking at early versus late instant stenosis, the study shows that in second generation drug-eluting stent, the patients who had early ISR, less than 1 year ISR, main culprit was the minimal luminal stent area. Minimal stent area was less. And patients who had more than 1 year of duration after stent implantation, mostly culprit was neointimal hyperplasia. So these are the two factors, early stent stenosis. So suboptimal stenting is the most common cause, and late stent stenosis, neointimal hyperplasia or neuroatherosclerosis is the likely cause. The focused update of ESC from 2017 has identified from some high-risk factors, prior stent thrombosis, stenting the only remaining patent coronary artery, diffuse multivessel disease, specifically in diabetic patients, chronic kidney disease, at least 3 stents implanted, at least 3 lesions treated, bifurcation with 2 stents, total stent length more than 60 millimeter, and treatment of a chronic total occlusion. These are all factors which can give rise to ISR. Imaging has, as we have told, that it's a very various roles in managing ISR. It can detect the age dissection, neointimal hyperplasia, neoatherosclerosis, late acquired malapposition, under expansion, and stent crush. And imaging should be basic. The class 1 indication for ISR strict PCI. Based on OCT appearance, ISR can be classified into 4 groups: homogeneous, where is uniform high signal density, low backscatter, typical areas of high smoothness of muscle cell content. This is mainly characteristics of neointimal hyperplasia. Heterogeneous, mixed signal density may represent presence of proteoglycan-rich neointima or neoatherosclerotic plaque. Heterogeneous and layered are the 2 classifications which are mostly found in DES stenosis. And comparing bare metal and drug-eluting stent stenosis, you can see diffuse pattern of stenosis is more common with BMS, whereas focal pattern is more common with DES. And time course of late luminal loss, late loss is maximum by 6 to 8 months in case of BMS, whereas ongoing late loss may occur even after 4 to 5 years after implantation of DES. And neoatherosclerosis is relatively infrequent or late in bare metal stents, whereas it is very frequent and accelerated course in case of DES. So factors considering when performing an ISR PCI, you have to identify the stent factors. You have to identify the intrastent factors like neointimal hyperplasia, neoatherosclerosis, presence of calcium or thrombus, hetero or homogeneous tissue, focal or diffuse pattern, and extra stent factors include multiple stent layers, vessel calcification, calcified nodule, vessel size, and residual plaque burden. Different studies involving the balloon angioplasty, bare metal stents, intravascular brachytherapy, rotablation, cutting scoring balloon, drug-eluting stents, and drug-eluting balloons have been performed in this subject. And what is the essence of these studies? Specifically, it has been found compared to balloon angioplasty. If you do angioplasty with either drug-eluting stent or drug-coated balloon, it gives better result. And compared to plain drug-coated balloon use, if you use prior scoring balloon before applying drug-coated balloon, it gives even better result. And comparing DCB to DES, it gives comparable results, and DCB is by no means inferior to DES in treatment of instant stenosis. So basically, the principle is to treat the ISR lesion, you first define the lesion, identify the culprit lesion, assess the lesion length and severity using orthogonal projection, use IVI liberally, prepare the lesion properly, routinely predilate all the lesions, use high pressure cutting scoring balloon, address all the mechanical factors, and ultimately treat with, in case of DACE ISR, you can use another DACE or DCB. In BMS Hyper, DCB is preferred choice, or you can use another DACE and finally assess your result with IVI. So this is a case of 61-year-old gentleman with diabetic hypertensive with stable angina and long segment disease, calcified disease in the LAD. It was rotablated with a 1.75 rotab bar, and we achieved a good final result. But the patient came back after 2 years with symptoms, and we found a focal restenosis in the distal part of the LAD. You can appreciate the hinge motion there. And after proper stent boost, we found a stent fracture. So that is the mechanical cause of instant restenosis. This patient ultimately went for bypass. The second case, the 62-year-old lady, diabetic, ACS PCI in another hospital. He presented after 3 months with STEMI and echo showed hypokinetic IVS. And this is the angiogram. You can see the proximal part of the LED stent. There's a lesion, and probably there is a under expansion of the stent or undersizing of the stent. So we did an IVAS, and definitely we found the proximal area of the stent is definitely has very low minimal luminal area. So we predilated that stent with a Scoreflex balloon of 3.5 into 10 and applied a sirolimus eluting balloon 3.5 into 35 and had a good result. The patient is doing well. The third case is a 56-year-old gentleman, diabetic hypertensive, guilty of history of multiple PCI, presented again in May 2017 with angina with normal LV function. His LAD and circumflex stents were patent, but there was disease in the RCA stent and distal part of the native RCA. So at that time, imaging was not done. 2 long everolimus eluting stents were put in the RCA overlapping the first stent. The final result was good, acceptable, but after 1 year, the patient again became symptomatic and he developed multiple focal restenosis. You can see the long length of stents here. So that was the cause here. We did an IVAS here, but unfortunately, I don't have the image. We went with a high pressure scoring dilatation in the throughout the stented segment and ultimately give drug-eluting balloons here. 2 drug-eluting balloons of 3 and 3.5 were used, and we achieved a good result. The patient was doing well until 4 years, again came back in August 2022. This time there was again some disease in the focal part, focal lesion in the middle of the RCA, again another restenosis. And we did a high pressure dilatation with NC Scoreflex and put another sirolimus eluting long stent in the proximal part of RCA. But after putting the stent, you can see the stent is under expanded in the middle portion still now. So IVAS showed there was multiple stent layers and some focal calcifications there. So we post-dilated at 3.5 into 826 atmosphere pressure. The balloon now nicely opens and we had a good final result confirmed by IVAS. So my take-home message is ISR accounts for 5 to 10% of all PCI, and new generation DACE have relatively reduced the rate of ISR. Increasing procedural volume and complexity of lesions result in higher absolute number of ISR in the modern era. In majority of cases, DACE or DCB remains the treatment of choice, and IVI provide useful information to guide the treatment. Thank you for patient hearing.
Thank you for excellent presentation. You rightly point out the incidence of the restenosis. You see, when they are at a plain balloon, that time 6 months, 30%. And then when the bare metal stent, the 30% reduced to 15%. Now, because of the DS, now reduced to 5%. So gradually development of this, because of the biological process, restenosis mechanism, and the mechanical process, rightly point out. The question of that, nowadays, drug-coated balloon is very useful. If you prepare the bait by the cutting balloon and the NC balloon, followed by the drug-coated balloon, if the lesion prepared, the drug-coated balloon, in my opinion, I commonly use for the management of the drug-coated balloon in all cases.
Exactly.
So how do you decide where to put a DAB and where to put another stent?
Yes, sir, that's a very important question because in nowadays, most of the restenosis we find is with DACE. BMS already I think we have stopped using for last 8 to 10 years. So most days stenosis, if it's a long segment diffuse disease, we usually like to put stents on and balloon together. If it's peristent stenosis, the lesion extends beyond the stents. You have to cover that lesion with a stent, and in the stented part, you can use a DEB. If it's a focal lesion, DEB is definitely the first choice.
If there is stent fracture,
If there is stent fracture, a mechanical correction has to be done. We have to see why the stent actually fractured. If there is any issue with the vessel motion, vasomotion. In my first case, there was definitely hinge motion. So we thought if we put another stent there, if there is another risk of fracture, we leave the patient at risk. So that patient went for CABG. So it has to be individualized for every patient. What is the actual cause of stent fracture?
Thank you, Professor. Another important thing, you have to diagnosis of stenosis and is also caused to be evaluated first by the IVA study. Whether under expansion, or whether the associated calcification or associated new atherosclerosis, that should be diagnosed faster. Depending on that basis, you have to take the decision for management of the instant response. Thank you very much indeed.
Thanks.
Thank you so much, Dr. Bhattacharya, for your contribution to EIS Eiicon 2023. Now we move on to the last topic of this particular session, and to speak on this particular topic, may I request Dr. Pankaj Manoria to please come up on the stage, and the topic being PCI of ortho-osteal stenosis. So we will be having this last session of potpourri, and then we will be having live sessions. So over to you.
So good afternoon, everybody, and greetings from Bhopal, the city of lakes. At the outset, I'm thankful to the entire organizing committee, Dr. Hajra, Dr. Soumitra Kumar, for inviting me to deliver my views on this very important topic. We know that aorto-osteal lesions are very tricky. Tricky for the matter that sometimes defining these lesions are very difficult. What angiographically it looks significant might not be significant, and vice versa is also true. Secondly, these lesions are very rigid and fibrotic and have a tendency for elastic recoil. So preparation of bed for these lesions are equally important. And finally, treatment is also difficult. Sometimes they may be geographical miss, placing the stent at the correct at the ostia, sometimes difficult. You may protrude too much or you may miss the ostium. So all these three factors are very important. That is why my approach to aorto-osteal lesions is always define the lesion, prepare the lesion, and treat the lesion. First of all, define the lesion. I'll share a few of examples. This was a gentleman, a doctor by profession, who was diagnosed as a case of left main osteal disease and was advised CABG. And when we repeat the angiography of this patient, it was borderline lesion. We were not sure why this patient was advised CABG. Is it critical or not? So defining this aorto-osteal lesion was very important. And the best way to define this is by doing imaging and intravascular ultrasound, or HD-IVUS is very useful for evaluating aorto-osteal lesions. When we did an IVUS in this patient who was advised CABG, the MLA at the ostium was around 6. Whenever the MLA is between 4.5 to 6, if it's less than 4.5, surely revascularization is a strategy. More than 6, it's conservative. Here's around 4.5, it's 5.5 to 6. So then the second step is to evaluate by doing physiology testing. When we did the resting physiology parameters by DFR, it was 0.096. Unless the value is less than 0.89, we don't send these for revascularization. We did an FFR also, which was again negative. It was around 0.95. So clearly, when we defined the aorto-osteal lesion in this gentleman who was advised CABG, we could clearly assess that this lesion is not significant and medical treatment is sufficient. So defining these aorto-osteal, first step is very important to define these aorto-osteal lesion. Second case, another case of a 71-year-old gentleman, diabetic, hypertensive, angina on effort. He was in medical treatment. And when we again did an angiograph of this patient, again, aorto-osteal lesion we found an aorto-osteal lesion. Again, we did an IVUS. Again, we found that the MLA was around 5.8. Again, intermediate zone. Again, we did an physiology testing also, but this time you can see the resting parameters was less than 0.889, it was 0.83. And also so since it is showing significant ischemia on the physiological testing, we went ahead and did the angioplasty and stenting to the left main ostia. And this was a pre-PCI MLA of 5.86 and a post-PCI MLA of 13.12. So defining these lesions are very important. The last case again a borderline lesion, LMC osteo lesion. We have a very separate group of imaging group in which I posted this image, and almost you say 11 out of 15 votes said it is significant on based of angiography. But when we did an IVUS, again, we found that this lesion was not significant. The MLA was 8.74. So almost 11 votes for angiographically, it was looking significant to all the major faculties, but it was not significant when we do an imaging. So imaging is a must to define these aorto-osteo lesions. The second is preparation of lesion. As I've said, that these lesions are very fibrotic and they have a tendency to recoil. So preparing these lesions before putting a stent is very important. And the best way to prepare these lesions is by using a cutting balloon, which causes a uniform expansion vis-a-vis an NC balloon, which expands at the least resistance area. So cutting balloon, the blades, putting at the right area and preparing these lesions are very, very important. Just to give you an example, this was an aorto RC ostial lesion. And this you can see that very tight fibrotic lesion at the RC ostia. So what we did we prepared it with a cutting balloon, did an IVUS, and once we found that a good cutting balloon has done a very good job, then only we put a stent. So all the images are very important before, after cutting balloon and post stenting. So if you've done a good work after cutting balloon, then only we should put a stent. Otherwise, expanding these undilated stents in these ostia may be very difficult. So cutting balloon is a very good modality to prepare these aorto-ostial lesions. And sometimes also these lesions may be calcified. So doing a rotablation in an osteo lesion is very, very challenging. What we need to do is sometimes we take care of a extra support rotor wire and we need to disengage the guide slightly until we are not ventricularized. And we should start rotablating sometimes with the burr inside the guide to really rotablate that ostial lesions. So finally, when it comes to treating these lesions, now the main is selection of guide catheters. For aorto-ostial lesions, less aggressive guide catheters like Jutkins are recommended to avoid deep engagements. And also it helps us in disengaging the guide during stent implantation. So if you're using a backup guide, sometimes it may damage the ostia further, it may cause ventricularization, and also sometimes pulling and pushing these backup guides are not easy. So best guide is to use Jutkin guides in these aorto-ostial lesions. Also, if there's a distal lesion, always the distal disease should be treated first. Side hose catheters we no longer use because it gives a false sense of security. So we don't longer use. And also for intervention on aorto-ostial lesion, a very tight aorto-ostial lesion, it's better to preload the wire when we are inserting the guide, because sometimes patient may land up in a ventricular tachycardia or hypotension. So it's better to preload the wire when we are engaging these guides in a tight aorto-ostial lesions. And again, a very important or a very important step in treating these lesions is to avoid geographical miss, because sometimes putting a stent exact at the ostia may be difficult. We may miss the ostia sometimes. So best is to take proper angiographic views. We have various techniques also, which I'll describe in my coming slides. Floating wire techniques is being used. A partial balloon inflation technique has also been used. And sometimes we use an adenosine-induced temporary block to stabilize the motion artifacts. And also imaging is very, very important to assess whether we have done a good job and we have covered the ostium or not. So in best angiographic views for a aorto-ostial stent placement, for LMCA is shallow alveolar. That means LO 30 to 10 degree and a cranial against 10 to 30 degree. And for right coronary artery, the best view to assess ostia is to make it very horizontal. And that is possible if we increase the LO by 45 to 60 with some caudal angulation. So these views should be kept in mind for a proper assessment of the ostia. Because if we are not making these views, we will not be able to define the ostia correctly and we may miss the ostia. This is just example. This shallow alveolar is the best view to assess the LMC ostia, not the caudal view. There's one more technique, the partial balloon inflation technique. This is we inflate the stent at 1 or 2 atmosphere and then again recheck whether we are covering the ostium or not. This will stabilize the stent, and also we have some space left to pull the stent also if it is not we are not covering the ostia. So slight 2-3 millimeter, and then I can reassess, and we can pull a push stent also if it is not covered. So this partial balloon technique is sometimes useful to proper place the stent at the ostia. Also, there's a sepal wire technique or a floating guide wire technique. That means we are putting one wire in the coronary or in the aorta ostia, which is hanging free, and which is useful for two reasons. First of all, it also acts as a landmark for the ostia, and also secondly, it prevents the guide from pushing in during the stent implantation. So it serves two purpose. So floating guide wire technique or the sepal wire technique is also very useful sometimes to assess, to define the ostia and place the stent and prevent from missing the ostia. Also, sometimes when there's a motion artifact, the stent is moving very much, we inject adenosine, which causes a temporary asystole for a few seconds, and that few seconds we may utilize for placing at the right at the ostia and prevent them and nullifying the motion artifacts. This has also been reported and sometimes very useful. So all these techniques are very useful to place the stent right at the ostia and preventing a geographical miss. Also, once we have done, when we implant a stent, an imaging is very necessary to identify for two reasons. First of all, whether we have missed or there's a geographical miss or not, we have covered the ostia or not. And secondly, once we place these stent at the ostia, there's a chance of doing longitudinal stent deformation during post-dilatation. So always once we have finished the job, do an IVUS to see that that aortic segment, we have not done any longitudinal stent deformation at that segment, because this is one of the precursors for restenosis in the future. So I'll elaborate on a few of the cases. To assess whether we have placed a stent right from the ostia is, two views are important. Above the short axis view, just start seeing the aorta. And if you are seeing the stent starts, that means you have covered the ostia. You can take also the L view, and that this is the L view, identify the aorta, and here you can see two studs are behind the aorta. So make use of both the views to assess whether you have put the stent, you have covered the ostia or not on the IVUS. Just to give you an example, how important is this to make sure that you have covered the ostia or not. This was a acute inferior MI setting. This is before BTCA, and this was after doing a angioplasty. The stent was placed right from the ostia, but IVUS was not done. What happened is, after 3 days, patient landed up with acute stent thrombosis, subacute stent thrombosis, with again re-ST elevation and complete heart block. And when we did the final procedure and assess what went wrong, and we clearly find that we missed the ostia. In that case, this was the reason of stent thrombosis. So after doing a stent at the ostia, an IVUS is very mandatory to confirm that we have placed the stent right at the ostia, because sometimes angiography may be misnomer. We may not be able to identify correctly whether we have placed the stent, covered the ostia or not. And IVUS is a very boon in such cases. This is a real example of how IVUS was very useful, and that clearly suggests that we missed the ostia, which led to subacute stent thrombosis. This time we covered the ostia and make sure we did an IVUS. Thus we see clearly this is the aorta. We have stent studs are behind the ostia. So this is very important, an IVUS, to make sure that you have covered the ostia. A second important aspect is to assess whether there's some longitudinal stent deformation in the aortic, in the lines, in the hanging segment of the heart. This was the final pullback which we are doing after putting a stent, and this we identify this multiple stent studs are visible. When you see multiple stent studs in the aorta, in the ostia segment, that means this is a longitudinal stent deformation. Then you need to rectify it. If you don't rectify it, this is a nidus for stent thrombosis and nidus for restenosis. So this is again a very important thing which we must look into whenever we're doing any aorto-ostial interventions. So finally, just to summarize, approach in aorto-ostial lesion should be to define the ostia correctly, prepare the lesion, and finally treat the lesion, and always do a good imaging to see whether you have done a good job or not. Thank you.
Okay, Pankaj. For a problem of our country, definitely the ostial is a great problem for many men. In our country, particularly in young females, if there is coronary disease, ostial is more common, particularly Takashio arthritis, because of inflammatory disease which extend from the aorta to the Apart from that, osteoarthritis and arthritis, other branches also involved. Of course, it is rare. But question of that is regarding the pain with the patient osteoarthritis critical along the LED or circumference, how will approach the management? How will treat this thing? Because
Yeah. You asking? I didn't get the question.
osteoarthritis along with the circumflex or LED,
Yeah.
how will manage the
Yeah, it depends upon, what I do is I do an imaging in both the vessels, assess what is the plaque burden in the side branch, what is the length of the disease, and then define my strategy. If the plaque burden is more than 70%, the disease is extending to more than 8 millimeter long stent segment, then I'll do an elective double stent strategy. If the short segment is involved, short disease, plaque burden is not much, I will do a provisional stenting and then reassess, do a final casing, and then reassess the side branch. If the final result is good, then I may go with the single stent. But if I find after doing a crossover, the second branch is significantly pinched, with significant ischemia, both on angiographically as well as clinically or on all imaging, I may put a second stent.
So to believe that you have to initially you have to place the particular floating wire in the aorta up to the left subclavian to prevent the blocking of the ostium. That's
exactly.
number one. Second, you have to dilate the ostium with a 2 millimeter balloon. Then subsequently 2.5 NC balloon. Then when you sappy, that is the ostial is fully dilated, then you proceed for the other branches.
Yeah, and apart from the osteoarthritis, severe pulmonary arterial hypertension is one of the causes of ostial left main, ostial left main stenosis. People have been subjected to CABG and blockage of the graft after treatment of the pulmonary hypertension.
Exactly.
So thank you very much, Pankaj, for the nice presentation. We'll have the live case after this session. Thank you, my coach.
Thank you so much, Dr. Minerva, for contribution to Eiicon 2023. I will request everyone to please stand in front of the stage so that we can have a picture perfect moment. I will extend my thanks to all the panelists and to moderator. So I request everyone to please, like every speaker of this particular topic, to please be here so that we can have a picture perfect moment. Ladies and gentlemen, now we move on to live case number 13, which is straight from Fortis Hospital. And the session will be left main bifurcation. And with that, we will be having the presence of the following chairperson in the panel. I will request Dr. P.C. Mandal to please come up on chairperson panel. May I request Mr. Dilip Kumar to please come up on chairperson panel. Requesting Dr. Arunangshu Ganguly to please come up on the chairperson panel. Along with that, we will have the following personalities as a panelist: Dr. Munna Das, Dr. Ashit Das, Dr. Somnath Mukherjee, and Dr. Basabendra Chaudhary. I will request the following excellencies to please take their seats in the staging area so that we can start off with the live session. I will request the technical team to get us in touch with the Fortis Hospital for live case number 30. And the session will be left main bifurcation. But the operator, we just have the live feed here, and the operator will be Dr. Shubhanand Ray and Dr. Sanjeev Mukherjee. Over to you, sir.
Shubhanand, Dr. Pandey here. Yeah, so you are live. So you present your case. Yeah, ask your cameraman to remove this eye in some other angle because blocking your view. Or you project the fluoro image onto the main screen. Yeah, show us the fluoro on the main screen, please. Yeah, right. Now we can see.
Can you see the monitor now?
Now we are seeing.
So, I'm going to inside the
Your right coronary artery is normal. Okay. We are seeing the old angio actually. Right. So you put a two stent, one into the distal and one in the proximal.
And now this one, which was the first stage was released last year. Even though I was trying to that.
Right.
Can you improve the audio quality, technical stuff, please?
Now you see that you can go there also and see. Give me another way. Give me another way. So now we are dealing with the lesbian bifurcation. It is 1, 1, 0. And this plan is to go and to transfer learning to our games to go to the AED to the and then
So you are planning to do IVAS?
yeah. It is very tricky running of the already. So And it is calcified, sometimes it becomes difficult to.
Show us the floor, please. We are seeing the IBUS. Right.
So the calcium is, okay. Now we will go. Now we go. Okay.
Yesterday. So this patient is on which antiplatelet, Dr. Roy? Oh, clopidogrel.
Yes.
Any reason for not using the ticagrelor or prasugrel?
So also this, Indian gentlemen, they developed LPI in the beginning, so are going to that. And particularly every that, so I found that agree. And you can see the argument now. The
Yeah.
sister moves around 1 to maybe 2.5. And there is some amount of calcium in the sister energy, but yes, if you have to test this plant, you can see what they have to do. Now we are in question continuity in the need. And you see that there is time disease with the calcium models and also
IBUS picture is not visible. Show us the IBUS. Yeah, okay.
And this is the movement and also the individual. And again, this is the movement.
So the
So
the proximal LED was around 3.5 and the distal was around 2.5. Yeah.
So, our plan is to put, as we have the significant background, we will do it,
Okay.
we will be using different data lab, data lab, register data lab. We don't have the that means we are related to the data lab. Share table as well as it does not have a form that although it is a mathematical, but this product value, there is a new computer who wants to the answer and interpret study. So I present some of the now. Yes, some of the and there is no value to the value. Now, initially, I was found the microprocessor and choose that was good value. But somehow, this value start to wonder that you can build a business and then use the ground with one level.
Yeah, but you had a difficulty in taking workhorse wire in the LED.
So I have wanted a video.
Can someone show the packet insert of this rota wire? Yeah.
Because I'm thinking about that, we don't have that. Okay.
See, your wire is in diagonal or LED?
What was the luminal area of distal LMCA in this patient? Distal LMCA?
Was around 6, I think. Yeah, doctor.
LED is 3.5. So why not take a 1.75 or at least 50? The ratio should be 0.5, not less than 0.5. Sometimes 0.6 also we take. So
I feel he'll burr at the point of this die. Distal hill burr. Yeah. Your tightest lesion in the LED was after the diagonal or before the diagonal? Before the diagonal. Okay.
Sumanan, your picture, angiographic picture is very cloudy. Is it possible to improve it?
How many? Not from machine. They are taking with the camera. So. Your wire is into the smaller twig.
So we're done. Okay? And coming out, Okay.
Which rota wire? Yes, I was not.
I have to ask about rota wire.
Yeah, yeah.
Now, are you using Rota Pro machine or the conventional Rota?
Dr. Roy, is it a Rota Pro or Rota Link? Rota Link and wire, we are not clear. Just tell once again, what is this good wire? Rota Glide.
Is it the same 0.09 at the back and 0.14 at the tip?
And the tip is 0.09, just like other Rota wire? Oh, so it's,
Can we complete the angioplasty on this wire also?
yeah,
Can we? We don't need to exchange the wire. Angioplasty also.
yeah. It's so slippery.
That's a good. We can place a stand also.
Yeah.
Not much. That's a very.
Where I was, using my finger for calculating, now I can do it 12 times, then go now, because the sleep part, after that, we will round to it. Not go. Anyway.
Let him just fix the wire only. There is actually acute bend at the LED.
Can you please improve the audio quality from the cath lab? From the cath lab side, improve the audio quality.
So you'll be doing stenting also on the same Rota Glide wire or? Okay. Okay. And this is what a Rota Glide is like extra support wire or? Okay. Oh.
At the experience of driving a car, I think rotor drive I can drive. Wait, what? It's so good.
Yeah. Is not connected to the
So give me a word, give me a balloon. I will. This is an AC study around 2.5.
Okay.
Then why would I take you change the driver bar. You can see that movement is something we have. And it's fragment the without even have inner segment of the army. But the mission is that the mission is what is the power bar. So I change the driver bars to the diagonal and so that the bar moves towards the outer wall of the artery. That's what we did with the party. Okay.
Yeah, after this, yeah.
And you can see that there is a cracking of the test on that.
Yeah, just after the diagonal, you have also a significant lesion in the LED.
So
This is what, 2.75 you said? 2.5.
These are European area. So it is one. So we will go down here. Okay, done. You will open nicely.
Yes.
So we are doing the 2.5 into something is similarly. Then we take I don't come out with the root of it. We're going to share it. Then nothing the data is going. Okay, I think I will. Yeah, this is I will.
So what length of a stent you are choosing for this distal one?
Huh?
Length of the stent you are taking?
I am the reason for the reason of that really. So that I will tell you the system. Now, you don't get that, no? So I need to just say from the digital reality to the visual reality.
Yeah.
This will be a 2.75 into something energy. Thank you. You can go ahead and down. Yeah, do that.
So you're going to take one stent for left main to LED and another one for the mid LED. That's right? Okay. What is the ACT like?
So, putting on here. Going. It needs a little bit of elevation there. I think it's crossing the then.
Yeah. I think you take a body wire, it will go. It was almost there. Sangamitra.
পরের কুইজ সেশনটা কি এর পরেরটা কুইজটা কি আছে দেখে নিন আমি একটা স্পিকিং লাগে ওয়্যারও দেখে দেন
You have to go a little bit more where it was getting obstructed here. What do if your stent doesn't go? You dilate further.
Yeah. Body wear helps. Sometimes dilatation helps. Then of course you can.
Yeah, now it will go, I think.
Usually we have problems in doing the wear. So sometimes it happens.
So you have to put the diagonal wire into the LED. That's the.
Yeah, I know that. The wire is on.
Sometimes patients' respiratory movements also help.
No. Just take the stent back a little bit and put the wire into the LED. It will change the wire bias. Actually, there is no shape into the diagonal wire. Just give a shape.
নেক্সট কুইজের জন্য কি আছে রেডি
বলে So Shubhananda, we have got 8 more minutes. We hope, yeah.
Yeah, it's quite maybe 24. Ah, 25.
Just go to heliocranial. Just change the angle. Heliocranial. Yeah. No, no, just change the angle a little bit to the heliocranial. Yeah, now it's technical.
Give me another 5 minutes so that we can put two steps on everyone.
Yeah, we have got 5 minutes. Don't worry.
What is your opinion regarding IFAS or OCP? What will help in these cases where bias is there? Or
No, IVAS was already done. Actually, we have to see was there any wire bias or not.
Yeah.
You see, it just walked in. Actually, there is specule just opposite the diagonal margin. So you remove, yeah, that's fine.
Now you can now there. Okay.
Right. Yeah. Okay. Good. Yeah. So you are going to take 3 or 3.5 for the. Okay.
Take a shot and then I come out with that. I don't think that I very take a shot. Yeah, that's it. It's about result. So we will go and then keep it at the city.
So take 3.5 into 16. Three times of this. So Dr. Roy, we have got 1 more minute to go. Probably we'll go offline. And we can continue? Oh, okay. So great. We'll remain with you for another 5 minutes. Great. Show us the RAO or some other view.
Now, we did our so, it is a thinking. It is a step. Master, transferring,
What is the length you said? Will it not be too long? You are not going from the left main ostium. Are we going from left main ostium or no? Then 32 is too long. Just show the last NGO, last cine you took. Just run it. It's not more than 24 millimeter. You take around 24. 32 is too long. You don't want overlap of 10 millimeter. Yeah. Take 24.
So, these are the problems we have now.
No, you balloon dilated. You can have some idea. The initial 3 millimeter balloon. Yeah, even 21, 22 will also do.
Or, I'm sure. 24 is the right side. Anyway, we are taking 380.1.
Yeah.
We can use space for the ball, you know.
Yeah.
There is a picture by taking a little longer than.
Yeah.
Right. If you just there goes.
Go to the caudal view, just have a relook.
Is okay? Final?
You don't want to go to the ostium?
Because I what, first of all, I need to see where my place is actually, where is lower and on.
You have an overlapping of around 6 millimeter. You can place at the ostium also here. Yeah. 1 millimeter.
So we went up to this, and then we go out to the 40 we go to and go further.
With the same balloon, you could have done the part of the distal stent. Distal stent, you have not post dilated, proximal to the diagonal. Yeah.
Nowadays, some people are not coming to the exactly at the LHC or because of two things. Number one, nowadays the states are going stars will get the chance of mountain talking. When you put the stem actually as a ostium, and at the same time, sometimes we become, difficult to enter the
Yeah, you are fine.
So, when the outside, I need to go and see the. No. So, we did the core. Now we will go to the circumference and we have to do 3.5 into the moon and go there. First you go up and then come to the east star, and you will see that after that you are
Absolutely.
Okay, fine. They give you the
How are you so sure that you have crossed through distal strut? Yes, it came back from LED, but you cannot for sure say that it is through distal strut. It's just assumption.
So after post dilatation, so was the IVS also. So the positioning of the balloon is important when you are doing pot.
Yeah, very much.
Christian Dubera, are you around?
We will read our recipes, so we are want to want to keep the and you're finishing.
So what is your expectation for MLA proximal LED? 9, 10, yeah. So 14 left mean around 10 for LED. Yeah, it's a fantastic result, yeah.
So, you know, what I'm saying is, you need to change the class, and that's why you know when and I like broadly directing the business with guided and nicely, and also the plant was updated gradually. So between the I'm not sure for the just there is a camera there, always we need a program doing so it's not going on. Okay, from there we can go down.
Yeah, just so from there only, yeah. So you are having almost 2.8 millimeter vessel at this. One five. So circumflex wire is from the actually the distal strut. Probably the left main will need some more dilatation. So do it with the, yeah, so emulate, just tell us what is the proximal LED.
Huh? 35.25. Listen.
Yeah, I said it. Come back. This is it proximal?
No, I think
This is the mid LED probably.
Thank you very much
Yeah.
for giving me the time.
Yeah, yeah. Thank you, Shivananda, for showing how to do a left wing bifurcation, left wing bifurcation in the same case. So thank you for great demonstration. So we are going off. Thank you. Okay, very good. So 14.8.7. Oh, okay, Shivananda, see you. Yeah.
Thank you so very much, and thank you to the panelists here. Thank you so very much for your contribution. Now we move on to the next session, but before moving on, we will have the picture perfect moment of the day. So we'll request all the dignitaries to please be in the front or basically in the middle of the stage so that we can capture this moment forever as a Smriti, you can see as a memory of Eiicon 2023. Thank you so very much to all the dignitaries. Now we start off with the Cat Lab nurses quiz. So I request all the nurses to please be in the front row. And along with that, I will request everyone who has put down their coupon here. We will be starting off with the lucky draw in the Victoria Hall in 5 minutes. So we will start off with the lucky draw in 5 minutes in Victoria Hall. But as of now, we start off with the Cat Lab and Nurses quiz. And this quiz will be, in short, the quiz master of this particular session will be Krishnendu Beda. So can we have Krishnendu Beda on stage? Because yesterday we really had great time. If you are in touch of with the technicians, you know that they have 115,000 rupees from here. I do not know the prize amount or the prize today here, but all the best to all of you here. May the best win. Try to answer as quickly as you can. But there are rules that I will be guiding you through. Rule number 1 is you cannot shout out the answer. You have to raise your hands. We have a spotter. She will be like the ultimate authority will be with sir, but she will be spotting whoever has put their hands up first, and then sir will pick, yes, she has done it, or else whatever it is. At the end, for example, there are 10 questions, and the maximum number of right questions one answers will get the prize. Okay, so it is not कि एक question का एक answer दे दिया और आपने prize जीत लिया. No, this is a cumulative one. At the end of the session, the one with the maximum right answers wins. So scoring will be 1 correct answer, 10 marks. Okay, so this is a scorer and spotter. Over to you, sir.
So these will be more or less open questions. So whoever knows the answer will raise the hand. Whoever raises the hand first will answer. Then the second person, if she answers wrong, then the second person will get the opportunity. And if she answers correct, then okay. So there will be around 14 to 15 questions that I will be asking. Mostly those will be from ECGs, X-rays, and a few echo images. You should be, as you are working in the cath lab, you are a pivotal part of the cath lab, so you should be knowing these things. There's very basic images that are there. Okay. There are also questions will be in parts. I mean, 2 or 3 parts question will be there. You can also answer like that. So he's a 60-year-old man. He's a smoker since 30 years. And he has presented to emergency with chest pain since 4 hours. So what is the ECG showing and what is the next step? Okay, right. Okay, right. And what is the next step you will do for this patient? Okay. So if we suppose she goes in a rural hospital where PCI facility is not available. And
refer to a bigger hospital.
you should also give thrombolysis if there are no contraindications. So we will give her that she has answered that correctly. So what is happening here? What is the ECG showing? A 54-year-old man, he is diabetic, presented to emergency with abdominal pain, vomiting, he is disoriented, and he has a CBG of 590.
Hyperkalemia.
Now,
Inferior wall MI.
incomplete answer.
R maybe.
No. Look at the keywords. Inferior MI with AV dissociation is there. And what this inferior MI has specified is decay is present. He has presented abdominal pain, vomiting, and CVG of 790. Inferior MI precipitating diabetic ketoacidosis. So we can give her marks. He has diagnosed partially right. Okay. So tell me what this is. No, sorry, not this. This one. This is more specific. Why? Well, ST elevation is also there in B1, B2.
B1, B2, and through subtle.
No.
Lateral.
This is anybody else like to? Inferior wall MI, lead 3 elevation is more than lead 2 and with ST elevation in B1. Do you know what that ECG suggests and what other leads you would like to take in this patient? Will you like to take, I am giving a clue, right-sided leads for this patient? B4 or B5 or? And why this patient has BP of 80/40? No. So no one is answering correctly. This is inferior MI with RVMI. ST elevation in B1 with inferior MI with ST elevation in 3 more than 2 goes in favor of RVMI. And for this patient, we would like to take right-sided leads, V3, 4R, V5R, particularly V4R is the most important. And because of RVMI, so this BP is low. And can you tell for this patient, RVMI with 80/40, what is the first thing that you will get besides the antiplatelet and whatever loading you are giving and the thrombolysis or whatever, anything else that first you would give this patient?
Start Noret.
What?
Noret.
No, fluids. IV fluids is the first thing that you will. IV fluid is the first thing that you will give. Okay, so nobody is answered. So this is a 45-year-old man. He has undergone PTCA 3 days back and he is now complaining of chest pain and that chest pain increases with coughing and on deep inspiration. What is the ECG showing?
This pass.
Okay. So this is classical ECG of pericarditis. He has underwent, he had some MI few days back. Now he has this chest pain that increases with coughing and inspiration. So this is a ECG of pericarditis anyways. No, it's okay. So tell me what this is. 70-year-old man, he underwent hip surgery 5 days back. He complains of sudden onset dyspnea and palpitations.
DVT. DVT. DVT होते हैं।
Venous thrombosis. Where it will go? Venous thrombosis. if there is-
Sarah has already said everything. You just have to say that diagnosis.
So pass. Go on, sir. Pulmonary embolism.
Pulmonary embolism.
Right.
So these are sinus tachycardia, RBBB, RV strain, pattern, right axis deviation, all these are. And the most important, he had hip surgery. So he is immobilized for a long period of time, almost 4 days, 5 days, maybe more than that. So DVT that has caused pulmonary embolism. So this patient presented to ER with ischemic CVA. He has a history of angioplasty 8 years back. So what is the ECG showing? Even if you say that rhythm, that will also be okay. And why this patient had a CVA?
Irregular RR.
Irregular R. Very good. Very good. Then what we do in our lab? For
AF.
AF, yeah, you are right.
AF, right.
Said AF.
Well, some ischemic cardiomyopathy is there and he has AF. So she will get.
So Joyce gets all the point. Ah,
Nobody is.
good. Good. You have to teach other people then. Good. So you do LA closer for this year.
So what is this ECG showing? Patient has come to ER, he is unconscious,
Pushpa.
BP is unrecordable.
Pushpa. Yeah.
Eh.
Then what? BT. BT. VA. Mike में बोलो. BT. Okay.
Okay, I will get. But monomorphic or polymorphic VT? What kind?
That will be difficult. You will get a point. BT.
Okay, so you will get the point. What will you do for this patient? First thing? Yes.
Short. Yeah.
So you will get the
Short.
marks.
Good answer.
So what is this? 25-year-old man presented with palpitations since 1 hour. Just the diagnosis, nothing else.
Wow.
Right.
Great.
Ragnar. Right.
Yes.
PSVT.
She gets 1 point.
Okay, so now this X-ray. This is a 70-year-old man. He has severe dyspnea, orthopnea, saturation is 75%, BP is high, and pulse rate 130. So what is this X-ray showing?
बोलो जो इच्छा है बोलो.
Kinetic.
हाँ? क्या? DCM तो है, लेकिन एक्सरे में क्या है?
X-ray टा किया है.
उसमें मशीन लगेगा आदमी. एक्सरे में क्या है? तो उसको तो पढ़ाई करना है, सिर्फ दारू नहीं पीना है. Okay, so this is basically pre-ventilation pulmonary edema. No points.
Exactly, acute pulmonary edema. Okay. The next one. What is this? 1-year-old child with cyanosis since the child was 6 months of age. What is this classical X-ray showing?
Dextrocardia.
Dextro.
Why dextro?
This side is left, this side is right. This is not dextro.
Just the diagnosis.
Takaisu.
What?
It starts with top.
Top.
Top. Yes, you're right.
Right.
Not Takaisu. Top.
So
So you'll get a point.
you'll get point. Okay. Now this is a 3-month-old child. She has mild cyanosis. Just look at the size of the heart.
जो साइनोसिस लेके आता है बच्चा, क्या क्या हम लोग कैथलैब में देखते हैं? ASD होता है, साइनोसिस नहीं होता है. साइनोसिस कॉन्जेनिटल हार्ट डिजीज, एक तो जिसमें इतना बड़ा हार्ट होगा या साइनोसिस होगा. ब्लू बेबी होता है. टेट्रोलॉजी फेलोस तो वो हो गया. टेट्रोलॉजी फेलोस इतना बड़ा नहीं होता है. हार्ट बड़ा है ना? हाँ क्या? M5 बना.
So I'm seeing this one term called box shaped heart. No, box shaped. It's also called box. It's so huge, the heart.
EPVC.
So abstention only.
Huh?
Abstains. This is
Abstains, okay.
abstention. Oh. Okay, so not this one. What is this X-ray showing? 45-year-old man, he has a history of taking anti-tubercular drugs 20 years back.
Heart কি আছে? Calcification. Who
What
said
is
that?
this?
You'll get a point. So this is called constitutive pericarditis with calcification. Yeah.
This is constrictive pericarditis with pericardial calcification.
Right.
Who answered?
A gentleman. তোর নামটা কি? মানবেন্দ্র.
Okay.
Next.
So this patient underwent some OT and then he has developed shortness of breath. What OT and what has happened? What is this X-ray showing? What? Okay, the pacemaker has happened and then why he has developed shortness of breath after
Lungs.
OT? Look at the lung field.
Pushpa. Lungs. Right lung. Yeah. Right. You'll get
Right.
a point.
Iatrogenic.
Manavendra will get 10 points.
So what is this? Child with cyanosis since 1 month of age. No.
Difficult.
Okay. This is a classical Eiicon site tool there. Transposition of gate arteries. Okay, that's okay. So you know echo, you know a bit of echo also since you work in the cath lab. What is this? What is the problem with this valve and what is happening here? What is the valve is so abnormal here?
Right. You'll
Right.
get a point.
Okay, this slightly tough. This 130-year-old man is complaining of exertional shortness of breath since 6 months. ECG will help in the diagnosis.
Pass.
Okay. So this was apical cardiomyopathy. Just look at the apical part of the LV. Okay, it's really thick. And this is a 30-year-old man with dyspnea, bilateral pedal edema, palpitations since 1 year. What this can be? Look at the thickness of the walls and both the valves are abnormal. There is biatrial dilatation. Diagnosis, just that.
Septum is thick.
Septal thick,
Which
walls
thick?
are thick, valves are also
Also
thick.
thick.
There's atrium, both the atrium are dilated.
Atrium are dilated. Difficult, but it is.
Stenosis of the valve.
No. Both are stenosed. Okay, but that's not the case. But why stenosis will have hypertrophy? Anyway, if your observation is correct, mitral stenosis and tricuspid stenosis exactly look like this until now let's see the movement. And usually they don't have hypertrophy. So I think he will get a point because he has spotted.
Right.
Yeah. So infiltrative cardiomyopathy, am I right? Infiltrative cardiomyopathy.
Infiltrative cardiomyopathy, respiratory cardiomyopathy.
Respiratory cardiomyopathy. So he will get Manavendra will get a point.
So this is the last one. Just another child with mild cyanosis. Very classical. I'm telling this is also called figure of 8 or snowman. Have you heard this term? Snowman or figure of 8 on X-ray, child cyanosed.
If it is difficult, give a pass. Yeah, it could be LA. Yes.
Yes.
But why in a 3-month-old child LA will be so dilated? With mitral stenosis. Tell me, what is the structure on the right side? Okay, that could be LA, but cannot go to the clavicle. You know, the structure cannot go to the clavicle. Usually bulging. It could be LA, but it's not LA. But it's something else. And what is there on the right side? Other side, this straight line. So what are the structure on the right side? RA, you are right. Then on the top, So Ben, no, outer cannot be on this side. Anyway, I think it's TAPVC.
Yeah, TAPVC, Supragadia TAPVC.
Anyway, so wonderful. That was the last question. Thank you, Shobhit. So I'll ask you last question, which will be very simple. That suddenly on the monitor, there is a straight line. Okay, while doing a cath lab, there is a straight line on the monitor. So what could be the possibility? 1, 2, 3, 4. 1, the patient is dead. Second, your patient has gone into VM. Third, his patient's chest lid got disconnected. And the fourth, the ECG machine is at fault. So out of 4, raise your hand, time starts now.
ECG.
He's the first.
If ECG patient condition, we can see the ECG disconnect.
Right. So first, when the patients are doing well and if you don't see any QRS, you look at the ECG connections rather than just panicking. The patient loses consciousness and you're throwing seizures and jumping from the bed, definitely jump on the CPR. So you'll get 10 marks. Okay, so who is the winner? Joyce, 1, 2, 3, 4. But Manobendra gave a good fight. 1, 2, 3, 4. Joyce got 60. 50 plus 10, 60. Last one. Okay. So it's my pleasure to announce the winner of today's quiz. So next time you come prepared with more knowledge. And you have to understand that it is a teamwork. Nurses, technician, everybody is important. And you have to participate in the team with a lot of knowledge. And I can tell you, my nurses, they can perform angioplasty and routine angiography, sheath, everything they can do, all of them. But they have to understand that the ECG is also important, the echocardiography, the equipments, the connections, patients, condition, saturations, everything is important so that you one day become one of the leading nurses in this country and also can represent India in the national and international forum. Thank you very much. So your prize money is 15,000 rupees. We'll hand over the check today itself. So we can go to the Lucky Draw Center right now.
Congrats.
And our next case will be live case from Apollo. So 2:45 exactly will start. So thank you.
Thank you, sir. Thank you.
Consolation prize. 1 chocolate for him.
So with a picture perfect moment, we conclude this amazing quiz segment where it is a mixture of answers we got. So now I will request sir to move to the next hall, Victoria Hall, so that we can start off with the lucky draw. Requesting each and everyone to please report to Victoria Hall, that is just beside this, so that we can have and you can be a part of a lucky draw. So at 2:45, we start a live session from Apollo. So requesting everyone after post lucky draw to please report here again.
Hello.
অনেকে প্রাইজ নিতে দেখি ওই জন্য তো ওই দিকে যাবো
I was not doing that.
Aftab Khan and Raja Nag. That is the main challenge. We cannot delay it. Yes. Just print it there. Just print it there. Please don't grab. Let me just see if you're
For this conference. Yes, I do like that. I did have a chance to. Yes, if you want to like buy. You will be on stage, like, if you want to go shopping or your family, go visit this planet. You can go to the Park Street if you want. Yes, Park Street is just one stop. Park Street. Standard is kind of like shopping. Standard. Yes, there is ES standard. You will actually vote understand with the which is like technically a this. It's 2 minutes. They're connecting, just adjusting the camera.
Hello, check. Bye. ওটা আমাদের এখান থেকে ওখান থেকে হচ্ছে হ্যালো হ্যাঁ
So it's time, ladies and gentlemen, we start off with the live session. We will be having 2 live sessions back to back from Apollo Clinicals Hospital. And to present case number 1, I will request the following dignitaries to please come up on stage as chairperson panel, requesting Dr. Manatosh Panja sir to please come up on stage, requesting Dr. Pankaj Manoria sir to please come up on stage, requesting Dr. Naveen Garg to please come up on the chairperson panel, along with the dignitaries. I will request Dr. Shanand Shetty to please come up on stage, Dr. Nitin Deshpande, Dr. Manatosh Panja, and we already have the presence of Dr. Pankaj Manoria. And operating on the case one, let me just take the time to call the panelists as well. Dr. Obik Karar, Dr. Arun Kaur, Dr. Chandra Kumar Das, and Dr. Devar Godua. If anyone is present, please be in the panel, requesting the panelists for case two as well to join the panelist segment. The names remaining the same, Dr. Obik Karar, Dr. Arun Kaur, Dr. Devar Godua. So we start off with case one from Apollo Clinicals Hospital, operator Dr. P.C. Mondal, Dr. Aftab Alam, Dr. Raja Nag, followed by case two, again from Apollo Clinicals Hospital. Operators will be Dr. Devashish Ghosh along with Dr. Shubho Banerjee. We start off with the live session now. Over to you, sir.
Okay, welcome to Apollo Hospital. I think Dr. P.C. Mondal, Dr. Akhtar Khan, Dr. Raja Nag, one side, and second case will be Dr. Devashish Ghosh and Shubho Banerjee. Only one case. Okay, there is only one case. So, okay, your comfortable time. Dr. Ahmad, Devashish Ghosh, and Saurav Das. Dr. Mondal case is not there. Apple is connected or not? Okay. Yeah.
So can.
So can we get connected with Apollo Clinicals? Yes, we are connected. Yes, it is audible. Yes, sir, you are audible.
Yes, you are audible. Please go ahead. Yes. To increase the volume, please.
So, what do? You present the case first, and then go to case step by step. So, operating operator will be and
Increase the volume, please.
And we have to slide, please.
Okay, please go ahead the history. Presentation. Okay, thank you. Now it is okay. Focus this slide. That's okay. Now.
Okay, so 61-year-old gentleman who came with a non-ST elevation with 2 months ago. The factor that is hypertensive and smoker. He shows which maintains the aneurysm. Echo did not show any major artery and there was no brain validation. So let's go on to the next slide. So this is the black parameters, the basic parameters. Renal functions were intact, his platelet counts were normal, and basically it doesn't seem to be a very high in this case, this kind of what he was doing. As an initial step, we want to found X space. Okay, so in the coronary angiography, at presentation, we had a CTCAD, which showed a completely occluded thrombotic occlusion of the artery, and then a moderate visible block with the involvement of the left, including the six areas. So we come to that. At initial presentation, because we thought that the RCA was so-called artery in Germany. This was opened up, and that was opened up in the first setting. Because the LMCA was a complex mission with involvement of both the major branches, both proximally and distally. What we found that we deferred for 2 reasons. One, the patient was not willing to get surgery. Second, he needed time to think about it, and he also meant that having a that main step, it may aim to develop a strategy, just open up the artery, which we did. So today what we have planned to do is to tackle the lens system. Well, any from the hall have any different opinion about the strategy we have set, keeping her happening all at the same time?
Let's see the angio first.
Okay, then we should, so then and angiogram is
Yeah, so this LMC and posterior proximal LED, and I think that circumflex is posterior lesion of the circumflex. Yes.
Show the initial angio.
I think we have so this is the angiogram. So if you run it, we have put in taken a femoral approach, and we have had actually
Please, please show the initial angios.
Sunil, you come to it is PC Mondal present at this LMCA that is presented. Now to the Devasis goes, other lab.
Sorry for interrupting. I think the cases are getting perhaps mixed up. We can see Dr. Mondal operating as well at times. So could we just make sure that we see?
So I think we present this, then we get working on this, and how we do the other. Is that all right?
So, okay, so,
So let's have to look at the angiogram.
okay.
In the meantime, what Ashfaq has decided to do is taking a separate calendar because so this is the can you please that? So any comments on the angiogram? Obviously there is significant disease after bifurcation, and the LCA physical disease is quite prominent, but there's some suggestion of disease in the osteum as well. And then you're not very sure how much to do. Can you show the LED? Yeah, so this is the LED shot. So which shows again the disease and some amount of left atrial disease and obviously some significant amount of physical disease. So this is the angiogram, this is the presentation. So let's have some strategies. Anyone strategy with this? What would we plan for the want to do more to the LED solution, or you want to say that you want to
I think the plan should be do an imaging first. Let's see, because it's looking like, yeah, exactly.
Oh, and so putting the LCX pull back. So this is from the LCX
The distal is very tight, no doubt.
the segment of LCX is very information. So what area would you really need to concentrate on that? You know,
In the bifurcation, the osteal circumflex, we need to assess what is the plaque burden, how severe is the disease at the ostium. Yeah, exactly. Yeah. Yeah. It doesn't appear significant on angiography.
So can we show the hospital?
Yeah. Yeah, on IVUS, we are seeing a very protruding calcium at the circumflex ostia. And disease is appearing much more tight than what it is appearing in the angiographically. And also we are seeing significant plaque burden in the LMC also.
There are two problems here. We will see that one, maybe the osteum is not too bad, but the distance between the more distal lesion and the osteum is just 2 millimeter. So what strategies would we use?
I think you see if the MLA at the osteum is more than 4 millimeter and the plaque burden is less than 50%, it's around 33%. Yes, so it's not it can be do a provisional strategy because we may not straight away go for and stent the ostia because sufficient MLA more than 4, plaque burden less than 60%. It's a can be left alone.
And the osteum is just 3 millimeters. Would it be able to?
Yeah, we need to find some landing zone. If we don't find a landing zone in the proximal segment, then we might have to cover the up to the circumflex ostia. I agree.
Yeah. The concentration on the IVUS here would.
Yeah.
For these interventions. So,
Else, the first is
Yeah. Some moderate calcium only. It is not a severe enough. Mild to moderate.
Calcium is not a major issue here.
But are there any healthy landing zone with the plaque burden is less than 50%? Do you find any at that spot where you can put a stent in the proximal portion where there's a plaque burden is less than 50%? I don't think so.
Now, there is just a 2 millimeter difference between us, fairly tight proximal lesion and others.
Yes.
Yeah,
this.
You want to concentrate on your body. Oh, so I think the strategy that is working is observational or dedicated to.
Yes, since you see the circumflex in the mid portion is very tight. Anyhow, we need to stand that. But the bus is whether we have a good landing zone in the proximal segment or not. I don't find a good landing zone in the proximal segment. In that scenario, we need to do a right from the ostia. I think so. But let's see the LED first also, the IVUS.
So, okay, so say, we have to set the area. I think we have to come to the next step on the area. So what you're suggesting is that if the circumflex ostia needs to be covered, we will have a dedicated treatment strategy.
Yeah, definitely then.
Any opinion from the family that they would prefer that they will go for the provisional strategy in this case? Okay, so what we do, we pass you on to the new IVUS and we pass on to the next class. So class is not progressing with the game and our part has already started. So we will see how we progress on this. So the LED IVUS can be shown, LED IVUS can be shown. So this is the IVUS strategy. So everyone and so strategy is there.
That is the tightest portion. So it's looking very tight on IVS. The MLA must be less than 2 or 3, I think, between around 2. Looking at both the IVS, I think it seems to be a double stent strategy right from the go. Because you're seeing severe plaque burden at the circumflex ostia also, and we don't find a healthy zone in the proximal portion of the circumflex. I think it's better to go for a 2-stent strategy.
To me, we should try for the provisional stent, if necessary, then take the descent and up front of the bypass and the 2-stent strategy.
So you would have this would be a 2-stage strategy?
Basically, you have to stent the circumflex, no doubt, because the proximal portion is very tight. First of all, yeah, Miss, the problem is there can be 2 ways. Either you put a stent at the most healthiest portion, the proximal circumflex, do a crossover from left main to LAD, and then reassess again. If necessary, then you put another stent. Or the second strategy, we can go away with a 2-stent strategy, either weak crash or mini crash, put a stent in the circumflex and crash it with a left main to LAD stent. You can do, I think both ways can be done. But you need to modify the plaque sufficiently because there's significant calcium is visible in both the vessels. And the plaque burden is also huge. You need to prepare it very well before putting a stent, I think so.
See, I think.
Because one of the ways is the benefit even if the stent isolated, you have to do it from before. Other to the LAD stent, the LAD stent, a left stent into the LAD will not be injured.
And also there's calcium at the circumflex also. To rewire may be difficult sometimes if there's a calcium is present. So it's better to have a patency of both the branches, then it's better.
Yeah, maybe you stent the mid segment first and then crossover from left main to circ and treat the circ as a main branch and then LAD as a side branch. That would probably be easier because the osteal part also has quite some calcium.
Hello. How about treating the sarc with drug? How about treating the sarc with drug-eluting balloon? Leave the sarc alone, just drug-eluting balloon for the lesion, stent the LAD and left main, and then there's a question of landing zone then. You can spare the...
Yes, you're perfect, Dr. Jha. You are take the precautions. So initially you have to prepare the lesions.
Yeah.
After that, we take the decision.
The disease is very severe. Disease is very severe and with a huge plaque burden.
So you have to prepare the lesions and then take the decision.
Yeah, it's a severe case.
And there's no need to landing zone there 6 hours. Okay, so
Yeah, I agree. So you're planning a double decay crash in this.
Your plan is the mini crash or nano crash or decay crash. Ultimately, if you take the 2-stent strategy.
has become a little unstable with a low blood pressure. So we want to do the experiment and then come back here and show you what we have done.
Okay, Devashish, if people Dr. Mondal is coming. Mondal, could you please?
Yeah, good afternoon. This is Aftab along with Dr. Mondal and Dr. Ajana. So we are in the lab third year. So we've got this case here. Let me just present the case in paper. Can you move to the next slide? So this is a 57 years old gentleman who's had an angioplasty done earlier in 2016. This is done in another institute where they have done angioplasty to the proximal LED, leaving the ostium of the stent has been deployed till the ostium of the proximal LED. And this patient has now presented with stable angina for the last 3 months. He has the risk factors of hypertension and controlled dyslipidemia. And this time he's presented with, as I said, chronic stable angina, and he has a normal LV function and a normal AV function. Next slide. So his basic parameters are normal. Next slide. So we did an angiography for him, and can you play the initial images? And a stress scanning was done for him, and this showed a significant viable delivery and a reversible ischemia in the interlateral wall. So this is the initial angiogram that was done for him. Can you see the images of the angiogram?
Not yet.
Okay, let's take the page.
Yes.
So this is the angiogram images, and here you can see that there's a patent stent in the proximal area, and there's a significant stenosis in the osteoproximal part of the circumflex, and this is a codominant circumflex. Next slide. We have just 1 minute. So I think we've got this is the diagnostic angio that we did today. Yeah. So any thoughts on how we should proceed with this? So there are 2 big concerns that we had. So this is a circumflex osteostenosis that we are trying to deal with. And here what we've seen is that there's a patent stent in the proximal area, but we feel that the stent has probably on the angiogram itself. We can see that there are a few struts which are crossed into the distal part of the LMCM also. So there's a possibility that few of the struts are lying across the ostium of the circumflex. And there's a new critical stenosis in the osteoproximal circumflex. So your thoughts on how we should proceed, and we'll tell you what our plan was.
Yeah, I think first we need to answer whether the stent is protruding into the left main or not. It appears like it is protruding into the left main, and the cause of circumflex stenosis is because of pinching of the stent from the LED. So we need to answer these questions by doing an IVUS both in the LED as well as from the circumflex, and then decide the strategy. I think it will all depends upon the imaging, whether we are through the struts or what is happening, what is the cause of restenosis. Let's see. Please show us the images.
So here, please speaking, I think the ostial lesion circumflex because of the flux shifting or the effect of the LED stenting, most likely. So definitely preparing the lesion with the help of the NC balloon first. If it is not satisfactory expansion of the ostium, then cutting balloon must be used in the management of the plaque modification of the calcification modification of the ostium of the circumflex. Then you take the decision.
Yeah, first and foremost, an IVUS should be done first in the LED, and then assess how much the stent is protruding the left main, and then we'll decide the strategy depending upon what are the results from the IVUS. I think so.
Okay, wonderful. I think that's what the echo those thoughts that we all had, and this is the strategy that we thought for. So this is the femoral approach, that's the 7 phase guide in the bifurcation. So initially, we started with a real guide, and though the guide was sitting well, can you see the next image, please? So the initial plan was, as we said, is to wire both the arteries and do an imaging in both these arteries. Since it's a critical lesion, we know that sometimes the iris may not cross, and therefore we did a gentle pre-dilation with a 2.5 non-compliant balloon at 8 atmospheres. Go ahead, yeah. So here, despite using pre-dilation, unfortunately, you are not able to track the iris. And again, it raises the suspicion that possibly there are 2 struts which are lying across the ostium, and that's preventing the iris from crossing. Next. So then the plan was to use a guided iris entry, and this you can see is a 6-point guide that's going to the guide. I think we don't have to images again. But despite using a guide set, unfortunately, you were not able to track the iris down.
I think
so then the next plan was, of course, that we changed over to another more supported guide, and then we moved on to an EPU. So this is a 7-bench EPU 3.5, and with a more supportive wire.
So
We direct the ostium with a non-compliant balloon, Wolverine balloon, and the small images that we had during the peak of the IVUS that had just peaked into the circumflex from the left main. Can I show the IVUS images that are
So-
on the screen there?
So was I was not going into the LED also?
No, we were not going to the LED, the circumflex was an area of thing. And we felt that by looking into the circumflex from the LED, may not be a into the circumflex. So the intention was to enter into the circumflex. And the further pre-validation was done with a Volgren 3 balloon. I don't know if you can see the IVUS images there. Can you show the IVUS images?
No.
Can you make the IVUS image?
Please show, yeah. This is pulled back from LED or what? From LCX.
See, you can appreciate that there are few stars of the this would have to be influenced. There are few stars which are rotating into the left main, and so the ostium positioning of the LED stand has not been absolutely true. Ostium is gone into the few stars have gone into the left main also, and those are the stars which are preventing from ostium from the IVUS from really getting into the circumflex.
Just run the IVUS, please.
We changed from what's supported by use Volgren to redirect the ostium again. And we can then after that we could track the IVUS catheter into the circumflex, this time even without the use of a Godzilla.
Just run the IVUS, please. Again.
Once it crossed now, and we'll show you the IVUS images post inflation with 3 millimeter Volgren balloon. So Raja will just comment on the IVUS pictures.
After, what is rationality use of the extension catheter? Because the better position for the guiding catheter is already there. And the
Initially, we were using a JS catheter, which did not fit well and were not providing a good support. So, because what getting the vascular, our lifestyle and the wire came out. So we decided to change the guide totally once around. So we took this with the EDU and it was sitting well and good support. In fact, one more maneuver that we did before using the Godzilla was what we call as a tracker balloon technique. So we inflated the balloon in the LED stand because that's a patent stand for 1 period of time. And then we tried to slip the circumflex, the catheter of the IVUS into the circumflex. But even that the tracker balloon technique is not really, or the anchor balloon technique did not help us to get the IVUS catheter down. So when the anchor balloon failed and your Godzilla assisted catheter into the circumflex state, I think the best thing was to change your guide to a more supportive guide, use more supportive wires, and do a better weight validation of the ostium, and that's how we get the catheter down.
Yeah, I think. Yeah, we have seen. I think IVUS clearly showed that the LED stand studs were hanging at the circumflex ostia, and these studs were preventing your catheter for the IVUS to go through and the balloon for finding difficulties. And this is the cause of restenosis because the stand was floating much into the left main, and these studs were causing restenosis of the circumflex. It's very clear.
Very much of basic, taking at least 15-20 minutes of repeated attempt going. Can know the last entry of the wear of the beginning. It's very difficult. And this one. Long time.
Yeah, because you were going through the struts, they were hanging in the ostium. That is why you were finding difficulty. It's very clear from the IVUS.
or maybe under surface of this
Yeah.
start of this.
They were hanging.
Yeah,
So,
luminal aspect.
so now right now what I'm thinking of is the IVUS in the like you can see. So we have come now almost.
Yeah, this is the ostia. This is you can clearly see studs hanging in the mouth of the ostia, and these were preventing from the IVUS as well as from the balloon to go through.
You can see I was separated inside the guide already. So it's a very short lesson for which we started with the JL, but it was not providing good support. Another thing was with the JL, when we were going into the guide here, it was providing with the LED. So that was another reason. So we now next plan is to of course understand the LED and from the left LED to the left hand also. Which angiographically does not seem to be too bad. I think the LMs, the left means the LED stand has performed well over the last 8 years. And we don't angiographically see much of a disease there. So what are your thoughts on what should be our treatment strategy of stenting in this artery?
I think first dilate with a cutting balloon at the circumflex ostia, put a stent and do a kissing. If the result is not, then again put another stent from left main to LED. Put a stent in the circumflex ostia, do a good kissing, assess again the left main, distal left main. If you see there's some disturbance in the left main, then again you put a one stent more from left main to LED and then crash this stent again.
So we want us to take the do a detailed brush with possibly, I don't know, you want us to take the circumflex of the side branch, or you want to make the area of the side branch?
No, circumflex the side branch.
Okay, so you tell, I mean, you think that we should do something like a mini brush in this case?
Yeah, can be done.
Yeah, so our concern was that we found that the LED has been set up in 25 and the struts are almost to the ostium. The circumflex is a short, the circumflex is a good size vessel, it's a core dominant vessel, almost to 3.5, and the left main is almost to a 4.5.
Okay.
So, and it's a short left main. So we don't really want to put too much of metal there. So our plan was to extend from the left main into the circumflex as a primary strategy for treatment of this lesion. And we would thought that we will then look at it going into the FD to see whether the LED really has a fixed page. Now I understand that when we do a stent from one artery from the left into one of the other branches, there's no data to suggest that we should do a testing into the other branch. If you have the LED branch there. But here in this case, because we're dealing with an LED as a side branch, we still feel that even though there's no data, we still want to open up struts into the LED. Because leaving struts across the
You see,
is something that we're not really comfortable with.
Dr. Mandal, if you put a stent from left main to circumflex, we already know that the LED stent is protruding into the left main. The struts will be going to get crushed, the LED stent does, no doubt. Because we see in the IVUS that the LED stent is protruding 2-3 struts into the left main. So if you put a stent from left main to circumflex, you're going to damage the struts of the LED stents, no doubt.
But I think we should want to spend that into the LED unless we really have a significant stenosis there. So we probably finish the casing there.
Yeah, kissing is mandatory in this case.
Even a LED as a side branch is something that they're really uncomfortable with. And we would want to sort of open up the strut into the LED. And your point is well taken because the fact that the struts are already there in the LED. Is imperative in this case. We are just using in the LED, there on the screen as a sense of available. I don't think there was any malposition or other expanders. No analysis. So our plan is to go ahead and do a comprehensive and then take it up from there. I don't know what case scenario would be DEP in reality and NC balloon in there and do a final.
Raja, actually speaking, these cases, we should finish the job first, the ostium of the LMC up to the proximal part of the sarc. After dilatation, we cross the sarc state and negotiate into the proximal part of the LED wire.
Yeah, you see the IVUS, the stents is clearly going into the left main, the LED stent. You can see 1 or 3 struts are going into the left main. So definitely you are going to damage these struts. You have to recross it, do a kissing and then assess. If a good MSA is seen at the LED ostium, then you can go with a drug-eluting balloon. You may not put another metal, but you have to recross it, do a 1:1 kissing, and then reassess the LED ostium. I think that should be the plan.
Yeah, so that's what we're trying to do. The circumflex vessel size to 3.5 and what is the size of the hospital? There for this time. So we have a diagram of 3.5 and length of around 30 millimeters. So we will make a 3.5 30 or 32 millimeters and then that. So they are starting with making a 3.5 into 33 stent. This is the science expedition that we are taking. And the plan is to go from the circumflex from the left end to the circumflex. Okay. So while we work here, I think what we can do is make a section graph again. When Dr. Bush is waiting with his the first case that we showed you. Over here.
Take a picture, please. So Mandal, Kishi Mandal, please take a clear picture of the bifurcations. Oh, this picture. Okay. So Dr. Ghosh, okay. Yes, yes, please proceed after the.
That means intervention. Everything does not proceed. So, direct initiative on a DP strategy. And when it says deploy the LCA step, and try to crush it with an alien balloon. We'll still get hemodynamic instability, but that has been retrieved, and I will ask Park to actually more or less describe what he did. Good afternoon. Good afternoon. Yes, we had a like coach. Firstly, plan for a detailed of coaching. As earlier, we have discussed that there is plan for that. So what we did was we did a thing and while pressing the tank, we noticed vitals went down.
So your plan for the decay cross, you already put the strain on the SARC and the 1 or 2 millimeter, it will be in the LMCA. That is, you give the strain path.
So we'll start from there.
Yeah. Oh, distal disappear.
So I think after this data will be we have put up within 3.5 million and after the crash, the BP went down and we did the so this is one we got.
Understand.
So you thought to this after this what the BP go down.
Put us in. Definitely.
So I think any thought to how should we tackle this case because we don't have a lot of luxury of trying here.
I think you've already put a stent in the circumflex and there's a dissection at the distal left main. To put a stent from left main to LAD.
The cause of dissection most likely due to the inflation of the AC and discussing the so it happens sometimes. Yeah.
We put a pen from which is
LAD. So this will be second class by the stent. Yeah.
Okay. And now we have recrossed the LCA and someone showed the hemodynamics of this patient. We have recrossed the LCA stent and done a pot. Before recrossing, we have done a pot and then we have recrossed. This is the pot.
The ports balloon is taken from the ostium up to the carina. Yaka. What is the size of the port size? 4.5. 8 millimeter. That's good.
So this is the present status, and after the pot, we have recrossed with the filter FP wire.
What was the size of the LED stent, left main to LED stent?
330, and actually, it's an infinity. It will go out 700.
Like this is, yeah, otherwise, yeah. I think except for resolute integrity, I think a stand of 3 is very difficult to go to 4.5. Other stands. Yeah.
And we were planning to do a kitchen and then take an Eiicon and see what we have seen. I think this is the challenges of left main stand, that you will get a very airy situation and you need to change your strategies very fast. What is the very as you know that a proper classical linear crash would have taken a significant long time. I think maybe some advantage on a very long-term basis, but at the moment that means this is good as that.
Dr. Gross, recrossing to circumflex appears to me it is a proximal or middle. It is not a, it is most likely proximal. It is ideally. Yeah. So decay crash, not for this crossing in the distal start. Never.
One of the things comes here is when we are doing a left main and if we take a suppose of Ventila and other mechanical support, but as the LV is good, the pattern 55% we would have stable. So we did not think of going into any MBS upfront.
So what balloon are you planning to take for kissing? 3 in the circumflex and 3.5 in the LED? Balloon for kissing?
I think that is the main aim of this case was that you need to have very sort of a strategy which you are willing to change according to the hemodynamics of the patient. Classical decay crash is what we planned, but because of the certain problems which we face, every one of us is facing problems. So that things can be stabilized much easily. It is hemodynamics are pretty good now. He's got of 160 by 90 on about 5 to 6 of noradrenaline, and his heart rate is 87, saturation is 100%. So I think hemodynamics have drastically improved after that detection. So any other thoughts from the house which things would have been done differently or anything else you would have thought of?
And Dr. Ghosh, one thing I used to prefer to the nanocross in this patient. The decay crash is multiple step that a minimum step is there. So it is time consuming and also many complications arise until it is very experienced operator and some selected group of patients could be utilized. I used to do the simple procedure, particularly to minimize the step in the mini crash is ideal.
The thing is that because you see, decay crash already good results of decay crash were from trials done by very dedicated mainstream operators with very high volume of evidence.
Yes. I think the only difference in mini crash and decay crash is the chance of recourseability of the wire after putting a second stent. It's much more with decay crash than mini crash. And secondly, the decay crash can be done with a 6 French, but for mini crash, you have to use at least 7 French. These are the main two differences.
Selected patient.
Yeah, I do mini crash.
So I think
90%.
So we are going into this unit, but we just post directing it. So we put directing the LCX. Very good. One step. Is it okay? Here. So if you see that Aspak is actually optimizing the LCX pair. So at that point of time, it was very difficult to do because you have to whistle that makes the termination. So, what we do, we'll see how the lab is progressing because, it needs to have stabilized and we have got a strategy, for this patient. And it seems to that very stable now. So let's go to the other lab and continue with the other lab space. So we are back in lab 3 now. So as we discussed earlier, we are now we've got so the plan is to stand from the hospital LMCA to the circumflex. Do a part in the left main. Since the left main is pretty short, we are going to take a 4.5 to 6 balloon and achieve a few of the balloon hanging into the aircraft. And then decross into the and then finish with the final kiss, and then do a refitting into both the vessels again. So again, comes find the ostium, and since the short left main, there's always a chance that we have missed the ostium. So again, this sometimes the difficult view. I think going back to the end of page, you can give us an idea.
I think you're too much into the aorta.
Yeah, this is too much into the sinus.
Yeah. Maximum 2 millimeter in protrusion in the aorta.
So this looks.
Yeah, this okay. This looks okay. Okay. Yeah. That's okay.
The other issue is that both this is we are not using. I think this is the non-extent that we are using. When you're doing an hospital position, it's also important to be aware and be careful about the both with the stent and the ostium. And then some of the techniques are this. Yeah. So this is basically now the rescue for the ostium, but then we know the distant path and
Osteoporosis.
So again, I think proximal quadrant stent is something we're concerned about, and I think it's important that takes all movements from the patient. And some people also tend to keep a wire in the ostium, but I think that technique is not no longer in this span of us.
Proximal LED little hazy. The white appearance is there. ACT at present.
We are the patient is probably in our again. So now the wiring in the circuit in the LED will in fact prevent your stent from being your guide from really going too much. Therefore, your injection will be mostly non-selective here. So I think we can get a pretty good idea on the hospital maintenance.
Okay.
So the circumflex looks pretty decent, and the LED does not have too much of
Yeah. Angiographically, it's okay.
we need to recross the left main, and then do a part in the left main, recross, and then do a kissing, and then do a re-welding the both the vessels to get into the golden area. Have your partner on the side table? Have your So right now we are at the stage where we have already installed the stent in the 3.5 30 dial, and we have come across to the left main. Post that the shots look good, so we will be doing a port in the left main, and then we will recross into the LED. That is the plan so far. Should we have any comments?
No, I think, yeah, first, after doing that, I'm sure you're going to take another IBUS run, isn't it, to look at the ostium,
Yes,
how it looks,
yes,
yeah.
yes. So our contribution to the validation was the LED station was widely patented and it was good. Only problem was that hanging started the left and also Neo as well as in the LCA. So we are doing a part with the 4.56 balloon.
Turning focusing now.
Going. Like we all know, the plot should be exactly at the bifurcation, so we are trying to negotiate that. And now we are good, we should increase. Fourteen. So the patient has already proceeded so far well, hemodynamically stable with normal diaphragm. So this time our next plan is to recross into the LED.
Okay. Your plan to sequential crossing and then the end of the simultaneous. Yeah, sequential. Then finally simultaneous.
So any comments from the panelists about the procedure, how differently it could be done?
I think the second strategy which we discuss is again do a decay crash, put a use circumference as a side branch, put a stand, and do one stand more from left main to LED. But I agree that it will increase more metal in that small left main. So I think this is a very good strategy. But let's see, once you recross the LED, do a good kissing. Let's see what are the MSAs of the circumflex and the LED stands. Is the circumflex as the LED stands, is metal free canal is visible or not? Let's see. It depends upon all on the final IVAS run.
Yes, we will take time. So we have crossed easily into the LED. Now,
Even in USA, most of the center, they do the only one final, after optimizations that will be confirmed by the final IVAS only. Because single time they used to do it. That's good.
we are taking a 275 already used the one, so we are taking it across into the LED and trying to dilate it further and then do a sequential simultaneously. So at this stage, you want to take a to be finished and then a final.
I think at the end you can do.
I think there is another 10 minutes.
Yeah, we will be finishing much before.
Now easy to cross the recrossing of the LED.
Yes, sir.
Yeah, because of pots.
There is that you can recross very easily, even with the usual.
So what size balloon are you planning to take for kissing?
3.5 and 3.
Yeah, exactly. 3.5 in LED and 3.
So Dr. Khan has to left because he has a presentation. So I have to take over from there and Dr. The sole operator here.
Initially, it was very tough actually, wearing, crossing with balloon, everything jumped out, tried with guides, the team was done, which guides, everything came out.
Limestone Godzilla.
So, we don't know that my bifurcation is a totally different animal and it's totally different in different individuals. So in our case, we expect that LED will change, or maybe we may have close also, but we will lucky to get a very normal emitting flow after the.
Dr. Mandal, when you are finding difficulty in the initial steps in going into the circumflex, taking the balloon, did you dilate from left main to LED to modify the struts?
No, we did not.
I think this could have been done. If you find difficulty in going to the circumflex because stent was into the left main, you could have dilated first from left main to LED, and then it could have modified the struts and could have made a good passage. I think this could have been done when you are having difficulty.
Actually, they already done the proximal ports. So that case is no difficulty may arise. Okay, now both the balloon within the LED and the SARC. Yeah.
So that was why we did go the LED and only concentrated on the area of the.
So good expansion of the stent of circumflexes. Both, yeah. Just prior to the kissing, would you please take a boost for proper application? Yeah. Okay. How much pressure given?
We went up to 14.
Okay.
For writing the LC extent, and now we are across into the left main, and we do a high pressure sequential first, and then do a simultaneous.
Okay.
So 14, 16. 14, 16. 18.
Okay, proper.
आपकी जरूरत है दूसरा लेके जरूरत की जरूरत है मेरे
Because of the short LMC, that is the problem for a proper apposition, both the kissing balloon. Yeah. Now is okay, I think so. Within the. Now do the simultaneous kissing.
Okay.
It's a good expansion.
Yes, sir. And will finish that with the final one with the total value.
Raja, patient is hemodynamically stable?
Yes,
Okay.
You can do an IVAS now. Final pot may not be required now. May not be required. May not.
To the center, you said one final spot only at the end.
The final pot may not be required. The succession message pots to it.
The final optimization.
That is more important. That's all.
Yeah,
Because may not be required final pot. If you have a good MSc, a final MSc in the left main, it doesn't matter whether you are circular or elliptical. What we achieve from final pot is to make it a circular from elliptical shape. That's all what we achieve from a final pot in a two crash. But if you have a good MSAs, it hardly matters. Because time is very short. Let's go. Let's see an IVAS first in the LED. Yeah, that is more important.
So rather than to finish the case and if there is time, we will shift over once we show you the IVAS. Yes, you can do it from there. Yes.
From reprocessing the LED ostia.
As a total transaction, maintenance, whatever. Put the IVAS in the main screen.
This is from circumflex, no?
Yeah, this is from this one. We can see the stuff coming in well mode. You can see at least a diameter of 3.25. There's no admission also. So now we are coming to the most proximal part where the tightest part was the options. Yeah, we are still now we are coming to this is the tightest part which we have done you can see this well expanded.
I think we need to measure that part.
Now we are in the LED battery. You can see the LED side is open well, and this is the left main.
Yeah, the left main ostia is well covered, it's visible. But we need to measure the circumflex ostia. It's looking, I think it's not looking very good. Just measure the ostia, circumflex ostia. Yeah, at this point. See the MSAs.
This is the tightest part only.
Yeah, not bad. No, it's not 6.5. It's around 5. No, it's around 5.
I think otherwise to start with, he had diffused this caliber weapon, but we will accept that with the idea of 5. Or we could direct on a second one. We will do a pot, we will go in pot, we will do across the posture and do a full direct. Thank you. I will ask that to be shifted to the.
Let's see the LED IVAS also.
Sorry, sir?
LED IVAS from the LED.
You want to
Yeah, because we need to see the ostium of the LED. The stats are very clear or not. because they were crushed from the circumflex to left main stent.
No. Minimum LED should be dilated. You want the 6.
Asymmetrical expansion.
LED should be more than 6.
Expanded. That's too much. Not very expanded.
Looks quite well, well expanded.
Yeah, but Dr. Mandal, but IVUS wise, it is not. Yeah, it's. I think we need to gain more. Yeah, it was an oblique, no doubt. It is an oblique. It's an oblique cut. Yeah, it's not. IVUS is not. But they say in oblique. But they say in oblique you overestimate, not underestimate. In case of oblique, always you overestimate the MSAs, not underestimates in oblique.
Now we are the valuation, yeah.
But 14.
Hello, give us layer. Oh. Then now we are coming to the valuation.
Again, you see, again measure the LED ostium. The expansion is very good everywhere else, just exactly at the ostium. I think it's, let's see. Yeah, that is that.
This is acceptable, and this is really circular expansion.
Must be around. Let's
Yeah.
see. Let's see. Yeah, it's okay. It's okay. I think everywhere else in the LED, the MSAs must be more than 9 or 10, it appears. But this is the area where the MSA is 6.4. You agree? Rest it's more than 10.
Acceptable, 6.5.
More than 10, but
Nearly 7, that is.
yes. Yeah, but LAZ 4 millimeter size.
7 is
maybe.
So we will be finishing with the segment of the audio of the LCS and do a final part at the lesson. And I'll ask them to be fixed because
Dr. Manal, what about doing again a kissing with a 4 in the LED at 3.5 in the circumflex? Because LED is 4 millimeter, no doubt, the LED ostia, and the circumflex is around, it's around 3.5. So I think we need to upgrade the balloon size. Then only we'll get a good different result. Otherwise, we do the same size balloon, you get the same result. You have to do a 4 millimeter LED and 3.5 in the circumflex, then do a kissing at nominal pressure, and then let's assess. Otherwise, the same size balloon will give the same result. You need to upgrade the size of the balloon in both the vessels.
Yeah. Okay, Dr. Nag will switch over to the Dr. Devanshi. Okay. Will come back.
Because before I was in the other lab.
There is a stain, no? That is very difficult.
And obviously we need to check. So, any comment on that?
Didn't hear the question. Please repeat.
We are just divers now. Is just behind us, we come to the technical.
Show us the IVUS run, please. Show us on the main screen, please. IVUS.
Okay.
This is from LED? L6. You understand?
Hemodynamics are stabilized very well. At one time, the system is around.
Show us the MSA at the right of the ostia. Please show the IVUS on the main screen.
Because you show the spinal IVUS. We have got 5 minutes.
Because at the ostium, it was looking some under expansion was visible at the right of the ostium.
Dr. Ghosh, do you have the IVUS with you, the final IVUS run of the LED and LCX, the LED? You see. Could you show us the IVUS run? Because could you switch it to the yeah that's it now, yeah.
What is the
variables are
measure at this point? This circle, this is around C less than 5. I think we need to do much more work. Don't you think so? Less than 5 millimeter, I think we need to do much more. This is circumflex.
This is circumflex.
Still it's less than 5.
I think any MSA less than 5.5 in a major epicardial vessel, it is shown as a marker for recurrent events.
Yeah, I think measurement wrong in measurement.
Without measuring, clearly visible that is.
So this is the LED.
Please interpret the IVAS. Oh, take the.
It looks okay. Yeah, it's satisfactory, but our area of concern, a matter of concern is the circumflex ostia, I think, which is the Achilles heel of intervention cardiology and bifurcation stenting.
Our both the cases, lemon stem and osteoproximal sarc as LED really is extremely difficult. And
you see in both these cases, the final diameter, the circumflex ostia, it was around 5.4 in the previous case and around less than 5. So it's the most difficult area when we're doing bifurcation.
okay.
Yeah.
Dr. Goes only 2 minutes. Yeah. Final till the. Okay, thank you very much. Both the cases done successfully. And I will personal thank to PC Mandal and Dr. Groves and their team. And Dr. Mann. Thank you very much indeed.
Okay, Dr. Shia, if you can just sum up what you have done just very briefly in a minute.
Thank you.
We can sum up.
Okay, PC Mandal, would you please show the final result and going to conclude your case? Answer for.
You can summarize.
Yeah. Yeah. Switch on to PC Mandal.
Yeah, we are still there. Lost, I think.
I think the. Okay. Okay, okay, good result. So, okay, thank you very much. Both the cases successfully treated. A very tough case because the distal LMC as well as the osteoproximal sarc and LED is very difficult job. I think I thanks to special thanks to the Apollo Hospital, Dr. PC Mandal and Dr. Ghosh and their team. Thank you very much indeed.
Thank you so very much. With this, we conclude a very complicated case which we had in our live session. I will request all the excellencies to please be in the stage so that we can have a picture perfect moment of this session. So I will request you to please come forward so that we can have a picture perfect moment of this session. And now with that, along with this, we move forward with the next session. And the session is Heart Failure Symposia, Drugs and Devices. And we have Dr. Arindam Pandey with us. Okay, so So we move on to the next session. The session is Heart Failure Symposia, Drugs and Devices. The chairpersons for this particular session will be Dr. Amal Banerjee, Dr. Shondip Mishra, Dr. T.R. Raghu, Dr. Rajiv Krishna, Dr. Arup Kumar Bishash, requesting the following dignitaries to be on the moderator panel: Dr. Shojato Chakraborty, Dr. Bapadito Kumar, Dr. Priyankar Mondal. And we start off with the very first topic of this particular session, quality of life, an important aspect in management of HFREF by Dr. Arindam Pandey. May I request Dr. Arindam Pandey to please take over the stage for covering this particular topic.
Good afternoon, my friends. We are going for a very important session on heart failure. First is the quality of life, an important aspect in management of heart failure with reduced ejection fraction. We have here Dr. Arindam Pandey. He will elaborate on the issue. Arindam, please.
Thank you, sir. Thank you, Dr. Banerjee and respected chairperson, Professor Das Bishas. He used to be my teacher and many senior people over there. So quality of life, is it important? So these are the table of content by which I'm going to, distribute my talk. So how important the improvement of quality of life. Recent guideline recommendation regarding the treatment of heart failure with reduced ejection fraction patients, role of ARNI, sacubitril valsartan, in improvement of quality of life, as well as the same molecule, how it improves the clinical outcome, overall clinical outcome in this group of patients, followed by conclusion. So why improving quality of life in heart failure patient should be one of the key management objective. Let us go through that. So many a time, whenever we give talk, we discuss about heart failure with reduced ejection fraction. We are very, very concerned about the outcome because this is a high mortality situation, 50% mortality at the end of 5 years. But seldom we ask the patient about their personal, very, very personal thing. How is the quality of sleep? How is the sexual life of the patient? Heart failure is not a good thing to have. So is the patient suffering from depression, any other psychological issues or not? And yes, fatigue, shortness of breath, edema, this thing we do take care. But many times these are often neglected issues in heart failure patients. So significantly reduced score of quality of life has been shown in different trials to be directly related with the long-term outcome of the patient. I'll go through a few important data. This is the data from Alberta Heart. So heart failure leads to decline in the patient's quality of life over time. And this is the clinical evidence which suggests that 32.4% of heart failure patients experience a more than equal to 5-point worsening of the Kansas City quality of life overall summary score at 12 months. So that is a very, very significant information and piece of evidence. Now, what is the impact of quality of life impairment on heart failure outcome? I already mentioned it has direct correlation with the long-term outcome. So composite outcome of mortality or heart failure hospitalization were inversely related to the quality of life score. So though there is no direct correlation, but indirectly, it also leads to improvement of the mortality and morbidity of the patient. Now, the same piece of data also suggests that patients with greater impairment of quality of life showed higher risk of mortality and heart failure hospitalization. There was 1.5 times higher risk of mortality and heart failure hospitalization in heart failure patients who had experienced a 5-point decrease in the Kansas City quality of life score. And also the mortality rate increases with the heart failure patient with higher NYHA class and greater impairment of quality of life. And global congestive heart failure study incorporating 23,000 patients from 40 countries has given us this information that 1.17 time increase in the risk of mortality in part 10U decrement of the quality of life score and also 1.14 time increase in the risk of mortality with the same sort of individuals. So in a nutshell, poor quality of life in patients with heart failure is linked to negative clinical outcome and also it linked to high rate of mortality and recurrent hospitalization. Therefore, regular assessment and improving the patient's quality of life plays a very vital role in improving their clinical outcome and also the better management, overall management of the heart failure and reduced ejection fraction patient. So what about the guideline? Are they silent about the quality of life? So this is the 2021 ESC guideline. They mention that assessing quality of life is one of the vital components in heart failure management program as recommended. So nowadays they give importance to the psychosocial problem, apart from the normal usual heart failure markers. So psychosocial problems, sleep, sexual activity, everything has been taken, given importance. So recent guideline, this is the overall guideline of heart failure with reduced ejection fraction. 2021, it's all same, but few new things because ACE inhibitor, ARNI or beta blocker, MRA, they are class 1 medicine along with the SGLT2 inhibitor, but few ARNI becomes a cornerstone therapy in this group of heart failure with reduced ejection fraction patient. And it's very important to understand ARNI may be considered as the first line therapy instead of ACE inhibitor in all heart failure patients. So de novo initiation of ARNI is now a class 1 recommendation as per the all the recommendation bodies, including ESC as well as ACC. And initiation of sacubitril valsartan in ACE inhibitor naive patient with heart failure with reduced ejection fraction has been recommended to be considered. And not only that, they also mention it can be even started or initiated in hospital. Why in hospital? Because only then it is possible to take care the immediate post-discharge 1 month period. So that is why the guidelines are very slowly changing. ACC 2022, they also have similar kind of recommendation in favor of sacubitril valsartan as the first line therapy for all heart failure with reduced ejection fraction patient. And the chronic symptomatic heart failure with reduced ejection fraction, ACE inhibitor ARB, if already the patient is on ACE inhibitor ARB, it should be, replaced even if the patient is asymptomatic. Why? Because that can take care of the, further reduction of sudden cardiac death and long-term outcome and mortality benefit. So heart failure, reduced ejection fraction therapy and their impact on quality of life. What evidence do we have? So improving quality of life is a target for increasing interest when evaluating heart failure therapies. And first-line that have been shown to improve the disease prognosis have had mixed results with respect to quality. Let's see how the other class 1 recommendation drug, do they improve? Do they have any effect on the quality of life? Now, beta blocker do not improve quality of life. So that is for sure. We do not have any evidence in favor of beta blocker, and there is mixed result with ACE inhibitor and ARB. So sacubitril valsartan has shown to improve the quality of life consistently across different trials. So role of sacubitril valsartan in improving the quality of life in heart failure patient with reduced ejection fraction. So it helps improving quality of life, functional capacity. So improvement of quality of life and functional capacity has been documented with improvement of the Kansas City quality of life score, peak VO2, 6-minute walking test, respiratory efficiency, and domestic activity as well as sexual activity. These are evidence which we are having. All the important parameters of quality of life has been shown to be improved with ARNI, and that is very, very consistent result. And if we see further, it helps this kind of patient to feel better and be active. There was significant change in the score difference with sacubitril valsartan compared to original analysis at 8 months. So even in long run, it has consistent improvement. So following initiation of sacubitril valsartan, improvement of this quality life score occurred early within 2 weeks and were sustained across a 12-month follow-up. So that is very important, very early improvement, and that improvement actually is getting sustained. So very, very robust, important data. And it has also showed that greater improvement of the quality of life compared to ACE inhibitor and heart failure, ACE inhibitor and ARB. And there was 4.5 points greater improvement in the overall score with sacubitril valsartan compared to NRP. So this is the evidence which we are having. Now, sacubitril valsartan also helps the heart failure with reduced ejection fraction to live longer. Treatment with this molecule, mean improvement of survival is around 9 years. So that is very, very important. Not only they are getting a better quality of life, they are living longer. So assessing whether your choice of therapy is improving patients with quality of life made easy. So this is a kind of journal which is available. If you can ask your Novartis guy, you can get it. And some of the hospital already has implemented. Our hospital, we have it. And by this, if you implement it, you can see clearly how much improvement of quality of life actually is happening to your patients. Additionally, sacubitril valsartan improves the clinical outcome. So this molecule helps your patient to live longer and stay out of hospital. At the same time, it also improves the quality of life. So this sacubitril valsartan, along with other GDMT, shows superior reduction in mortality. Can it be combined with other molecule? There is clear-cut evidence that 62% reduction in the risk of all-cause mortality with sacubitril valsartan, along with beta blocker and mineralocorticoid receptor antagonist in this group of patients. And at the same time, 42% reduction in the risk of all-cause hospitalization and along with sacubitril valsartan, a beta blocker and MRA are actually being co-prescribed. So they can be co-prescribed with other class 1 molecule, and it has shown to improvement of the cardiac function. So not only the quality of life is getting better, the mortality is coming down, survival is improving, but also echocardiographic parameter. We all know that whoever is using this molecule, there is consistent improvement of the ejection fraction. In the study, it is shown that 12.8% improvement of the ejection fraction if we use this molecule over a period of 12 months. And not only that, the parameters of echocardiography in systolic volume, in diastolic volume, in systolic diameter, in diastolic volume diameter, everything actually has a very consistent improvement after 12 months of continuous use. So if I summarize, improving patients' quality of life should be considered as an important aspect while managing all heart failure with reduced ejection fraction patient. So we should initiate sacubitril valsartan in heart failure with reduced ejection fraction patient with confidence. It will improve the quality of life. It will improve the physical and social activity. It will improve the clinical outcome. It will improve the cardiac function as well. So with that, I'd like to stop here. Thank you very much.
Thank you, Arindam, for your very elaborate and very good discussion. Just I initiate the question, only a few questions. The question from my end is that which particular subset of patients with heart failure with reduced ejection fraction who are best benefited so far as the quality of life, which is your main object in speaking, which subset of patients are best benefited so far as quality of life is concerned from ARNI?
So which subset you meant to see the, different spectrum of infection?
Actually,
in Eiicon class.
Anyway, you can tell the Eiicon class or the ejection fraction.
So the study shows that the benefit in terms of improvement of quality of life is seen across the board, irrespective of the NIH class, irrespective of the ejection fraction. But yes, someone who is very, very symptomatic, class 4 symptomatic, we do not expect that the gentleman or lady is going to have sexual activity. So we should not, jumbled up our expectation also, but rather a patient who is, class 2 symptomatic. If we initiate this molecule, probably his sexual life can be better. So rather, in a very advanced heart failure patient, symptomatic patient, we should focus on the sleep or the mental anxiety, depression, anxiety. Those parameters might get improved better way. So different, component of quality of life, we should focus in different subset, advanced heart failure symptomatic subset or, lower symptomatic subset.
Another thing, as Dr. Banerjee was talking about, when you are discussing about the improvement, it is hardly not alone because we often use multiple drugs. So the whole team of drugs are responsible for the improvement of the patient.
I fully agree with you, sir. We should try to give maximum number of medicine because this is not a good thing to have all the molecules which are shown to improve the mortality. But if we look into the evidence, the improvement of quality is there only with
I was coming to
other molecule, though they have very
that you have highlighted the issue of quality of life besides the longevity. Initially other studies have been mainly focusing on longevity, but newer studies, they are highlighting the issue of quality of life. And you have already shown that the quality of life is related to many aspects of the patient's well-being. So it could be physical, social, and psychological and emotional. All these components are very important. And we all know that the prognosis of the heart failure has now become even worse than many of the malignancies. Initially, it was likened only with the malignancies, but it is now with the development. Fortunately, we have got ARNI now, which is showing some evidence in favor. Now, the issue is how to use ARNI. This is also very important. When you are talking about improvement in quality of life, do you think it is dose related, that you have to escalate the dose, or you just fix up, start up, keep it there?
So
What's the message to the audience?
Yeah, I feel the evidence suggests that we should always try to build up the dose because maximum benefit is seen at highest dose. But even if we cannot achieve that highest dose, the recommended high or recommended dose, rather 200 milligram twice a day, whatever dose we achieve will get better benefit compared to ACE inhibitor. So that should be the message to the audience.
So the message is guideline directed medical therapy. First of all, the attempt should be, if it is not possible, at least maximally tolerated dose. The essence is whatever possible to give it. Don't refrain from giving it. So that is very important. And do you think, I am just, you have highlighted the issue of ARNI, beta blocker, diuretic, MRA, etc. Any thought process about Verquvo?
Verquvo is a new kitty in the treatment of heart failure. Verquvo, as we all know, it has been evaluated in worsening heart failure patients. As of now, we do not have any evidence in chronic heart failure patients. So worsening heart failure is a different entity. All the guideline, ESC, ACC, they are now focusing on the worsening heart failure. This is because important entity. It has some strong correlation with the mortality of the patient. In those group of patients in Victoria trial, Verquvo was evaluated. There is another very large trial which is going on known as Victor trial. As long as we do not have the data from the Victor trial, we actually not in a position.
When we will be not waiting for worsening heart failure, it is another member it will be given because it is easier to give. Potassium, creatinine, BP, these are not the major hindrances, which often become a hindrance in case of ARNI. And
I fully agree with your point, sir, but we do have evidence only.
We have to wait for some time.
Yeah, we have evidence only in worsening heart failure patients as of now. In future, these points are very important.
From the audience, otherwise we'll be inviting the next participants. So thank you very much. You have been doing a very good job as usual. Thank you.
Thank you so much, Dr. Pandey, for your contribution. Now we move forward with the next topic that we have of this particular session. For this, I will invite Dr. Aftab Khan to please come up on stage. And his topic is evolving evidence with ARNI, implications across the spectrum of LVEF. So we have Dr. Aftab Khan. Before he starts off, sir, aap kya khate ho? How does this energy come from you? Because you were just in the OT and then we have you here, like we were awestruck.
Me run all the way from Apollo here. So I think the credit goes to him rather than to me. So thank you so much. And it's an honor to be here in front of my esteemed teachers here.
Timer, please. Timer.
Yeah, and it's not showing in the slides.
Oh, you are using your own computer.
So the problem is with
So we just require some time to set up. So I think we are. No, please allow us some time so that we can just get through with this technical.
Or if there's a next speaker you want to start with, I'll one set this up.
So it will again happen because the laptops will be changing. So again, if we call upon next speaker, we can, but the setup will be done again.
No, do you have this thing? Then I'll shift to another, I'll change to a PowerPoint presentation. So this is a MacBook, so I think there's a problem with Mac.
Okay, sir, do we have the permission to move forward with the next speaker?
So yes, who is the next speaker?
No, okay. So as of now, we move forward with the next speaker. May I request the presence of Dr. Shubhashish Mishra, please come up on stage, and his topic will be clinical outcome of EVPRO everolimus eluting stents 2-year observation data in real world scenario by Dr. Subhashish Mishra. So we move forward with the third session as of now. We will be back with the second session in a while. Post this.
So was the, anyway. Subhashish Mishra. Okay. He is speaking on the clinical outcome of EVPRO everolimus eluting stain 2 years observational data in real world. Yes.
I am grateful that I am sharing the stage with a lot of eminent cardiologists of the India, and I'm thankful to the Eiicon. And also, I am apologizing that my topic is not included in the heart failure symposium. It is something different, so that this could be just ignored. So let us have some, my topic would be based on the everolimus eluting stent, and just have a look about the historical milestone. About the last 50 years, we have achieved a lot. From the 1976 to the starting of the balloon angioplasty by Andreas Gruijing, and then the first coronary stent in the 1991, in the mostly in the 20 years, we have achieved in 2011 the biovascular scaffold without metal. So this is the era where the golden era of the interventional cardiologist, and there is a lot of human benefit from this discovery of the stent. So what problems we encountered during the stent technology? The first bare metal stent, they have lot of restenosis, and this is taken to be the intimal proliferation. So then the cytotoxic drugs or the antiproliferative agents comes into the role, and then the first generation stent, which are paclitaxel eluting drug stents, they came to know that the restenosis rate is lower, but comes with a thrombosis rate. Then the second generation drug-eluting stent, that is the Limus family, and this have a lot of beneficial effect where the restenosis rate is lower, the thrombosis rate is lower, and then we have right now the biovascular scaffold, but the problem with biovascular scaffold is mechanical performance. So my topic will be based on the drugs, but there is 3 things in the stent, where the stent metal, the polymer, and the drugs. So both all the 3 plays a role in the achieving a better outcome. So with the second generation drug-eluting stent, we have a thinner stent strut technology, and also the biodegradable polymer, which helps in the achieving the final outcome. So what is the difference between the sirolimus and the everolimus is just a molecular advantage or molecular difference between the sirolimus and the everolimus, but everolimus achieved a higher bioavailability and a shorter half-life than the sirolimus, and so it has found out that it decreases the vascular inflammation and promotes the rapid endothelization. That is the main thing where the everolimus nowadays become the most widely used drug-eluting stent in the clinical scenario. So these are the some of the commonly used stent in our day-to-day practice, and we will find out that mostly the Giants family, the Giants Alpine or the Giants Sierra, have the everolimus as a drug, and also the Synergy, which is found out to be a most widely used stent, and these are having the everolimus. What other drugs we have in the limus family is jotralimus and the biolimus, and other drugs are on the point of discovery, and also their luminal coating. So first, let us review some of the clinical outcome about the everolimus eluting stent. So I'll go to straightforward the meta-analysis about the everolimus eluting stent versus the paclitaxel eluting stent, and these are the SPIRIT clinical trials program. The SPIRIT is from class 1 to 4, and this meta-analysis showed that in comparison to the paclitaxels, the everolimus eluting stent, the target lesion failure is significantly reduced. So it has almost reduction of 29% reduction in the target lesion failure. And what is more important is all-cause death and myocardial infarction is also reduced by almost 30 to 40%. So this meta-analysis showed that everolimus eluting stent or the second generation stent is actually beneficial in the clinical scenario. But another very important point comes from this meta-analysis is the stent thrombosis rate. So the stent thrombosis rate has reduced in the everolimus eluting stent in comparison to the paclitaxel eluting stent, and the everolimus mostly because of this reducing the vascular inflammation, have a controlled intimal proliferations, and all these drugs has a beneficial benefit in the reducing the stent thrombosis, but we should just not ignore the stent technology also. So the conclusion from this meta-analysis that this emphasized that stent selection decision can markedly affect the long-term outcome of the patient with the coronary artery disease undergoing the PCI. So we have to individualize the stent choice when we're going for a clinical field. So one important aspect about the decision making is the diabetes mellitus. So diabetes is a patient which we have found out that that a lot of stent thrombosis rate is higher, and this meta-analysis showed that everolimus eluting stent has a significantly lower rate of stent thrombosis in the diabetes mellitus. Then also there is a difference between the paclitaxel and everolimus eluting stent. This is the Tuxedo India investigator trial. This is the Indian data where the stent thrombosis rate is found out to be significantly better in the everolimus eluting stent. And this is true in all subtype of the patient. So another drugs, another stent where comparable is a jotralimus and the everolimus, and this is that the 5-year report from the Resolute Allcome trial. So jotralimus and everolimus coronary stents found to have almost similar efficacy, and these stents have equally good outcome during the long-term outcome. So the second generation stent about the drugs, the everolimus and jotralimus, is almost comparable. Now, this is the 1-year data of systematic analysis and meta-analysis of six randomized control trial about the stent thrombosis, because stent thrombosis is one of the important factors when we choose the choice of the stent. And so jotralimus is also comparable to the sirolimus in reducing the stent thrombosis. So real world data is very important. The real world data, this is the real world data from the USA, the Giants V USA, where you can find this important point is DAPT interruption because of the many reasons. The DAPT is interrupted within 6 months. Even if the DAPT is interrupted within 6 months, the data showed there is not a marked increase in the stent thrombosis. So stent thrombosis rate is almost equal or comparable. So this real world evidence also suggests that the everolimus eluting stents are equally benefit. And this data comes from the India, the real world data from the Giants V India, and Giants V India has a similar result from the Giants V USA. So about some imaging study that is OCT and IVA study about the everolimus eluting stent versus the jotralimus eluting stent. We will not go to the first generation drug eluting stent. So jotralimus and everolimus, both the stents you can see by the OCT trials that the uncovered stent stress or the stent foreshortening is equal, and this is almost comparable. So everolimus eluting stent is almost comparable to jotralimus eluting stent when the imaging study has taken up. And this is the second IVA study, the restent ISR. The restent ISR also showed the neo-intimal volume the late luminal loss, and the percentage of luminal stenosis is almost same in both the group, that is Jotralimus and the everolimus group. So all the real world data, the meta-analysis and the imaging study, they found out that everolimus eluting stent is better than the paclitaxel eluting stent, and it is almost comparable to the Jotralimus eluting stent. Now coming to this data about the retrospective study, that is phase 4 trials of the everolimus eluting stent, that is EVIPRO. So this EVIPRO is from the SLT, that is Sargent laser technology, and this EVIPRO as a very thin strut technology with a biodegradable polymer, and it has innovative S and C linked 8 crown design, and also the foreshortening is very minimal, that is less than 0.2%. So this is a retrospective single arm and the multi-centric and observational post-marketing clinical follow-up study where 500 subjects have been enrolled, and I think this is cleared from the ethical committee and the quality of standard care. And the main object of this study is to evaluate the safety and performance of the EverPro, that is everolimus eluting stent, in patient with a de novo coronary artery disease under a real world setting. So the primary endpoint is a target lesion failure, that is from 12 months, but more follow-up data is coming. So follow-up is taken up by 12 months, 3 years, and 5 years. There is multiple secondary endpoint, that is cardiovascular death, target vessel myocardial infarction, clinical driven TLR stent thrombosis, target vessel failure, target vessel revascularization, device success, procedural success, and quality of life. So all the patient implanted with EVIPRO, that is EverPro cobalt chromium everolimus eluting coronary stent system, will be included in the consecutively as part of this study. The excluded criteria is the same as the other trials. So mostly the patients which has been by medical history is differentiated between the diabetes mellitus and hypertension constitute the most of the patients, and other the smoking. And regarding the ACS, the most patients are from stable angina, and in the ACS STEMI taken the main proportion. So the is mostly around 60 plus minus 10, and that is male female ratio is 73% versus 26%. Now we'll come to the what is the lesion morphology. Mostly single vessel disease have been taken up, and SEC classification are a B2 classification lesions are mostly taken up. So what is the result is that there is no incidence of TLF observed at 12 months follow-up after implantation of EverPro DES1. The device success rate is almost 98.5%. So we will not go to this particular study, just highlighted this study because this has only 500 enrolled patients. So there is no cases of stent thrombosis or CDTLR or all this taken. More long-term follow-up is needed to actually establish this stent's outcome. But this is a short-term trial, short-term study. So only 2 year follow-up. But in a nutshell, we can say that everolimus eluting stents has a better efficacy and almost similar result to the Jotralimus eluting stent, and should be, and in the for the diabetic populations, and also from the stent morphology like bifurcation and the complicated coronary anatomy, the everolimus eluting stent has a better result. So the present study demonstrated a favorable safety and performance of EverPro DES1 for improving luminal diameter and reducing the restenosis for the treatment of de novo lesion in the native coronary arteries in patients with a reference vessel diameter of 2.25 to 4.5 millimeter in patient eligible per PTCA. Overall, the finding of this interim study report provides an essential insight into the outcome of the study with a lowest rate of MACE and demonstrated the value of conducting rigorous and comprehensive research. So MACE had not occurred through the 12 months follow-up period, which established a basis for the early clinical safety of this device, but longer term follow-up is needed for a better outcome, to know the better outcome. Thank you.
Thank you, Dr. Miశ్ra. Can you go back to your slides so that we can find the lesion property as well as the arterial property, whether it's proximal, LAD, distal, and also, yeah, you have given the patient profile, but the lesion profile, arterial profile, you have mentioned about 1 vessel, 2 vessel, 3 vessel, but whether how many are LAD, how many are proximal, how many are difficult. Another thing, this is not a comparison data. This is basically a real world data because we cannot compare two things until and unless we tell about each and every detail. For example, patient detail, procedural detail, imaging, whether has been used or not, how much pressure has been, whether optimization is regularly done or not, whether all the centers have been doing performing. So procedure is also important.
Yes.
And what about the polymer you have used?
That is
Because
PLA,
that is also
biodegradable
important in the outcome.
Yeah.
And strut thickness, coating technique, release kinetics, whether it is abluminal or covering the whole thing. You have just mentioned about covert chromium. So I think we have to wait for further things before commenting. Any Prakash, Aftab, any questions or comments? Arindam?
So initially, sir,
because main thing I found the superiority of everolimus. That has been the main crux. That we all know. What specific about this stent?
That we have data, but the platform which were used on this platform, this is a new evidence. And though it's a small study, but it's encouraging result. I think by this study, it will be approved for users in India.
Yeah, it should be approved.
So then we need to use it and find more, comfort level and all.
This has been newer data, so just a 2-year follow. But that is why I have told you.
Any comment?
So I think that what your concerns are really genuine, because I think it's just the drug, because the drug has been there for quite some period of time. I think now we are looking at the benefits that are related to the safety of the drug, as well as the fact the release kinetics. So I think we all know that certain long-term effects that we get is based on the efficacy is based on the release kinetics of the molecule, but certain long-term effects in terms of stent thrombosis is based on how much polymer gets left behind after a period of time. So how does the degradation of the molecule happen? So these are exciting times when you're going for thin struts also. So I think all those are also equally important. So the molecule is, of course, something that's been there for many years, and we know that it's efficacious. But as Professor was saying, that I think we need to have more data on, and since this is a pilot study, I think we will probably get more data on how
this is just initial follow.
Thank you so much. Prakash, your final comment? Okay. So hold on. Okay. So it has been a nice presentation, and we shall be waiting for further results, further usage.
Yes.
Thank you.
Thank you. Thank you.
After, are you ready for your talk?
So we conclude this particular session now. Thank you for your contribution, Dr. Mishra. Now we are again back with evolving evidence with ARNI implications across the spectrum of LVEF by Dr. Aftab Khan. So I guess, yes, we are here.
Yeah, apologies for the delay there. So I think Dr. Arindam has already spoken about the quality of life scores. And we now know that ARNIs are approved as class 1 indication for patients with heart failure with reduced EF. Now the data gets a bit murky, and there is a certain confusion that happens when we're talking about the mildly reduced EF or the persons with preserved ejection fraction. And that's where my focus would be, to try and see what the evidence is there in patients with the mildly reduced and the preserved ejection fraction. So when we look at the mildly reduced ejection fraction patients, and now that the guidelines tell us that anything less than 40% is reduced EF, 41 to 49% is mildly reduced EF, and anything more than 50% is preserved EF. We know that these patients who present with preserved EF have a different subset of clinical presentation. They are usually women, they are obese, they have atrial fibrillation, they have many metabolic risk factors, whereas patients who have the low or the reduced ejection fraction tend to have more of ischemic heart disease. They tend to have more of LV dysfunction producing renal dysfunction. So these are more common in patients who have the reduced ejection fraction, whereas patients with the mildly reduced ejection fraction tend to fall between the two. So when we look at the mildly reduced ejection fraction, the ischemic heart disease component is similar to the patients with the reduced ejection fraction. So these patients have ischemic heart disease as one of their primary reasons for LV dysfunction. Whereas when you look at the renal disease, patients with mildly reduced ejection fraction tend to have more renal disease similar to the patients with HFpEF, because they often tend to have many of the associated comorbidities. They tend to have atrial fibrillation or many of the other metabolic syndromes that patients with preserved ejection fraction may have. And therefore, the treatment mostly falls into the category where most of us would treat a mildly reduced ejection fraction similar to our patients with reduced ejection fraction. And therefore, it was suggested that drugs which are useful in patients with reduced ejection fraction may also be equally efficacious in patients with the mildly reduced ejection fraction. This is something that, again, I said, patients with mildly reduced ejection fraction often tend to have ischemic heart disease and new ischemia as one of the reasons for their clinical presentation. And disease, there is evidence also in the trials to say that ischemic etiology is a common feature in patients with the mildly reduced EF, similar to patients with the reduced ejection fraction. Now, what is the data that we have for patients with mildly reduced ejection fraction? So this is a small study which was done, published recently, almost last year, which looked at the efficacy of sacubitril valsartan in treating patients with heart failure with the mildly reduced or the mid-range ejection fraction after myocardial infarction in diabetic patients. So when we go to the MI studies with valsartan sacubitril, I think we had a negative study there, though the statistical data was not reached, but there was a lower figure in patients who were on sacubitril valsartan as compared to ramipril. So this study is one of the studies which has looked at the biochemical parameters. So it has looked at ejection fraction. Here it looked at the ejection fraction after a period of 12 months of initiation of sacubitril valsartan in patients with a mild reduced ejection fraction after the myocardial infarction. And they found that the LV ejection fraction improvement is significantly more in patients with on sacubitril valsartan. And similarly, you get an LV remodeling. You get a better LV, lower LV dimensions after 12 months as compared to baseline once patients are on sacubitril valsartan, and a lower risk of rehospitalizations in the mildly reduced ejection fraction or the mid-range ejection fraction post myocardial infarction. So this study is different than the previous study, which was done in patients with reduced EF. So this is a study which is a positive study, and this gives us some hope that you can possibly have data to use it in patients in the mid-range of ejection fraction. Similarly, we all know that many of the data that we have looked for, and similar to an SGLT2 inhibitors also, ARNIs have also had a dual effect. Not only do they have an effect on cardiovascular prevention, they also have effect in renal protection. And this is one more study which has looked at the outcomes of renal dysfunction in patients with the mildly reduced ejection fraction. And again, this is a slide that we all know from our physiology days. There's a vicious cycle that goes in patients with LV dysfunction and in heart failure, and the renal function lipid progression that happens over a period of time. Creatinine is an important biomarker, and this study that we are talking about, it looked at creatinine, and a creatinine of almost 1.3 was the cutoff mark. Patients who have renal dysfunction also are definitely, along with LV dysfunction, are at worse risk of having future events. And again, this is a slide which is a little busy slide, but what again we understand is that patients who have association between LV dysfunction and renal dysfunction is much higher in patients who have LV dysfunction. So patients who have HFrEF or HEF with mildly reduced ejection fraction are more likely to have a renal dysfunction associated with their LV dysfunction rather than patients with HFpEF, where the renal dysfunction may be a little lesser. Again, the benefits of sacubitril valsartan in patients with heart failure, reduced EF and mildly reduced EF, and patients with coronary artery disease and CKD was assessed. And again, this showed that there was a positive result. Sacubitril valsartan did result in a benefit in terms of improvement of renal function and a reduction in the deterioration of GFR over a period of time. Coming back to guideline recommendations, earlier for the patients with mildly reduced EF, ARNIs were prescribed earlier only for patients with reduced ejection fraction, where we know that it's a class 1 indication. For the mildly reduced EF or for patients with preserved EF, we only had diuretics as the class 1 indication. And we had data from SGLT2 inhibitors, which were put it in the class 2A category. But with the recent guidelines, ARNIs have been given a 2B category, where the data says that there is some evidence to say that you may consider using ARNIs in patients with the mildly reduced or with ejection preserved ejection fraction also. So there's a 2B recommendation, and this is based on certain studies that we now know of. So these are the guidelines now. So what is the evidence that is coming up now? So there is biochemical difference, definitely. So when we know that when you look at NT-proBNP, definitely there's an improvement when you're using ARNIs. There's an improvement in quality of life scores, also similar to the reduced ejection fraction group of patients. And we know that it reduces the readmission and the hospitalization rates with heart failure in this group of patients. So is this a time for us to adopt it in all the spectrum of patients, irrespective of the ejection fraction? Well, there is now data which is now looked at the pool data from Paragon and Paradigm HF. So Paragon HF was a preserved ejection or data which looked at preserved EF, where the EF was more than 45% in the group of patients of Paragon. And Paradigm HF was, of course, with reduced EF. And when they did a pooled analysis of these group of patients, what they found is that patients with the mid-range, though Paragon was a negative study when you look at statistically, but when they did a subgroup analysis, they found that the benefits could extend even till an ejection fraction of 57%, or in ladies especially, so women had a better outcome. But again, when you look at all outcomes in terms of reduction in total heart failure hospitalizations or the risk of cardiovascular death, there was a tendency towards a reduction in the pooled analysis of Paragon and Paradigm. Now, coming back to recent evidence, so this is a late-breaking discussion. The Paraglide HF trial, this was published recently at the Prague heart failure meet. I've lost the slides. Okay, so this is basically, now we know for sure that for patients who have a reduced ejection fraction, there is data. But for mid-EF, mildly reduced EF, or for preserved ejection fraction, there was still a data that there's a positive data. Now, Paragon HF was, the criteria for Paragon HF was that these patients should have to be stable at least for a period of 6 months. So they should not have had an episode of acute heart failure hospitalization within the last 6 months, or they should not have had an acute myocardial infarction within the last 3 months. Now, unlike the Paradise MI trial, the Paragon HF trial looked at it beyond 6 months. But we know that many of our patients may not be waiting for 6 months, and most of the guidelines are not talking about early initiation of ARNIs. So therefore, the Paraglide HF trial looked at an early initiation of ARNIs after an episode of heart failure hospitalization. And this was done either inside the hospital or within a 30-day period. And what they did is they looked at biochemical parameters at 4 weeks and 8 weeks. And they also looked at secondary events in terms of cumulative composite endpoints of heart failure hospitalization and composite of renal worsening also. The other thing to note is that in this trial, the systolic blood pressure cutoff was kept at 100, and the eGFR cutoff was more than 20. So they looked at more stricter, a more sicker group of patients than the Paradigm HF group also, where 30 was the cutoff. And in this trial, this is again important because the Paragon HF had shown women showing some benefit. And therefore, the Paraglide HF again had almost a 50% or women who were included in this trial. And again, if you look at this slide here, you can see that when you have a subgroup analysis of the ejection fraction, you had an ejection fraction of 40 to 49% in almost a quarter of patients, 50 to 60% in 52% of the patients, and another quarter had a supranormal EF of more than 60%. So these are patients who are real life patients, and these here patients who are randomized in hospital in almost 70% patients. So here the patients were started on medications early, unlike the Paragon HF where we had started late. And a subgroup analysis of Paragon had said that probably an early initiation of heart failure of ARNI would have made the difference. So this was a positive trial in terms of biochemical improvement. So there was a reduction in the NT-proBNP of almost 15%. And this is something that I think all of us now look at is the win ratio. So when they looked at the win ratio of sacubitril valsartan over valsartan alone, there's almost a 19% win of overall, there's a 40% win of sacubitril versus 31% with valsartan. But when you look at all the components, whether it's heart failure, hospitalizations, urgent heart failure visits, or cardiovascular death, there is a win of sacubitril valsartan over valsartan alone. And again, when they looked at an ejection fraction less than 60%, what we normally would call as the preserved ejection fraction, again, you see that there is a win, and this win is more in the patients with the ejection fraction less than 60%. So anyone more than 60%, we still would say that we don't have enough data, but less than 60%, probably we still have, we can say that we could probably benefit from ARNI also. They also looked at additional outcomes in this Paraglide HF trial. And what they found is that the composite endpoints and the recurrent renal endpoints were also in favor of sacubitril valsartan. Safety was also a concern for us. And of course, renal worsening was much lesser in sacubitril valsartan as compared to valsartan alone, though not statistically. And there was no increased incidence of hyperkalemia or symptomatic hypertension in sacubitril valsartan as compared to valsartan. So to summarize, I would say that we now have data to say that in patients with reduced ejection fraction, we know that yes, we must start sacubitril valsartan early. When it comes to mildly reduced EF or in patients with preserved ejection fraction, well, the data says that we should think of opt-out. So we have to say whether the patient would benefit. And if the patient cannot be given, we need to have a reason to say why we are not putting these patients on an SGLT2 inhibitor or an ARNI or an MRA. So for a low ejection fraction or reduced ejection fraction, it's always an opt-in where we'd want to start these drugs. For a preserved ejection fraction or a mildly reduced ejection fraction, it is an opt-out where we have to exclude these patients and see which of these benefit. There is data possibly to suggest that we would have reduced NT-proBNP, and we have improvement in terms of reduced hospitalizations and possibly an all-cause mortality. And these benefits are more when you have a patient more towards the reduced EF. So when you have a patient who's probably in the range of, say, 45 to 60, these are the patients who are more likely to benefit rather than someone who has an EF more than 60%. So with that, I'll stop my talk here, and I'm happy to take any questions.
Thank you, Aftab, for your excellent presentation. Actually, this concept of giving ARNI to patients with mildly reduced ejection fraction came into the minds of the heart failure specialists. It has been shown that many of the patients who are in the category of the reduced ejection fraction, when they improve and the ejection fraction goes beyond the 40%, and they are still being continued, the ARNI and other drugs, they are still benefited. Then came the concept, let us see how far this up to the ejection fraction. Then first it was decided that up to 50%, it might be beneficial. Now the latest trial data, which you have shown, that up to 60%, both SGLT2, though SGLT2 has some age over ARNI, those who are with a mildly reduced or ejection fraction more than 50%, some age over ARNI, but it is still in the last year, ACC, they have recommended the patient as early as possible. If you start these are practically the disease modifying drug. So if we start this drug early, the patient will be more benefited. There will be less further or very slow deterioration of LV dysfunction. And particularly the ischemic group, they are the best benefited from this group of drug. Any comment from?
Thank you. Aftab, I'm very happy with your presentation because what Arindam showed, that quality of life is also improved and there is no debate and doubt in HFREF, but you have gone with higher up EF. Now, the FDA recommendation has already been like this. It is not only recommended for reduced, but also in any EF, so to say, not only restricted to 60. But by that, the doctor thinks that he will be improved with this patient. So, in that case, he is open. But overall, even ultimate comment has been that probably that will be more beneficial in lower the EF is. And when the study, sub-study or subset analysis was done, it was that the females improved a bit more better. 57%, up to 57%, there was some improvement. Now we are showing the results of 60. Suppose I'm asking everyone, somebody gets a heart failure with 65% ejection fraction, Some methodology shows it is 62, some doctor shows it is 67, some doctor shows it is 65. This may have happened in Delhi today. Would you start earning in those cases? Even in heart failure?
Yeah. So I think the concern is mostly, I think I think that's a very general question that we've asked for all of us is the coming to diagnosing heart failure with preserved EF, and that always becomes a concern. And when it comes to a patient who has classical symptoms of orthopnea, has fluid overload, has effort intolerance, it becomes easy for us to diagnose heart failure. But the problem comes in patients who don't have these conventional symptoms, who have only on exertion. And we know that sometimes in preserved EF, you may not get an NT-proBNP, which is very high, very high. You know that in so your echo becomes your friend for you. And I think that's where the echocardiographers need to look at more carefully. I think we need to look at, especially if you have a very hypercontractile EF, then I think it's important to rule out secondary causes. I think if you have thickness there, we want to rule out amyloidosis, rule out the other things also. And the heart failure mimics, as we say, a patient who has a pericardial disease. All those things also need to be ruled out before we really rush to say that this is heart failure preserved EF. So the problem is usually in diagnosing. I think that's where most of us have to speak to our echocardiographers and give them a heads up to say that we are suspecting heart failure in this group of patients. And if they can look more carefully into the E to E prime ratio, look at our left atrial volume indices, look at your LV mass thickness, and give us an idea whether this is in. So I think that 62% is okay on paper, but I think it's the clinical assessment that will make a judgment whether you want to start this. And as I said, it is always opt out. So we would want to start unless we have some other pressing reason. And for a patient who has a very high EF, I think we would want to rule out other causes also, which are possibly maybe correctable in these group of patients.
Patient profile is more important rather than this EF. That is rather artifactual classification, up to 40, 49. And another thing, hopefully, I am hoping that this will no longer be limited to 2B in heart failure with MREF. Sooner it is going to be class 1. Any comment from Prakash or Arindam?
I think
Kashi is also there.
I think where we have started, we started with lower ejection fractions, and they get the most of the benefit. But as a whole, the people who are living with 40 to 60%, they get the best benefit of this molecule because they are larger in number. So in the society as a community level, the people living with 50 to 60% ejection fraction is much higher than people living with 15 to 20% ejection fraction because they're not going to have a 10 years longevity. And second, if you have one episode of heart failure, this time has come to replace ACE inhibitor ARBs with ARNI because of certain things. Now we know that the hyperkalemia is much less with ARNI. The blood pressure control is much stronger and better than ACE inhibitor or ARB. Conceptual, I would say, conceptual is much higher. Prevention of renal failure in long term is much more in favor of sacubitril valsartan because, especially if you combine with SGLT2, so many of our patients either pre-diabetic, diabetic, they have metabolic syndrome, and they have our potassium intake of Indian diet is much higher because we are mostly vegetables and fruits. When fruits though you don't take much, but carbohydrate diet is much in quantity than the European diet or in Japanese diet. So we have a problem here that higher incidence of diabetes, higher incidence of CKDs, and higher incidence of potassium. So if you can adopt ARNI on the very first day of any heart failure, don't look at the ejection fractions. That would be the futuristic and intuitive and thought-provoking.
That is the essence, to be precise.
But as you said, the lower the ejection fraction, there are more evidence. So evidence will be lesser, but benefit as a whole in the community, the world, will be in higher ejection fractions. Thank you.
Are you moving in the same direction of SGLT2 inhibitor, like the DELIVER trial, that ARNI can be given across the ejection fraction in all the patients?
Actually, when the trial with the ejection fraction, I mean, preserved ejection fraction was conducted, it was seen the bus was narrowly missed on the 0.06 of the p-value. probably, and subset analysis also showed that some patients benefited. So maybe with further usage, your question may be answered. Any comment from your side?
And regarding just few days back, the article has come up.
Yeah. So this in the Paraglide HF. So what exactly is the Paragon HF had started 6 months after your last episode of hospitalization. We started with a much stabler patients, but now we know for the ARNI, the early initiation, as Dr. Hazra said, early initiation would give you a better remodeling. We don't see sicker patients. So this Paraglide HF is more real world. They started within 30 days or inside the hospital. So 70% patients had in hospital initiation, and possibly that is the way to go possibly. So what they're going to come up is now a
So that is again another important message from both of you, all of you rather, that start it early.
Early, that's important.
Start it early
with
before
dose is tolerable.
advanced remodeling has occurred.
Yes. So start with whatever. dose
I
is
think
tolerable.
time won't permit any discussion. We could have continued further, but
I'm just commenting on these things regarding he was suggesting they're telling the ejection fraction. Some persons who are more working on the mechanics of heart, they are telling ejection fraction to reflect the systolic function of the heart is not good predictor. Rather the JLS. JLS, if you find that JLS goes down to below some level, then I think the systolic function started deteriorating. Say after 2 years or 3 years in the line, we may have that GLS criteria might be for the recommendations of SGLT2 and ARNI. Might be. As is presumed, as has been rightly mentioned by all of the wishes, that basic things we have to start early so that we can take some preventive measure at the molecular level. That is the best thing. Rather than the preventive use of these drugs early. Thank you.
So it has been a nice session, and thanks for your presentation. Big hands to Dr. Aftab and the whole session, and my special thanks to my co-chair, Senior Dada.
I will request all the speakers to please once again come up on stage so that we can have a perfect moment captured for this particular session. I will request all the speakers to please come up on stage along with the chairperson and moderators to please be in the front of the stage so that we can have a picture perfect moment of the day. And with that, we will be having 2 back-to-back online sessions right now. The next session and the last session of the day is chronic thromboembolic pulmonary hypertension, and we will be having 2 topics covered under this particular session. But before we move on to the topics, may I request the following dignitaries on stage as chairperson: Dr. Rajiv Krishna, Dr. Bishwarup Sarkar, Dr. Ashok Parida, Dr. Shuni Banerjee to please come up on stage in the chairperson panel. May I request the following dignitaries to be in the moderator panel: Dr. Shunandan Shikdar, Dr. Navarun Roy, Dr. Arnab Roy, Dr. Shubha Dubey. And I will request the technical team to please connect us digitally on the screen. The first session that we will be covering is interventional management of CTE-PH by Dr. Bhagirath Raghuraman. He will be connecting with us online. So he's already with us, and we have Dr. P.K. Hazra sir in the panel. So we can move forward with the first topic, interventional management of CTE-PH.
Hello. Sir, yeah.
Can you see my
Bhagirath,
slides?
you are nicely visible and audible. Thank you for joining.
Just play my slides.
No, sir. We can't see your slides.
I'll just put it up in a second. Can you see or not yet?
No, sir.
I'll leave and rejoin maybe after that.
Sir, when you,
Can we, yeah, Julius, we can move on to the next speaker.
Yes, with your
This is
permission.
already, Julius, can you hear us?
Yeah, I can hear you.
Yeah. Can I go to your presentations and then we'll go to Dr. Bhagirath's presentations?
Sure. I'm just trying to share screen.
Yeah.
So as we have the presence of Dr. Julius Punen with us online right now, so we move on with his presentation now with this topic, surgical management of CTEPH, and here we start.
sir,
You see this?
sir, you have to duplicate your screen. Otherwise, it's coming very small.
Now?
Yeah, done. We can see it.
Okay, so can I start? Can I start, please?
So awaiting your
Yeah,
response.
we can hear you. We can see you very nicely.
Good evening, everyone, and thank you for the opportunity to share some of my thoughts about CTEF with you. It is customary to introduce the topic regardless of how many times it has been done before. Now, CTEF is a consequence of incomplete resolution of pulmonary emboli. So we have to be clear, it is not everyone who gets pulmonary embolism who gets CTEF. Only a small percentage of people, which varies from 3 to 5%, will end up having CTEF. And it is a problem about clearance of the clots from the acute PE. So in a patient with CTEF, this gets progressively organized into fibrotic material, which obstructs the major pulmonary arteries. So for, you know that CTEF is a form of precapillary pulmonary hypertension. And in the definition of precapillary pulmonary hypertension, you have these components of having to have a peer pressure, a mean peer pressure of more than 20 millimeters of mercury, wedge pressure of less than 15 millimeters of mercury, and a PVR of 2. So these thresholds have changed over a period of time. So it was a different number before the last symposium, and the PVR became 2 only in 2022. In the definition, we also need abnormal ventilation perfusion scan of that one mismatch segment and typical findings of CTEF on angiogram or CT scan. This has to be after 3 months of supervised anticoagulation so that we don't mix up with subacute pulmonary embolism. Okay, so in the diagnosis and approach for treatment, we usually have a multidisciplinary team approach, which involves all the specialties which are included in this program. So the most important question we need to answer there is there pulmonary hypertension, and is CTEF the cause of the pulmonary hypertension? Even though that's a simple enough sounding question, it is usually quite difficult to differentiate this entirely from primary pulmonary hypertension, sometimes with in situ thrombus. And if in those patients, if you take them for surgery, they just do not do well. The only contraindications which are absolute would be parenchymal lung disease. If you improve the perfusion in those areas, it's not going to improve the oxygenation. And of course, severe LV dysfunction, which also is a relative contraindication, because once you improve the pulmonary blood flow, the LV dysfunction can get worse. We look for systemic pulmonary collaterals in all these patients. Presence of them indicates that there is a low pressure area beyond the line level of obstruction. And one should consider all the various treatment options, medical management, BPA combinations, and we rarely require to do a transplant on these patients. So imaging becomes the mainstay of CTEPH diagnosis. The VQ scan is the best screening method for this disease, because if you take CT as the screening method, you might miss very distal disease, because CT is not very sensitive. The regular CT is not very sensitive for very distal disease. You can have other forms of CT like cone beam CT, which I'll show. So in cone beam CT, you can detect more distal disease. And if you have dual energy CT, you may be able to get some idea of the perfusion also. So MRI also gives you a good indication of the perfusion and as well as the obstructions. DSA is considered the gold standard in the diagnosis, particularly in patients who have distal disease. Somehow I'm not going in the right direction. Okay, so in a DSA you can see the lesions quite clearly, and distal disease can be diagnosed fairly well. We have basically 3 treatment options. One is the pulmonary endarterectomy, which is the gold standard. We have BPA. Some of these areas overlap because the proximal vessels are best addressed with surgery. More distal or subsegmental arteries can be addressed with BPA as well. And if it's a microvascular disease, which can be part of this spectrum, it is best addressed medically. And sometimes you need a combination of these. There are some favorable risk factors for surgery which have been laid down, so that for anyone who's starting a new program can have this determined well. If there is a clear concordance between all the imaging, and if it's lower lobe disease, and if you have a clear history of DVT and without heart failure, and the PVR is under 1,000, that forms a relatively lower risk group. The operation, we follow the UCSD technique with we go on bypass with usual cannulas and access the clots through generous incision in the pulmonary arteries, which remains intrapericardial. We do not go beyond the pericardial reflection. And since about 2018, we have avoided using cardioplegia in these patients. And first step is to remove all the interluminal clots. And as I'll show you in this video, you have to develop an endarterectomy plane. This is the most important part of the operation. You have to develop the correct plane. When you develop the plane, you're left with pearly white intima on the other side. And once you develop the plane, you can trace it down into the level of the obstruction and remove the fibrotic clots that are obstructing the segmental or subsegmental or whichever place where the obstruction is. So that needs to be removed very carefully by dissecting it out like that. There are a lot of potential complications. One is intraoperative bleeding, and you could also have reperfusion edema, RV failure, or the worst thing is persistent pulmonary hypertension. When the PA pressure remains high at the end of the operation, it becomes a problem. Sometimes you get a combination of these, and you must have a well experienced ECMO program if you take on pulmonary endarterectomy, because a lot of times you need ECMOs to deal with any of these complications. So airway bleeding we identify by blowing the lungs at the end of the endarterectomy. You can see bubbles coming out of the pulmonary artery. If bubbles are going to come out when you blow, blood is going to come out on the airways when you finish. So we identify the artery and pack it with Surgicel. And once that is done, we can check again, the bleeding would stop. So in summary, CTEPH is a sort of rare complication of acute PE. Sometimes they're not symptomatic. There is fibrotic intravascular material obstructing the clots, and there is usually a secondary microvasculopathy which involves less than 500 micrometer vessels. We do not exactly know the mechanism how these transforms into CTEPH. And apart from lifelong medication, including anticoagulation, the best treatment option is surgery. And for those who are not surgical candidates, other treatment options can also be used. Thank you very much.
Thank you. And Julius, you know that nowadays lot of newer devices which can take out these clots in acute phase, maybe subacute phase. But when it is chronic, then probably these devices won't be able to take out this fibrotic material. Do you think if you introduce this device after opening the pulmonary artery, using this instead of forceps or other material, it is actually much easier to use the suction device, stronger suction device directly on the clot? Or
I do not think so, because see, when we're dealing with acute clots, you're looking at fairly soft clots. Whereas in CTEF, what you're dealing with is fibrotic material. There is hardly any clot there. You might find intraluminal clot, but removing intraluminal clot is only part of the procedure. That does not treat the obstruction. The obstruction is at a distal level with the fibrotic material which are blocking the lobar or segmental or subsegmental vessels. So by using a suction device, you're not going to be able to get it. And this is fairly stuck to the wall. So actually, you are going to develop a plane between the fibrotic material and the intima or the media sometimes. So it is a endarterectomy and not an embolectomy. In an embolectomy, you're removing only the embolus. In an endarterectomy, you're going to be removing part of the intima along with the clot. So the plane is developed there and dissected along with that. Suction is not going to help. Sometimes.
So second is, where to stop? I mean, what are the surgical endpoints so that at this point, I'm going to stop visibility of thrombus, disappear from the surgical field, or you explore further downstream?
So first of all, you have to be very clear with the imaging information as to which are the segments or subsegmental vessels which are blocked.
Right.
You have to continue your endarterectomy until you get the tail ends out. So it may be, you may be able to hold what is the lower level of fibrotic material, but you have to dissect into the smaller vessels beyond your line of sight and remove the obstruction till you find the tail ends. Only once the tail ends are removed, the obstruction is removed. By removing the intraluminal or the larger vessel clots, you're not going to change the PVR.
Right. The third question and last one, is there any incidence of residual pulmonary hypertension, which is very likely to happen?
Yes.
Or how long it takes for the completeness of your disappearance of the pulmonary hypertension from the system?
So if your PVR is quite high at the end of the operation, say if it is something like 500, the mortality is quite high. If it is little lower, like under 300 or so, or somewhere in that range, a lot of them get a little better over 3-4 months with some remodeling of the pulmonary circulation. So residual pulmonary hypertension is there to some extent, even up to 25% of the people, and they will benefit from drug therapy.
Thank you. Thank you very much for your contributions, and thank you for joining. Now we'll switch over to Dr. Bhagirat Raguraman, and over to you, Bhagirat. Sir, it's still a blank.
Can you see now?
No, sir.
You can see now?
No, sir. Sir, can you first stop sharing?
Stop sharing. Okay.
Then when you share the screen, you'll get a whiteboard. Don't select that whiteboard, select the other option.
Oh, that's what I did. Okay. So.
Where you'll get, your PPT is on, right?
Yes.
Yeah. You'll see your PPT, just click on that and share. Yeah. Yeah, it's coming, sir. Thank you. You're on.
On? Okay. Technical glitches. Okay.
You're good to go. You're good to go.
Okay. Respected chairpersons, ladies and gentlemen, good evening. thank you to Dr. Pandey and the entire Eiicon team for having given me this opportunity to speak on interventional management of CTEF. Good evening, Hazra sir. As always, a pleasure to see you and to learn from you. So nothing to disclose. I think some of this is overlap with Dr. Julius's talk, and simply because our zones of there is a common zone wherein both of us would be offering therapy, and also because we work together. And much of my learning from CTEF is also from Julius. Multimodality treatment of CTEF. This is the 2022 guidelines, which say that the zones are level 1, 2, 3, and 4. The A type is the proximal PA fibrotic obstruction. BCD is distal PA fibrotic obstruction, and E is microvasculopathy. Dr. Julius has already said that. So level 1 and 2 is managed surgically. Level 3 and to some extent level 4 is managed by balloon pulmonary angioplasty, and of course medical therapy is across the board. Straight away I'll jump into the investigations of CTEF. A few of it already Dr. Julius has mentioned, and I'll take this in greater detail because this is important for me for the management of CTEF. So suspicion is echo and a VQ scan, confirmation by right heart cath and pulmonary angiogram, and CT pulmonary angiogram is the gold standard. And in selected cases, we do an MR angiogram. We assess the hemodynamics, comorbidities, and also the entire team, including the surgeon, is there in the decision-making process. This is the 2022 guideline recommendations for investigations. Echo is a class 1B indication, right heart cath 1B, VQ scan 1C, CT pulmonary angio 1C, routine biochemistry, blood tests, immunology, HIV testing, thyroid, and so on 1C. Referral to a PH or a CTEF center of excellence like ours is a 1C recommendation. Abdominal ultrasound is important to diagnose and to screen for portal hypertension. Pulmonary function test 1C. Chest CT for other causes of PH. And of course, DSA is yet another guideline recommendation. Now, this is a snapshot of the echo that we perform. RARV is dilated in the upper panel on the left, and you see a free-flowing TR. We use a grid method to analyze the right ventricular function, and also speckle tracking image, which you see in the lower left panel. We often use 3D assessment because 3D is very, very important for quantification of both the right ventricular volumes as well as the function. And this is very important because this helps in prognostication. Of course, yes, the panel on the right shows free-floating clots. This becomes tricky, especially in those patients where you want to perform a pulmonary angiogram or perform interventions, especially in the acute on chronic patients, because there's a chance of dislodgement, including a cardiac arrest on the table. So we have to be extremely careful. We get into the RA, use the curved catheter like a headhunter to avoid the RV effects and get directly into the RVOT. And this is done when absolutely necessary only. VQ scan, the panel above shows the ventilation and perfusion, and the panel below shows an overlap. This is to decide how many segments are involved and how soon you have to intervene and to the extent of intervention that has to be performed. The CT pulmonary angiogram, I told you this is the gold standard. We have both the planar as well as the 3D imaging. The 3D imaging is especially useful. This is what we call as the 3D spin imaging, which our radiologist, Dr. Vimal, provides. And this is especially because the access to the various pulmonary artery tree branches, according to the bronchopulmonary segments, is extremely well elucidated in this particular view. And with this, I'm able to plan the approach as well as the extent of intervention that has to be done. MR pulmonary angiogram, this is for selected cases. We can couple it up with doing an MR perfusion angiogram, again, only in selected cases because most of the data would have been obtained by a CT pulmonary angiogram itself. We also have a method by the MR angiogram to assess the turbulence in the right ventricle as well as the RVOT and the pulmonary artery. And this is to assess how the turbulence is, and this can be again reassessed after the procedure to see quantify the success of the procedure. Pulmonary cath and angiogram. The right ventricular pressure, the pulmonary vascular resistance, all these are parameters that helps us to prognosticate the patient, to inform the family as well as the patient regarding how far down the line the patient is. what are the likely outcomes, and which are to the high-risk patients wherein the mortality is more than 20% in 1 year. The ESC guidelines have clearly specified based on the right heart cath parameter, 6-minute walk test, CPET, and so on. Based on this, you can identify which patient you have to take earlier and what is the risk thereof. Pulmonary angiogram, selected cases, especially useful in those patients who are not being taken for surgery. And here I can assess how exactly to approach the patient. This is in addition to the CT pulmonary angiogram data. So the therapeutic options, as per the guidelines, of course, Julius has already said, it's a surgery is a class 1 level of evidence B recommendation. BPA is a 1B recommendation in patients who are technically inoperable, have residual pH. Hazara sir, you had asked that. So those who have residual pH, they come into the BPA category, and those who have distal obstructions, who are not amenable to surgery, these are the ones that we take up in BPA. Of course, medical management is across the board 2A level of evidence B recommendation. So the BPA, the main topic today, it's for patients who are inoperable because of advanced stage, comorbidities, surgically inaccessible or distal or peripheral lesions, residual lesions, and recurrent CTEPH after surgery when inoperable for the second time. Again, pulmonary angio, and we do a collateral angiogram. Collateral angio is extremely useful to identify collaterals. This is useful in massive hemoptysis because the patient is likely to crash, and you need to identify which is the possible potential area and how to approach this, and we either call it off or inject PVA particles. This, again, a bronchopulmonary segments knowledge is very, very useful to assess which are the segments involved, how to approach, and how to go about it. In addition to the pulmonary angiogram, sometimes we use an IVUS or an OCT or an angioscopy. The OCT gives us a 3D rendition so that we can see exactly how the webs are positioned and how to approach and tackle the lesions. The angioscopy gives us the surgeon's view. And here again, you can decide how to access and approach the lesions. The angiographic subtypes, there are totally 8 subtypes. Type A, localized ring. B is web. Type B, 1 is longitudinal defect. Type B, subtype 2 is complex mesh lesions. Apart from this, the more complex lesions are the abrupt narrowing, subtotal, pouch, and tortuous lesions. Especially in the pouch and tortuous lesions, the interventions are best avoided because there's a high chance of complication, including perforation and rupture, and then the patient has to be taken up by the surgeon for lobectomy. Hardware, I use a long femoral sheath, guiding sheath, B-palm atraumatic wire, crosspander balloon. The various balloon sizes are seen here, and of course, gelatin sponge particles. These are injected whenever there is a hemorrhage or a bleed, so that I can buy time, and sometimes I can get away without requiring the surgery. Right femoral access, 8 French multipurpose catheter or a left arm plots or a right Judkins catheter, 014 floppy guide wire, graded balloon dilatation, dynamic inflation is required. Start distally with just 2 atmospheres and progress up to 6 to 8 atmospheres in the more proximal portions. I may use IVUS and OCT depending on the case. What's important here is don't do more than 5 to 6 branches because of the threat of reperfusion edema, and also only 1 lung at a time. Never perform procedure in both the lungs. So these are a few example cases. This is a right upper lobe lesion that you can see here. I used a 3x20 balloon, and you can see that in the panel below, there's an excellent result. This is right middle lobe pulmonary artery totally occluded. I used a Fielder XT wire to cross this lesion, and then used a microcatheter to change for B-palm soft atraumatic wire and graded balloon dilatation. And you can see that the entire right middle lobe artery opens up. Next case is, this is yet another right middle lobe artery occlusion. This patient came in all the way from Kenya for this procedure. He was dependent on oxygen. We did a couple of branches, and along with that, this particular branch probably made the difference because he's now off oxygen and has a good 6-minute walk test and a CPET performance. This is the 4th case, left lower lobe pulmonary artery, totally occluded. You can see that I used a balloon support, that what we commonly use in the coronary lesions, and then open it up with a 420 balloon, and you can see that the entire left lower lobe pulmonary artery opens up. Excellent perfusion, and this patient is again having a very good functional tolerance. And this is the last case that I'm showing you. This is again right middle lobe, lower middle lobe pulmonary artery occlusion and balloon dilatation, and you can see that the web has been cracked and there's a good perfusion in the right lung. Collateral embolization, I already told you this patient presented with massive hemoptysis, a 6 grams drop in hemoglobin, and then we injected PVA particles. We couldn't get the coil through, so we used PVA particles and completely shut down the collateral, and this patient is doing fine on follow-up. Subsequently underwent a surgery. Combined procedure, as Julius has already told, some patients require not only surgery but followed up with a balloon pulmonary angioplasty also, because some lesions are inaccessible or there is residual pH. So we do a combo procedure which gives us good results, and you have literature published in this regard. Lastly, complications of balloon pulmonary angioplasty: vascular injury, vascular dissection, allergic reaction, adverse reaction to conscious sedation, and so on. More importantly, lung injury, massive hemoptysis, hypoxia, requiring ventilation, renal dysfunction, and access site problems. We use what is called as a Pepsi score, and this Pepsi score helps us to avoid, it tells us exactly when to stop and when to not progress with the patient. A rule of thumb would be, at the moment the patient develops cough, this is reperfusion edema. If the patient develops hemoptysis, you need to stop now. Always have surgical backup and ECMO ready. I thank Julius for being there for each and every one of my cases. This is the data of the 30 patients we have done so far. Most of them have had excellent results. Future directions: rotation angiography, Singo iPilot software, and there is a new pressure wire or a Certus wire which can be used to maneuver into various branches and also measure the pressure difference across the lesion. Lastly, there are some other interventions in CTEPH. Of course, intrathecal septostomy. There are clear-cut guidelines and criteria in whom it has to be done. This is again phase 3, phase 4 trials, not yet commercially available. So what we generally do is, to bail out patients, we do a balloon atrial septostomy, as devices are not yet licensed for use. Pulmonary artery denervation. This is showing good results. It's coming up again. There's a resurgence in a big way. This is the first case that we did. This is, we are doing the ablation in the proximal right pulmonary artery, and then we did a ring lesion in the pulmonary artery, and this patient had a good improvement in functional class and overall improvement in the pulmonary artery pressures. Last is the percutaneous spot shunt. This, as we often say, is the one that differentiates the boys from the men. A technically very, very challenging procedure. We go in from the aorta, get into the pulmonary artery, and put in a covered stent. This is the first case that we did here. And you can see that there is, we use the wire to perforate through and then snared it out and then brought back the sheath inside. And then you can see that this is the covered stent dilatation. And the last panel on the right shows that there is a free flowing channel available. So this helped to save the life of that particular patient. I'd like to place on record my sincere thanks to my chairman, Dr. Devi Shetty, and Professor Yamashita from the Tokyo Medical College, who initiated me into this procedure. Thank you, everybody.
Just a superb presentations. I mean, big clap. I mean, really touched my mind and soul. Now, only one thing, Bhagirath.
Yes, sir.
I always put my newer thoughts in any discussions.
Yes,
so only
sir.
one thing which comes in my mind, which you have perhaps not discussed, ECMO, FFR, this OCT, IVAS. Is there any role for drug-eluting balloon once you dilate with?
Yes, sir.
2.5?
The literature is very clear that stenting is not required, because the way in which, I mean, due to paucity of time, I didn't get into this. The way in which the balloon angioplasty works is that you actually crack and tear the web. And after that, the pulmonary artery remodels and you get the same diameter both proximally and distally. So there is no real requirement for a drug-eluting balloon. And also, many times there is a huge mismatch in the distal pulmonary artery tree. So when you put in a stent, you wouldn't have fully expanded it. And when the vessel subsequently remodels, the stent will be actually, distal part will be free floating in the pulmonary arteries. That's why it is not really recommended. Of course, I think over time you may get self-expanding stents which may be more useful. At present, it is not recommended to use both drug-eluting stent and drug-eluting balloon. There is no documented advantage at this point in time.
Right. And second is your pulmonary artery denervations.
Yes,
if
sir.
you have too many clots, I don't think pulmonary artery denervation will solve the problem. It is basically for PPH.
Sir, in the first case that we did, we had about 16 millimeters fall in the mean pulmonary artery pressure. And obviously, it's not something that is going to make a huge difference. One thing is that I think we still are in the learning curve process. So we did an ablation in the right pulmonary artery origin and left pulmonary artery origin. Probably technically there may be better ways to achieve more complete and comprehensive denervation. And also this is one of the procedures that can contribute. There is no way in which you can denervate and completely get the pulmonary artery pressures to normal. That does not happen, not even in BPA and not even in PA denervation. So these are, as we call it, procedures which offer hope for the hopeless. So there we can make a difference to some extent in terms of NYHA functional class, quality of life, and so on. It's not going to completely make them class 2 or class 1.
So you have many Penumbra, Ikari, other lysis system.
Yes.
And what about the laser? Laser is very good for coronary thrombus.
Yes.
Is it as good as coronary thrombus in pulmonary artery?
There is no literature available for the use of laser. I see that now there is data emerging for using laser in coronary artery disease. So whether this can be extrapolated to be used in pulmonary arteries, I don't know. And most importantly, this is the type of lesion in the pulmonary artery is different compared to what is there in the coronary arteries, because this is all fibrotic bands, and then you have a combination of thrombus and adherent material. So whether laser will really help, I really don't know. I think time and more literature will help us to answer this in due course.
Any comment? No. So there is wonderful presentation from both of you, and coming from a hospital of international repute, and they have already established their name, fame, and signature on pulmonary hypertension, both Julius and Bhagirath. Many patients from this part of the country has gone there, got treated surgically, as well as for many other procedures. We are really proud of you. Thank you very much, sir.
Thank you, Hazra sir. Thank you very much. Very grateful.
So it's time for some awards, and thank you, Bhagirath and Dr. Julius.
Thank you, sir. Thank you.
Thank you. Thank you. Bye-bye.
Thank you so much for the contribution to Eiicon 2023. And now I will request sir to please come forward, as we are about to start off with a very crucial and awaited segments. One being the winner, the handing of the check of the winner of Cath Lab Nurses Quiz, and second is the quiz, the lucky draw. The lucky draw. Yes.
Are you ready with the check for the nurses, Kavita? Just give your name, correct name, spelling to them. Are there anybody outside who is waiting for the lucky draw, or we are left with this number of people?
Back in team, please check.
Please check out.
Because please ask them to join here, because one and only rule is you have to be present here to get the prize.
Yes.
I think my voice is enough that it went there.
So, I don't know whether Dr. Basavendra is here. Dr. Basavendra or Rinabrata? No, I don't think they are here. So it gives me immense pleasure to announce the best CD presenter of yesterday and today. They are almost a neck-to-neck tie between Basabrata Chaudhary and Rinabrata Sen. And Basabrata got 96 and Rinabrata Sen got out of 100. He got around 92. So the winner is Basabrata Chaudhary. If he's here, if he is not here, doesn't matter. Please communicate that he gets a ticket to USA, San Francisco, a TCT back and forth. The CSI is going to sponsor. So this is going to continue next year. So we spread this message, all across the country. The CSI is going to have this kind of reward system for the CD presenter for the youngsters. Not only restricted to youngsters, it may be, and today in the technician, yesterday technician quiz was conducted. Siladitya Hajra got the first prize of 15,000 rupees. and nurses session, Joyশ্রী from AMRI, Shiladit is from Ajikar, Joyশ্রী from AMRI Dhakuria, she is our nursing, cath lab sister in church, very sincere and very talented, helpful. You call her anytime, she's there. Early morning, late night, she will respond to your call. Only drawback is that she is unmarried. So if somebody is around, she gets the best prize. She wins 15,000 from CSI. And now it is time to have the lucky draw number. The gold finger of our ex-friend from Metronic, Ongshuman, and Hajra, another Hajra. So Ongshuman Hajra has touched a number with his golden finger. The number is 386. The 386, if you're here, you'll get the prize. If you're not here, you'll not get the prize.
So the number is 386.
386. Very few taker here, I think.
3 আর 6 we move forward আর কিন্তু পাবেন না no?
Okay. If there is no claimant, it's about 6 o'clock anyway. So next prize, the first prize still unclaimed because nobody is here. 349, 349. 349, 349. So কোথায় গেল? ও কাশিদা একটা তোলো। ও তুমি কন্টেস্টেন্ট হচ্ছে কি হয়েছে তাই?
সব দেখে দেখে নিজে
কে দিই, ও ইজ নট এ কনস্ট্যান্ট। ব্লু কনফ্লিক্ট অফ ইন্টারেস্ট। So another Ongshuman has picked up 065. No cheers. Finally got it. Finally. Come here. Ongshuman, you please hand over the first prize, what? 20,000 rupees to Taposhi.
Okay, such a wonderful moment here we have, and একটু হাসো দেখি।
Yes.
একটু হাসো না, একটু হাসো, একটু বড় স্মাইল দাও। Okay, so the first winner of the evening in lucky draw, we have this very beautiful girl here. Okay, so time to move on with the next winner.
Julie, come here. Gold finger. Blue.
So I need to pick up a green, right?
Hey, green, blue, whatever I am colorblind. Hey, show me your number. I have to check your number. Just is the judge, 065. Right. Wow. So second prize is 266. So there are only 1, 2, 3, 4. Wow.
আচ্ছা যে জিতেছে
Fantastic.
সে এত খুশি, বাকি খুশি কেন? আমাদের অসুবিধা নাই, ও জিতছে, রুটে আসছে, নাচছে, ঠিক আছে, বাকিরা এত খুশি কেন? ভাগাভাগি করা হচ্ছে।
তুলি, এটা কাশিদা, তুমি তুলে দাও প্রাইসটা। So she is from the headquarter, CSI West Bengal branch. But I have to check your number.
After awarding.
ম্যাম,
Right.
যেটা পেয়েছেন, আপনার কাজ হচ্ছে আপনি জিনিসটা পেয়েছেন, বাকি রান্না খাওয়ার জন্য ডিনারে আমরা বাড়িতে সবাই চলে আসবো,
Right.
বাকি কাজ আপনি করবেন।
So it's my duty to give a vote of thanks to each and every participant who have helped us in garnering support for a beautiful conference. I would like to thank each and every participant, the industry, Tuli, Sanghamitra, Sunil, and her team, his team. The transmission was perfect, 10 out of 10. We have a lukewarm response, the audiovisual staff, the ITC staff, and especially the industry people. To name few, like we have awarded Sajanand Medical Technology the best stall for the first time in any conference. The second best stall was Altius. So give a big hand to these two winners. So we'll be handing over the memento and some prize for these two stalls. And we have a lot of encouragement from Microlab, Novartis, Sun, IPCA, MacLeod, and many other names which are coming in my mind. But, there's Lupin, the Torrent, so many pharmaceutical companies, when I approached them, they generously contributed and our fund swelled up. This is a historical moment. For the first time in eastern part of country, we have almost 18 live transmissions, and the fund we have generated is almost 1 crore 30 lakhs rupees. And I'm hoping that more and more will come. This is the fund not for fun, not for fun. This is a fund for academics, for upgradation of our knowledge, and also awarding people who will be delivering their best cases. So spread this message to your youngsters. Virtually, we're connected almost 2,000 people all over the country, and maybe there are some deficits or deficiencies, inadequacies from my side, and you have to pardon me for that. But I try my best to give you the best, and we are all friends together, and together we can make the Bengal a proud and a prosperous state, and I'll bring our glory back if you work together. So let's join our hand together and give a big clap to Bengal and CSI Eiicon. Thank you very much. See you next time, and thank you once again.
Okay, so before, thank you so much, sir. Before we conclude, can we have a moment for sir for beautifully organizing this 2 day of kind of a celebration and a get together and a beautiful conference. Sir, একটুখানি আসুন না মাঝখানে, একটুখানি জোরে হাততালি হবে, তো বসে বসে হবে, আমরা তো এবার বেরিয়ে যাবো, একটু জোরে হাততালি হোক সকলে মিলে। So a moment for sir, and thank you so much. Yes, we bow down to him because all over India participated in this Eiicon 2023. So ladies and gentlemen, this is a wrap for this year, but bhalo থাকবেন, সুস্থ থাকবেন. This is your Suprabhati signing off for the day, but sessions are going on in this hall, so you can go and participate in and be a part of the sessions that is in the second hall, that is the Victoria Hall. And I will request all the officials to please come up so that we can have a solid proof of what this year's Eiicon looked like. So we request all the officials to please be on stage so that we have a wonderful moment here. Some of you can be like in the carpet, and few of you can be on the stage so that we can get this stairs frame.
আসছি আমরা আসছি না
লাকি ড্রয়ের উইনার খালি হাতে এসছে। কোনো প্রুফ নেই তো? Okay, so we will have a picture with the check. So I will request you to bring your gift. Go. খুব সিরিয়াসলি নিয়েছে ব্যাপারটা যে নিয়ে আসতে হবে। Thank you so very much, everyone, for joining and being a part of this wonderful today's conference, Eiicon 2023. This is officially a wrap.
Krishna ki says.
কেউ আছে ওই পারে কেউ আছে হ্যালো
Yes,